everyone, our respective faculty, academicians, dear fellow surgeons, physicians, residents, dear students, and thyroid and parathyroid disease survivors. I am Dr. Sunil Mattu, an endocrine surgeon, and I welcome you all to the first Jammu Thyroid and Parathyroid Surgery conference or masterclass, what you can say. It is a unique academic exercise, the parts of which will be of interest to each one of us. So without wasting any time, I would like to request one of our patrons, Professor Shadilal Kachru, who's a senior professor retired from GMC Jammu, to make some initial welcome comments. Over to you, sir.
Thank you, Dr. Sunil Mattu. Good evening, and good evening to Dr. Suman Kotwal, Professor Amit Agarwal, Professor Changu, Professor Sheetal Singh, Professor Rajgopal Shenai, and everybody. Before I proceed, I would like to introduce myself. I'm Dr. S.L. Kachru, ex-professor and HOU from Department of Surgery, Government Medical College, Jammu. I consider myself privileged to be a part of today's program, that is Masterclass on Thyroid and Parathyroid disorders. It's an initiative, I think, first of its kind in J&K, and it has been, the credit goes to Dr. Sunil Mattu and Dr. Suman Kotwal, who need to be congratulated for putting in their efforts to organize this webinar. Both of them are highly trained professionals in their respective fields. Dr. Sunil Mattu has been a postgraduate in Surgery Department of Government Medical College, Jammu, and has earned his postdoctoral degree, MCH, from one of the most prestigious institutes of the country, that is SGPG. And after that,
sir, you'll have to unmute your mic, sir.
yes, am I audible now?
Yes, sir, you're audible, sir.
Okay. Dr. Suman Kotwal is a well-known endocrinologist of the J&K state and has been shouldering the responsibility of his super specialty in Super Specialty Hospital, Jammu, single-handedly, besides his clinical practice after his working hours. Both these doctors have put in a lot of efforts, cover most of the relevant topics of today's seminar, and have been successful to rope in various.
Sir, you'll have to unmute your mic again, sir.
Both of these doctors have been able to rope in most of the eminent speakers from different specialties, not only from India, but from other parts of the world also, like UK, Greece, and other places. All these speakers will be introduced individually when at their turn to the audience before they start their lectures. I can say the same thing about various experts in the panel discussion, which belong to various parts of the country, from Lucknow, from Vijayawada, Hyderabad, and belonging to different specialties. The various sessions are being chaired by eminent and experienced experts like Professor R.K. Changu from Jammu, Professor Gurjeet Singh, Professor Pramod Kalsotra, Professor Rajesh Goyal from ENT department, Dr. Paras Khanna and Dr. Sujit Bhatt, oncosurgeons from Jammu, Professor Subhash Bhardwaj from pathology department, Professor Rajendra Singh from ortho department, and Professor Zahur, Dr. Sanjay Dar, Dr. Vikrant, Dr. Kailash, to name a few. I would like to add that the domain of thyroid and parathyroid disease is not confined to endocrinologists and endocrine surgeons only, but it impinges on the domains of general surgeons, internists, psychiatrists, urologists, and nephrologists as well. So this topic of today will be of great interest to all the people of different interests and different specialties. And I hope that this seminar will be quite helpful in adding to the knowledge of all the members, all the delegates, and will ultimately help in delivering a better patient care. Thank you. Thank you, Dr. Sunil Mukherjee.
Sir, I thank you for the welcome note. Now I would request Professor Amit Agarwal, who is the head of Department of Endocrine Surgery, Sanjay Gandhi Postgraduate Institute of Medical Sciences, and past president of ISOPS, IAES, and Indian Society of Thyroid Diseases, and is the chief editor of World Journal of Endocrine Surgery, to say something regarding this conference and give some opening comments. Over to you, sir. Amit, sir.
Thank you, Sunil. Good evening, one and all. And at the outset, I'd like to congratulate Dr. Sunil for having started this first Jammu Thyroid and Parathyroid Surgery Masterclass. I'm very happy at the kind of topics and the wide range of speakers from all over the country that he selected and managed for this masterclass. And I'm sure it'll be a great success. Dr. Sunil has been our alumni very recently. And I must say the success of any institution is sort of measured by the kind of role that the alumni play in improving the national life. And I'm very happy to share with you that all of our alumni who are actually in all four corners of the country have been doing great work in the field of endocrine surgery, along with the eminent endocrinologist and ancillary specialties. And I'm sure Dr. Sunil will definitely be an example in the area of Jammu to take care of the endocrine diseases. So I must congratulate you and wish you all the success for this wonderful masterclass on thyroid and parathyroid surgery. Thank you, Sunil.
So thank you for your comments. So today we have two chief guests for our meet. One is Professor Rajgopal Shenoy from KMC Manipal. He has not been able to join us personally as of now, but he will join later this evening. So I would request Professor Amit Agarwal to introduce our guest of honor. And then we have a video message from Professor Rajgopal Shenoy, which we'll play. Thank you.
So it's my pleasant duty to introduce to all of you Professor Rajgopal Shenoy, who is the guest of honor for today's masterclass. He is a professor of surgery at KMC Manipal. He is the former head department of surgery, also an ex-associate dean of academics at Manipal, and he's also been is also currently the member of the National Governing Council of ASI for the years 2022-2024. He has a vast 35 years of teaching experience, both at the undergraduate and postgraduate levels, and of course has mentored thousands of surgical students, both nationally and internationally. He has been getting the Best Teacher Award consecutively for 5 years. As is expected, he has been author and editor of various books, especially that Manipal textbook of surgery, which is very popular among postgraduate students. He has more than 50 publications in peer-reviewed journals. So he's been a distinguished academician and visionary, and he has delivered numerous talks, both on the national and international forum. And I'm very happy to have the message of Dr. Rajgopal Shenoy.
So thanks for introducing our first guest of honor. Our second guest of honor for today was supposed to be Professor Sheetal Singh from Jammu, who was a great academician having more than 40 years of teaching experience, and of course a great clinician as well. But unfortunately, he had to leave for USA and is not present in the meeting. So I think we should then now proceed with our academic schedule. So our first talk of the day is on thyroid nodules and TIRADS. It will be delivered by Dr. Sarthak Sharma, who is a radiologist, and our chairpersons for this meet are Professor Shadilal Kachru, who is Senior Professor of Surgery and ex-head of the unit GMC Jammu, Dr. Abhishek Krishna, who is Assistant Professor Endocrine Surgery in SGPJA Lucknow, Dr. Vikrant Chandel, Associate Professor of Surgery at GMC Jammu, and Dr. Kamal Kishore, who is Associate Professor of Head and Neck Surgery, GMC Jammu. I would like to request Professor Shadilal Kachru to introduce our speaker.
Sir, sorry to interrupt you, sir. Should we play the video for Dr. Rajgopal?
We can play the video.
Yeah,
first.
so we can just do it
Sorry.
immediately, sir.
Very good morning to all of you. I am Dr. Rajagopal Shanay, Professor of Surgery, former Associate Dean and former Head of the Department of Surgery, Kasturba Medical College, Manipal. I am extremely happy to be associated with this first Jammu Thyroid and Parathyroid class. Actually, is a master class. I feel it's an honor to be associated with this as a guest of honor, and I am privileged also. I was going through the various lectures. I consider it as an academic feast. To postgraduates, to undergraduates, and also to eminent general surgeons. Why I said general surgeon? Because you know that thyroid parathyroid surgery, it's one of the basic component of a general surgery training program and a postgraduates. Every general surgeon should be quite aware of this. However, so many recent advances have taken place, including the field of minimal access surgery. It's not just about making an incision in the neck and the removal of the thyroid and parathyroid gland. It's about all about understanding of the process of the pathophysiology, a surgery with the minimal complications, including the nerve injuries and parathyroid hypocalcemia, etc. So I feel various speakers will go into the depth of these things and make this a wonderful Jammu first thyroid and parathyroid master class. So all over India as well as international faculties are involved in this. General surgeons, specialist surgeons, postgraduates and undergraduates will get immense benefit out of this, and I extend my thanks to Dr. Sunil and Suman for inviting me to be a guest of honor for this wonderful program. Thank you again.
Now I request Dr. Shadilal Kachru to kindly introduce our first speaker.
Sir, you'll have to unmute your mic, sir.
Dr. Sarthak Sharma is a consultant radiologist at Jammu. He, as a radiologist, sees many patients with thyroid problem pathologies. And the primary role of a radiologist these days is because of the ultrasound and imaging. And I think Dr. Sarthak will elaborate on those things and TIRADS. I request Dr. Sarthak Sharma to start with his lecture.
Thank you so much, sir. And thank you, everybody, for being here this afternoon. And I'll switch over to screen sharing now. So today's discussion is on thyroid nodules and TIRADS. And this is a brief outline of what we'll be discussing over the next few minutes. Let's start with some facts about thyroid nodules. They are quite widely prevalent with an estimated prevalence of up to 67% in some studies on sonography. The overwhelming majority of them are benign and only up to 7 to 15% are actually malignant. Ultrasound has become the commonest imaging modality in the diagnosis. And what we're seeing is that there is an increasing number of incidentally detected nodules thanks to the higher number of imaging that is going on these days, and especially with the metabolic imaging, especially PET-CT. And the last 2 points I would like to emphasize here that the thyroid cancer diagnosis rate has increased markedly over the last few years, and it is being overdiagnosed now more than ever before, and accompanied by an ever increasing incidence of microcarcinomas less than 1 centimeter in size. So the fact of the matter is we are facing an epidemic of thyroid nodules, and if I had one picture to summarize this would be it. So Overdiagnosing thyroid cancers means you're picking up small tumors that, if left alone, would not have resulted in significant symptoms or death. And these have accounted for as many as 70 to 80% of the cancer cases in some series. This is a landmark study which was published in the New England Journal of Medicine in the year 2014. This outlined the increasing incidence of thyroid cancer after the application of an ultrasound-based screening study in South Korea starting from the late 1990s. What happened was there was a sky-high incidence of thyroid cancers, but as you can see along the x-axis, the thyroid cancer mortality rate has not increased or increased only minimally. What are the ramifications of overdiagnosing thyroid cancers? When we are diagnosing more patients with indolent thyroid cancers as compared to the number of people who actually die from it, we create a burden on our healthcare systems. We have a pressure to treat small indolent tumors. Then there is the issue of patient anxiety and obviously the consequences of thyroid cancer surgery. Patients have to have lifelong thyroid replacement surgery, and obviously we cannot ignore the post-surgical complications. Now, what are some of the challenges that a radiologist faces every day in imaging these thyroid nodules? Whenever we see a thyroid nodule, the questions that spring up are, what is it? How should a radiologist report it? Should the nodule be sampled or left alone for follow-up? And what is the actual risk of malignancy in that nodule? And finally, and most importantly, how do you communicate these things to the patient? The underlying causes are manifold, but the important ones are there is a lack of standardized reporting nomenclature in ultrasound. And as it is, there are a lot of overlapping imaging features in thyroid nodules themselves. There is significant inter-observed variation, and there is a lack of risk stratification systems and a lack of management guidelines. So TIRADS was devised to address these very issues. TIRADS stands for Thyroid Imaging Reporting and Data System. It is actually an ultrasound-based risk stratification system for thyroid nodules. The aims of developing TIRADS were to homogenize the ultrasound reporting lexicon for thyroid and to make more effective communication between sonologists and clinicians, and to provide some kind of a quantitative risk assessment of malignancy with reasonably high sensitivity and negative predictive values, and also to reduce the number of unnecessary cytological samplings in these nodules. These systems use a combination of sonomorphological features which are assigned either points or assigned patterns. And based on these categories, further recommendations on sampling or follow-up of these nodules are done. So there are a lot of TIRAD systems in vogue nowadays, but the most widely used ones are those given by the American College of Radiology in 2017 and the Korean Society for Thyroid Radiology in 2016. And these are some of the important morphological features that are assessed across all these systems: the composition, the ecogenicity, the margins, the shape, and the presence of ecogenic foci within these nodules. What are the morphological features that are suspicious for malignancy? And these three are are common in almost all these systems. These are a microlobulated or a spiculated margin, microcalcification, and an anti-parallel orientation. These are discriminatory features which can potentially step up the TIRADS category. Few examples of ultrasound appearances. This is a typical spiculated or microlobulated margin. And this is a markedly hypoechoic nodule, as we can see. This is a typical taller than wide. We can see that the height of the nodule appears to be more than the width. And these are few very fine bright spots within the interior of the nodules representing microcalcifications, or what we call on ultrasound as punctate ecogenic foci. Coming to ACR TIRADS, it was preceded by a detailed thyroid reporting lexicon by the American College of Radiology in the year 2015. And then the ACR came up with this white paper in the year 2017. Very briefly, since we're short on time, these are the 5 parameters that are evaluated: the composition, the ecogenicity, the shape, the margin, and any ecogenic foci. Each of these parameters is assigned certain points, and the points from each parameter are summed to determine the final TIRADS category. And we have categories ranging from benign TIRADS 1 to progressively increasing degrees of suspicion, not suspicious, mildly suspicious TIRADS 3, and moderately and highly suspicious TIRADS 4 and 5 categories. In TIRADS 3 and TIRADS 4 and 5 categories, we have recommendations for cytological sampling based on the nodule size. And for those nodules that fall below these thresholds, the ACR recommends a follow-up period which can go up to as much as 5 years. Notably, no follow-up interval is less than 1 year. Briefly discussing the Korean TIRADS system. This was devised by the Korean Society of Thyroid Radiology in 2016. It's a pattern-based system. No points are assigned. However, we evaluate the nodule composition, echogenicity, and presence of these 3 suspicious features that we have discussed in the previous slides. And again, we have 5 categories, and benign, low suspicion, intermediate, and high suspicion, with the accompanying risks rates of malignancies in these nodules. Now, coming to the clinical impact of TIRADS, it really does have an impact if applied properly. Well, when you have a well-defined radiology reporting terminology, you can better describe the features that will predict malignancy within the nodule. You're able to make better management guidelines and better management recommendations for the patient. And also you can reduce the number of unnecessary thyroid nodule FNACs. And these are some of the papers that have validated these findings. So this was a meta-analysis of more than 18,000 patients and more than 21,000 thyroid nodules, which has come out earlier this year. The pooled sensitivity of ACR TIRADS was 0.89 and the pooled specificity was 0.7. The conclusion was that ACR TIRADS has a favorable sensitivity and a moderate specificity in the risk stratification, and it could all, and implementing this system could avoid a large number of unnecessary thyroid biopsies with the cost of a slight decline in sensitivity. And this paper has also made some comparisons between the existing common risk stratification system. We can see that the Korean TIRADS has a higher sensitivity, but a much lower specificity as compared to the ACR system. And the American Thyroid Association guidelines are also having a higher sensitivity, but again, a lower specificity than the ACR. The percentage of malignant nodules biopsied is much lesser in the ACR TIRADS. And that is because a lot of these nodules which are falling below the size threshold for sampling get follow-ups. So that is the reason why some of the malignant nodules will not be biopsied, at least initially. Even the percentage of benign nodules biopsied is the least in the ACR system and most in the Korean system. If we compare the sampling threshold sizes of these systems, we can see that the ACR has the highest threshold for sampling of these nodules compared to the Korean and the ATA systems. Now, does nodule size matter when we evaluate diagnostic performance of TIRADS? It does, and it should actually, because tumor size is a very important prognostic factor in papillary and follicular thyroid malignancies. And when the tumor size crosses 2 centimeters, the risk of distant metastasis is quite high. How do we determine which nodule to leave alone and which nodule to biopsy? Well, this is a sort of a strategy that can be worked upon. For nodules that are between 1 to 2 centimeters are not having aggressive features, we can reduce the number of unnecessary sampling. Obviously, the trade-off would be we would be reducing the sensitivity of malignancy detection. But for nodules having a size higher than 2 centimeters, we would need to have an increased sensitivity. Obviously, the trade-off would be an increase in the unnecessary sampling rates. Based on this philosophy, a modified Korean TIRADS system has come up this year only. The chief changes, I'll not go into the details, are that the category 4 of intermediate suspicion has been subclassified into 4A and 4B, with another change being that the size thresholds for FNA have been reduced across these categories 3 and 4, as we can see. What are the results? Well, on the left side, The modified Korean TIRADS now has a greater specificity compared to its predecessor, with a minimal decline in sensitivity only. And again, when we consider the reduction in rates of unnecessary biopsies, the modified Korean TIRADS does quite well as compared to its predecessor. Now, TIRADS is not without its pitfalls, and there are quite a few number of challenges in its implementation, starting with the varying degrees of scanning techniques from various radiological practices. And there is a marked difference in reporting some of the suspicious imaging findings, chiefly the hypoechogenicity and punctate echogenic foci, which have a great deal of inter-observer variability and can cause the TIRADS category to be spuriously high or spuriously low. The criteria for extrathyroidal invasion are still not well defined on sonography and need more long-term surveillance studies. There is still insufficient sensitivity for the diagnosis of follicular malignancies and follicular variant of papillary thyroid carcinoma. This does not extend only to TIRADS, but this is an inherent problem with ultrasound system of ultrasound itself. And a lot of thyroid nodules are still being classified as TIRADS 4, despite every measure being taken to reduce the unnecessary number of FNAs. We still have hit a ceiling when it comes to reducing this number. And when it comes to ACR category 3 low sensitivity nodules, there is still an absence of long-term active surveillance studies in the low risk tumors. And it is still not clear whether leaving these tumors alone is safe or just following them up is enough. To make TIRADS more successful in day-to-day practice, most importantly, we should have accurate assignment of the various morphological features. A lot of continuing education is required, and a greater degree of knowledge of management recommendations and awareness of these risk stratification systems amongst all the specialties is needed. With time, the modification of FNA size thresholds is imperative, obviously based on the evolving evidence. Some of the future developments or what is in the pipeline, it is being contemplated to have a larger size threshold for recommending FNA of the TIRADS 3 to 5 nodules. Incorporation of risk, incorporation of nodule location into the evaluation is being considered. Isthmus nodules are considered to have an increased risk of malignancy. Changes in some point assignments for suspicious features, especially punctate echogenic foci, is being considered. The role of elastography and contrast enhanced ultrasound is still being evaluated in larger numbers. And there may be some role for artificial intelligence and machine learning, primarily as an adjunct to the existing systems. And recently, the Multidisciplinary International Thyroid Ultrasound Working Group has formed to provide a single international guideline. And that concludes my presentation. Thank you very much for your patience.
Thank you, Dr. Sarthak. Thank you very much for your elaborate presentation. It has been a very illuminating lecture from your side. The conclusion drawn from your speech is that ultrasound has a great role to play in the management of these nodules, thyroid nodules, particularly when it comes to FNA, which wants to be FNA or which wants to be biopsy, where we have to go for surgical intervention and which are to be followed up. One relevant, I want to have one query that microcalcification and calcifications have a great role to play in the, as far as ultrasonographic findings are concerned. Sometimes we can have colloid calcification also, calcification of the colloid. So can we differentiate between the two phonologically and?
Yes, sir. Actually, we can, and it can actually become a little difficult at times. Colloid calcifications will typically have the reverberation artifacts extending for more than 1 millimeter in depth from the calcification itself. However, sir, the caveat is, and I think this, I'm quoting this from the Korean Society paper, that any echogenic focus in the solid part of the nodule cannot be ignored as a colloid calcification. Whenever we see a calcification with typical features in the cystic part, it has a higher likelihood of being benign. And any calcification in the solid part cannot be left alone, sir. In cystic areas with the typical reverberation and comet tail artifacts, we can be reasonably confident that we're dealing with colloid calcifications.
Okay, can I have any comment from my co-panelists like Dr. Abhishek Krishna?
Can I come in?
Yeah, please. Dr. Chungu, please.
Sarthak's presentation I find very encouraging to surgeons in a way that that despite increasing trends in the quantum of cancers of thyroid, the mortality rates are not concomitant, which means that we have a lot more to do for the cancer patients, cancer thyroid patients. And two, like he pointed out, the taller lesions on the ultrasound are like more malignant. So it's contrary to what we have in other things, other malignant lesions, like wider things are more malignant, wider than tall are more malignant than the taller than wide. And in any case, the TIRADS and the ultrasonography is improved the prognosis of cancers, and it is also given us to understand that there will be lesser need for lesser biopsies or FNACs if they do a very good ultrasound and delineate the suspicion of a tumor. Thank you.
Thank you, Dr. Sarthak. Thank you, Professor Shatilal Karchu and Professor R.K. Chungu for their comments. So now I would request for the second session, Dr. Kailash Singh, who is Associate Professor of Surgery and Surgical Oncologist, GMC Jammu, and Dr. Suman Kotwal, who is Assistant Professor Endocrinology in GMC Jammu, and Dr. Sujit Bhatt, who is Consultant Surgery Oncology Jammu, to kindly take over and introduce Dr. Shamim as the next speaker. Thank you. I think Dr. Sujit Bhatt is there. Dr. Sujit Bhatt, you can introduce Dr. Shamim.
Yeah. Good afternoon, everybody, and congratulations, Dr. Sunil, for organizing such a wonderful CME. And I welcome Dr. Shamim, who is an additional professor in Department of Nuclear Medicine, AIIMS, New Delhi, and he will be speaking on the nuclear medicine in thyroid and parathyroid disorders. Welcome, Dr. Shamim.
Thank you, Dr. Sujit. First of all, I would like to thank Dr. Sunil Mattu and Dr. Suman Kotwal for organizing such a beautiful and relevant, I think, CME or masterclass. So I'm privileged to be part of this. So today I'm going to talk about the role of nuclear medicine in thyroid and parathyroid. So, yes, briefly, some basic concept about the nuclear medicine. Nuclear medicine is actually done with the injection of radiotracer, either intravenously or some radiotracer are given orally. So then patient has to wait for some time, and then further imaging is done on the SPECT and the PET-CT images and the scanners. So what is the role of nuclear medicine in thyroid and parathyroid pathologies? It has two roles to play. Number one is the diagnostic and the other one is therapeutic. In diagnostic, we have parathyroid scintigraphy, while for thyroid, we have thyroid scan, thyroid uptake, and iodine 131 whole body scan for thyroid cancer. In therapy, it is useful in both hyperthyroidism as well as in thyroid cancer. In hyperthyroidism, it is given for Graves' disease as well as for AFTN and toxic MNG. Coming to parathyroid scan, actually parathyroid scan is done when there will be hyperparathyroidism. That means the gland is overactive. So the purpose of the scan is to localize the parathyroid adenoma, which particular gland is involved in the disease. The scan is done for that purpose. So as in this case, I can say there is, can you see my arrow?
Yeah.
Yes. So there is increased radiotracer uptake in relation to the left parathyroid adenoma, the thyroid uptake as we can see, and then there is a parathyroid uptake. Then the salivary gland uptake is also seen. That is a physiological part of the disease. And what we can see, this is actually the parathyroid adenoma, which we can see from here. Give me 1 second so that I can. So next is that we have there is a case from our clinic. This was 27-year female patient were having hyperthyroidism, and as we can see, her PTH level was 345 picogram per ml. She underwent parathyroid scintigraphy. On the right side, the three images, as we can see, there is a parathyroid scan. In parathyroid scan, we can see the thyroid gland uptake as well as parathyroid activity. Are you able to see my this arrow?
Yes, sir.
Yes, it is visible.
Okay, so in this scan, I can see this is right lower parathyroid adenoma. On the SPECT images is below on the left side, as we can see, there is a focal uptake in corresponding to that parathyroid adenoma. So on the right side, we can see this is the choline PET which was done in the case, though it is not required in this case because this parathyroid adenoma was quite visible in the parathyroid scan on the left images, but we can see that there is images are sharper in choline PET CT, and this is actually done when there is a negative parathyroid scintigraphy, not in cases like this. This is actually the parathyroid scintigraphy is indicated here like hello. The parathyroid scintigraphy is indicated in those cases like this was a 32-year female having hyperparathyroidism. Her PTH level was 193. She underwent parathyroid scan. On the left side images, all the three left side images are parathyroid images, parathyroid scan images. On this, we can see we are not able to see any parathyroid adenoma. Only the thyroid activity and the salivary gland activity is visible. So on the right side, we can see there is arrow. That is the parathyroid adenoma, which is quite visible on the choline PET CT. So choline PET CT is actually indicated only when we have a parathyroid scintigraphy negative. So like in this case, so this happened actually when there is a small lesion like this. They are better detected on choline PET CT rather than the parathyroid scintigraphy. So here in these cases, the choline PET CT play important role. So coming to another case, this was 55-year male having hyperparathyroidism. This patient had PTH level was 537 picogram per ml. This patient underwent parathyroid scintigraphy. On parathyroid scintigraphy, as we can see, we have ectopic place of parathyroid adenoma, and this adenoma is quite visible on left lower image. As we can see, there is a sharp focal uptake noted in the parathyroid scintigraphy. As a part of thesis, we did choline PET CT on this, which we can see on the right side three images. The topmost images, the arrow can show this is a parathyroid adenoma. In addition to that, there are multiple areas of uptake noted in the rest of the scan. We can say this patient was having multiple brown tumor. Because of that brown tumor, the activity was seen. So in parathyroid scintigraphy, we have two investigations which are quite useful and reliable, which help us localizing the parathyroid adenoma and help the surgeon to go directly to that parathyroid adenoma and get it resected. So in these cases, we have parathyroid scintigraphy, which can detect more than 90% of the patient, but in 10% of the patient, we do need choline PET CT, where there is a small lesion or the parathyroid scintigraphy is negative. So these cases are we get help from the PET scan that is called choline PET CT. Either we label it choline or the fluorine. Coming to the next indication, which I'm going to discuss is thyroid scan. Thyroid scan is most widely used investigation in thyroid malignant thyroid pathologies. Thyroid scan can be done with the help of the two radiotracer. The radiotracer which commonly used for the thyroid scan are technetium 99M and iodine 123. Both are same. Sometimes we eat our roti with sabzi. Sometimes we eat our roti with I can say maybe chicken gravy. So the purpose is to eat the roti. Similarly, we can do the thyroid scan either with the technetium or with the iodine 123. So both can give us the same information, almost the same information. And normal thyroid scan, as we can see the right upper image, look like a butterfly shape gland, and we can also see the salivary gland activity, that is submandibular parathyroid and sublingual gland activity. So in normal thyroid scan, both the activity, that means the thyroid and the salivary gland activity will be similar intensity, but when there will be pathology, either the uptake will be less or uptake will be low. So all depend upon the which pathology we are dealing, then we can see that particular pattern of uptake in that pathology. The other investigation which is done for thyroid is thyroid uptake. This thyroid uptake is done for actually to differentiate between Graves' disease and hyperthyroid state from the thyroiditis. So normal uptake, which we can see with the help with the technetium agent, is 0.3 to 4%. With iodine, we can have 7% and 17%. This is more of typical nuclear medicine, may not be interesting for all of you, but increased uptake is seen in Graves' disease, AFTN, and toxic MNG, and decreased uptake is seen in thyroiditis. So with this uptake in thyroid, with the help of thyroid and with the help of uptake, we can differentiate between the Graves' disease and thyroiditis, and we can characterize other pathology on the basis of the thyroid scan. This is the case where this was the case of Graves' disease, where the thyroid scan can help us to differentiate between the Graves' disease and the thyroiditis. The first image we can see on the right side, this is the normal image, and the third image, which we can see, this is because of the Graves' disease. Thyroid is enlarged, uptake is more, salivary gland is suppressed. So on the basis of this, we can say this patient is having Graves' disease. On the right end, the last image, as we can say, the thyroid gland is not showing any uptake. That means this patient is having thyroiditis. The uptake of the thyroid is 0.09%. So from this, we can differentiate between the thyroiditis and the Graves' disease. Why it is important to differentiate? We all know that Graves' disease has different management and thyroiditis has different management. So it is very important to differentiate between these two modalities. They both have clinical and laboratory presentation. Not always, but most of the time they have a similar presentation. Coming to the other indication of thyroid scan, that is to help to characterize the thyroid nodule. Sometimes the thyroid nodule is difficult to differentiate between the Graves' disease and the thyroid nodule. Then the thyroid scan is indicated. Here, as we can see, there is a thyroid nodule in the right lobe of the thyroid, which is showing uptake, and the rest of the gland is suppressed. So on the basis of the thyroid scan, we can differentiate whether this is a autonomously functioning thyroid nodule, because again, this type of disease can be treated with radioiodine therapy and surgery. So it is very important to diagnose the autonomously functioning thyroid nodule in the thyroid problems. Coming to the next indication, that is to differentiate between Graves' disease and toxic MNG. Sometimes the thyroid gland is diffusely enlarged. In that scenario, it is difficult to differentiate between Graves' disease and the toxic MNG. Like in this case, on thyroid scan, we will see multiple nodules. Some are hypo and some are hyper. So on the basis of the thyroid scan, we can say this patient is having toxic MNG. Coming to the next indication, that is evaluation of the ectopic thyroid, because this will give us the confirmatory result. As we can see, we have left image, which is a normal image of thyroid. Thyroid is based in the thyroid bed. The next image is sublingual thyroid, where we can see the thyroid gland is located in the sublingual location. And there is a submandibular swelling. We are not sure whether this is submandibular gland or a thyroid. On thyroid skin, this is particular, on the right image, we can see there is a uptake. I think there is a background sound coming from, I think some speaker is on. Please, you may please switch it off. So coming to the next indication of thyroid scan is that thyroid agenesis. The thyroid scan is quite useful in detecting the primary congenital hypothyroid patient, where it will give a specific diagnosis by doing the thyroid scan. Like in this case, on the right image, as we can see the thyroid scan, only the salivary gland activity is seen. Submandibular activity, where we can see the upper arrow, and then the subparotid gland are seen. There is no activity in the thyroid bed region. That means the thyroid is definitely absent. So from this, we can say that this patient is having congenital agenesis of thyroid. So coming to, this was the diagnostic part of the nuclear medicine in thyroid and parathyroid. Now I will be coming to the diagnosis.
Background में चल रहा है, गपशप तो मार ही सकते हैं हम.
Sure. Then this I will be coming to the treatment part of the Graves' disease. That is it is actually, we all know that Graves' disease is treated either conservatively or with the ablation is done with the help of radioiodine or with the help of thyroidectomy. Conservative therapy is done with anti-thyroid drug. They are also, they have few advantages and disadvantages. That the advantages of anti-thyroid drug are that they are non-invasive, there is OPD procedure, cheaply available, and they have low risk of hypothyroidism, but they have high relapse rate. High relapse rate, that some patient may show side effects and response is not seen in some patient. Coming to the radioiodine, again, it is very cost effective. This is also a OPD procedure. This will help in reducing the size of the thyroid gland. So, but it has a disadvantage of that lifelong hypothyroidism are the chances with the radioiodine therapy. Similarly, with thyroidectomy, we have rapid and effective response to the Graves' disease, hyperthyroidism. But the other advantage that there is slight chance of exaggeration of ophthalmopathy, which is seen with radioiodine, which is not seen with the thyroidectomy. But it has also few disadvantages, like lifelong hypothyroidism can be seen with thyroidectomy, lifelong risk of hypocalcemia when you resect the parathyroid gland, and there is chances of recurrent laryngeal nerve injury. So considering this fact, surgery is also, pardon? Coming to the radioiodine therapy in hyperthyroidism, in Graves' disease, it is given 5 to 10 millicurie. For AFTN, it is 10 millicurie, and toxic MNG, it is given in 15 to 15 millicurie. The iodine which we get, it is available in two forms, either in the liquid form, this is just like a water, and other is the capsule form, ready-made pre-dose capsule, which can be taken and injected, and it's very simple to take as well. This was the treatment for the hyperthyroidism. That was Graves' disease, AFTN, and toxic MNG. Now coming to the treatment of thyroid cancer. As we know, if we are planning to clean our house, we need jadu and pocha both. Either jadu or pocha will not help in cleaning. We need both of them, this combination. Like similarly, for thyroid cancer, we need surgery and radioiodine therapy. Surgery will work like a jadu, and radioiodine therapy will work like a pocha. So after doing the surgery, patient will be classified as low risk, intermediate risk, and high risk. That is based on histology subtype, patient tumor invasion, lymph node involvement, post-therapy thyroglobulin level. On the basis of these, the patient is classified into low risk, intermediate risk, and high risk. Patient, those are having low risk, they will not be given radioiodine. They will be treated with TSS suppression only. Patient, those are having intermediate risk, and the patient having high risk, they will be treated with radioiodine therapy, and the TSS suppression and active surveillance is done. Depending upon that, either they are progressing or they are responding, again, the therapy can be re-explored. And some patient, only 5 to 10% patient can show the progression, and they can be treated with tyrosine kinase inhibitor. So what is the procedure of giving the radioiodine therapy? After surgery, the surgeon job, after the job of surgeon, then 4 weeks of interval should be given, so that the TSH value should go more than 30, because at that point of time, we will be able to detect all thyroid lesion and the remnant thyroid, and the patient will undergo the whole body iodine scan. Like this we can see. In this case, we can see only the thyroid remnant in the neck region. The activity we can see, this is salivary gland activity, which is physiological, and the gut activity, which is again a physiological. This patient then given radioiodine therapy on the basis of that. After radioiodine.
Sir, sorry to interrupt, sir. Sir, in the interest of time, I would request you to be a little brief. Thank you.
I will go fast. This is after radioiodine therapy, we can get different type of scenario. Like in remnant, we can see the remnant where we can give only 30 millicurie. When we have remnant plus node, we can give 100 millicurie. When we have remnant plus lung, 150 millicurie of iodine is given. And when we have skeletal metastasis, 200 millicurie is given. This was the case from our clinic. This was the patient having only remnant. This is physiological activity. Patient was given 30 millicurie of radioiodine. As we can see, after 6 months, there is complete resolution of remnant. The patient has responded to that totally. Another patient having lung metastasis, as we can see on the CT, and then there is a remnant in the neck and the lung lesion. Patient, this was 150 millicurie was given, and this was the post-therapy scan. On the last scan, which was done after 6 months, there is a complete response to the therapy. This patient again is a lung metastasis, and on the 6-month follow-up, as we can see, there is a complete response to therapy. This patient was having brain metastasis, lung remnant, lymph node, and lung metastasis. This patient was given therapy. After the 3 therapy, all other lesion has shown the resolution except the lung lesion, which is still persisting. This patient was having metastasis to D4 vertebra only. This patient was treated with radioiodine therapy. And on follow-up, as we can see the second image, there is no uptake in the D4 vertebra. That means this patient has responded. So take home message from my talk is that when you are unclear, you may go nuclear. Thank you very much with this for your patient listening. Yeah, I will be happy to answer any question if you have.
Sir, thank you very much. I'm Dr. Pandey. I practice nuclear medicine. I was just listening to your talk, and it was a very illuminative talk. And I should tell you, the only problem that we get, one small suggestion that I have is, mostly in skeletal metastasis, whenever we are giving radioiodine, mostly we see the resolution. In rare cases, we see a resolution. Otherwise, usually it persists. So there is a combination of radiotherapy there. If at all it helps. Apart from that, nothing helps whenever there is skeletal metastasis. That is in my experience that I've seen. Just wanted to comment on this, sir.
Dr. Pandey, I don't know your experience, how many patients you have treated for skeletal metastasis. I don't know how many high dose therapy we have in the country. There are 3, 4 I know, which is one in PGI Lucknow and one is PGI Chandigarh and AIMS or somewhere. I don't have any no people those are having experience in treating skeletal metastasis. But let me tell you that we have a very excellent result over here in institute. We have 25,000 patients for follow-up of thyroid cancer. We have more than 80% response in thyroid patient. Those are having skeletal metastasis, and we don't have this problem. We do face, but that number is very less. And in those patients, yes, as you mentioned, we consider radiotherapy for that particular lesion. If there is any impending fracture or that lesion is going to cause some impairment, and that particular scenario, the radiotherapy role come into that way.
Thankfully, sir, in Jammu, we are having a full lab which is accredited from AERB for high dose therapy inside BN hospital. So the center that we have, it is a fully accredited center, and we are doing radioiodine therapies here. All your patients are welcome here. We must try it there. But as far as my experience goes, the skeletal metastasis part that we have seen, yes, you must be having a large number of patients, I'm sure. But what little we have done a lot also, because we have got 2 radioiodine therapy wards at different places in the country, and my experience was that just what I shared with you. But it is good to learn that it is possible. Maybe we did not go beyond 200 millicuries. Maybe that might be one of the reasons, and very few we went beyond 100 millicuries.
I'm thankful to Dr. Shamim.
No, this statement is totally wrong. That 200 millicurie, we cannot go beyond 200 millicurie.
So Dr. Shamim, I think we need to move further in the interest of time. We are already lagging behind by 15 minutes. So if you have any questions, you may post them in the chat box or Q&A section, and we can have a discussion there. So we'll move to the next speaker now. So the chairpersons for the next session are Professor Pramod Kalsotra, who is Professor and HOD Head and Neck Surgery, GMC Jammu, Dr. Avinash Rajra, who is Consultant Surgical Oncology, Jammu, and myself. And I would request Professor Pramod Kalsotra to introduce our next speaker.
Yeah,
Sir.
Dr. Sunil,
good afternoon.
Okay.
I welcome Dr. Amit Agarwal, Professor and Head SGPGI. He's a big doyen, big surgeon, and excellent teacher in his field. So I'm waiting for his talk. So let's start with Dr. Agarwal.
Thank you, Dr. Pramod and Dr. Sunil, for having me on this wonderful first Jammu Thyroid and Parathyroid course. Can you see my slide, please?
We can see, but you need to make them full screen.
Yeah, I'm doing that. Yes.
Yeah.
Sorry. So my task today is to talk about the recent advances and the modern approach to an indeterminate thyroid nodule. And my previous two speakers laid the background by sharing with you their thoughts on the radiological and nuclear medicine aspect of the thyroid nodule. Now, the prevalence of the thyroid nodule, as we all have heard from the previous speaker, is high, up to 60%, as documented by high-resolution ultrasonography. But the important thing to keep in mind is that very few of these lesions ultimately will prove to be malignant, and it's somewhere less than 5% in most series. Now, what is an indeterminate thyroid nodule? We are all aware of the Bethesda system, which is the standardized system for reporting the cytology report of a thyroid nodule. And the category 3 and 4 are the ones which are known as indeterminate thyroid nodule. However, some series have also included diagnostic category 5, which is suspicious for malignancy category, also in the indeterminate category. Now, the Bethesda provides a very robust diagnostic framework, but there are certain pitfalls. For example, the cytology itself cannot distinguish between follicular patterned lesions such as the follicular adenomas and follicular carcinomas, and the problem with the indeterminate nodules. Now, why are we talking about this? Why is it so important to discuss this section? It's important because once the cytologist gives the report as indeterminate, it's a source of anxiety for the patient. And you can have reactions ranging from like, I fell apart, I cried. There's kind of a shock because when you hear the word cancer or a probability of a cancer, it creates a lot of surprises and shock for the patients. And the patient may say that, okay, you have to drop everything else and you have to, get yourself evaluated and treated and, put your life on hold. No, so that's why it's very important for us as clinicians to really deal this very sensitively. Now, above all, we don't want to do many harm. And what is that harm is? Because once you identify a patient with the cancer or probability of cancer, it triggers a cascade of deleterious events. Like people are transformed into patients. There is inevitable emotional consequence, and there is a potential exposure to risk, which is related to overtreatment, whether it's medical or surgical. And on the other hand, even at the public health level, the overdiagnosis will stretch the capacity of the health system, would increase the spending, would subtract the resources from those patients who are actually in the greatest need for the health care. So these are the ramifications once you give a diagnosis of a probability of cancer. Now, let's look what has been the traditional approach over decades. We are all very familiar that we do a good clinical exam, we do a cytology, we do an ultrasonography, and then if you get an indeterminate report, you subject the patient to surgery, which is a diagnostic or a therapeutic lobectomy. The clinical factors which I mentioned was, for example, if the nodules are firm, fixed, or rapidly growing, obviously there is a suspicion of malignancy. Important point to remember for the postgraduate is that if the intraglandular location of the nodule, it has been confirmed to be an independent risk factor for malignancy. And nodules from the isthmus are more likely to be diagnosed. So that certain clinical red flags are there, which as thyroidologists we must be aware of. And as our previous speaker mentioned, you get a thyroid report of certain features such as macrocalcifications, hypoechogenicity, taller than wider nodules, irregular margins, extracapsular spread. So these are certain pointers at the ultrasonography which can point towards the presence of, which can only tell you the probability of malignancy is higher as compared to the other features which are suggestive of benign nodule. Now, if you look at this flow chart, which was published in the ATA guidelines way back in 2009, and if you look at this here, where the indeterminate cytology, which could be either a Hürthle cell neoplasm or a follicular neoplasm, and the patient is then subjected to surgery with or without perhaps a preoperative ultrasound. Now, this was the only recommendation. And at that time, the molecular markers were recommended may be considered for patients with indeterminate, but the recommendation rating was C. So this was almost more than a decade back. Now, what is the problem with this traditional approach? As I already mentioned, the problem is of indeterminate cytology, which could be the tune of 10 to 15%, and a non-diagnostic cytology, which is so almost 30% or 1/3 of your nodules are not going to have a firm diagnosis, and your patients is going to land up in that anxiety factor, which I mentioned. Second important problem with this approach is that no single ultrasound feature is adequately sensitive or specific to confirm or to rule out malignancy. So what happens? Majority of these would undergo surgery. And as I mentioned, 80% would turn out to be benign lesions. And therefore, there is a concern over the cost, frequent outpatient visits, frequent evaluations, and a diagnostic thyroid lobectomy, which has a lot of ramifications. So definitely you would agree with me that there is a clear need for a more refined, a more tailored, and a careful approach to the evaluation of these prevalent lesions so that you can provide a healing touch to your patients and avoid all those anxiety attacks in your thyroid nodule patient. Now, one important development which Dr. Sarthak already shared with us was the development of the TIRADS reporting system on the similar lines of the BIRAD reporting system of the breast cancer. And here what they do is there is a constellation of features rather than a single feature. As I mentioned, no single ultrasound feature is suggestive of a malignancy, but when you sort of combine them and you give them a score, so anything above 4 B or C is highly suspicious of malignancy. So it is said that instead of taking one feature, you combine these features. And it has been shown that the category 3 or 4A has a very high negative predictive value if you combine with the Bethesda cytology reporting system. We also did a study, one of our previous MCA students, and we found that it was quite sensitive and helping us to predict malignancy in Bethesda 3, 4, and 5 lesions, that is indeterminate lesions. And this is under publication. And we recommended that sonography of thyroid nodules should be reported in a TIRAD format. And I'm happy to share that our radiologists finally agreed to, after so many years, to report the thyroid ultrasound in a TIRADS format. Now, having said that, we must also realize that there is some degree of heterogeneity across various systems. You have the American College of Radiology system, you have the Korean system, and whatnot. So there are so many systems. So what is the way forward? A very interesting development has taken place in the form of machine learning approaches, which is deep learning or artificial intelligence. And these tools may actually aid in the computer-aided diagnosis, what is known as an automated second opinion. And I would encourage you to read this paper, which is a very interesting paper about the deep learning. And here the conclusion was that the sensitivity and specificity of the deep learning algorithm for a thyroid nodule was similar to the expert radiologist who used American College of Radiology thyroid imaging and reporting system guidelines. So very, very interesting development that I can make play, and I can foresee in coming future, perhaps the automated reporting system perhaps would be the norm in our clinical practice. The other exciting development that took place for our thyroid nodules was the development of elastography, particularly the ultrasound elastography, because it was very easy to be used in the outpatient clinic by the surgeon or the endocrinologist or the radiologist. And here what happens is that you give a certain amount of pressure, which causes deformation of the tissue. And the principle is that in general, soft tissue would deform more, which is benign tissue, whereas hard tissue, which is a malignant tissue, will deform less when applied pressure. And then this property can be color-coded on grayscale and is given as an elastogram. Soft tissues are coded as red and hard ones as blue, but this can vary from machine to machine. And here is the principle. Here, there are two kinds of elastography: the strain elastography, which is more commonly used, and the shear wave elastography. And so, as I mentioned, there's degree of displacement, which is larger in the softer tissue or benign tissue as compared to the harder tissue. And this is an example of our patient with a benign nodule. You see more of green here, whereas here it's more of blue here, which is suggestive of a malignant. And it takes only a couple of elastographies to learn, and all surgeons I would encourage to learn this technique. It's very easy to master the technique, and you can use it in the outpatients. It just takes 10 minutes, even lesser, to carry out this, and you can give a beautiful report which can complement your cytology and the TIRADS by better predicting malignancy. So I'm sure in all the outpatient rooms of our endocrine surgeons, they would have an ultrasound machine which has a software for elastography. So it's a promising tool in the management of nodules, and it can reduce unnecessary surgery. So these are some of the papers you can find in literature. Now, the previous algorithm, as I mentioned, one of the recommendations was to use a repeat cytology. But unfortunately, the cytological assessment in the second aspirate provides only a definitive diagnosis for only 40% of class 1 and class 3 nodules. And 60% of patients will still have to undergo lobectomy, so which may be an overtreatment at the initial surgery. So something clearly is more needed to have a better predictability for malignancy. And here comes the role of molecular testing in the FNA aspirate. And this test have been developed over the last 1 decade. And there are 3 main molecular approaches that you should keep in mind. One is testing for somatic mutations. The other is testing for the gene expression. And the third is the messenger RNA-based classifiers, or the circulating markers. So these are the 3 broad categories of molecular testing, and I'll discuss one by one in the subsequent talk. So the advantage of molecular testing is not only to select the patients for surgery, but it also can help you to decide about the correct initial surgery, whether a total thyroidectomy or a hemithyroidectomy, and also whether to perform a prophylactic central compartment dissection or not. But this is not my mandate today, and I will just stick to the utility of molecular testing in selecting patients for surgery. Now, what is an ideal molecular test? There are 2 types of tests. So rule-in test means it tells you whether a particular nodule is going to be malignant or not. And the rule-out test, which tells you that a particular nodule is going to be benign or not. So an ideal rule-in test would have a positive predictive value for a histopathologically proven malignancy, similar to a malignant cytologic diagnosis that is above 98%. Whereas an ideal rule-out test would have a negative predictive value, similar to a benign cytological diagnosis, with a sensitivity of a 96.3%. Now, let's see what is in a rule-in test and what is rule-out in practice. So the 7-gene panel is the rule-in test, where you test the 7 genes. And it's a rule-in test because it has a very high reported specificity and a positive predictive value reaching up to 100%. And the test to remember is the thyroid sequence test, especially the version 3, which is the latest version. And this involves the next generation sequencing analysis of 112 cancer-related genes, where we look for point mutations, gene fusions, copy number alterations, or abnormal gene expression. And a lot of studies are there in literature which have actually proven. And the scientist to remember is Nikiforova from USA, who's actually a pathologist, but he has done maximum work in developing this thyroid sequence. And a lot of series have shown. And this is a very important slide, and I'll just like to spend 2 minutes on this. So if you have a cytological diagnosis of FLUS, the cancer risk by cytology is 14%. But if you have a follicular neoplasm, the cancer risk by cytology is 27%. And if suspicious for cytology, the cancer risk by cytology is only 54%. Now, if you add the test of this panel, this 7-gene panel, and if this test is positive, the cancer risk increases from 14% to 88% in the FLUS category, from 27% to 87% in the follicular neoplasm category, that is the category 4, and from 54% to 95% in the suspicious for malignancy category 5. So you see the utility of the 7-gene panel, where the predictability rate has gone up extremely, extremely high, and you can then counsel your patients accordingly. Now, what is a rule-out test? The other category of test is the gene expression classifier, or GEC, where you test the expression of 167 genes. And it's a rule-out test because it's a high negative predictive value. And this is the commercially available kit is known as Afirma, which is available in most of the countries abroad. And this was the landmark paper published in New England Journal of Medicine, where the data showed that the thyroid nodules that are cytologically indeterminate on fine needle aspiration and then benign, according to the gene expression classifier, would turn out to be benign. So with a very high sensitivity and specificity, a very high negative predictive value. And this was an interesting paper which actually compared the results of the endocrinologist patient decision, whether to operate on these patients or not, And they found that the historical rate of surgery was 74% in indeterminate nodules. But if you apply the gene expression classifier, this operative rate fell to 7.6%. So a drastic reduction in the operative rate if you use the gene expression classifier. So in short, the THYRADS sequence, which is the 7-gene panel version 3, and the Afirma, which is the GEC, they have a positive and negative predictive value, and they make them suitable for use in both the rule out and the rule in testing. So, but the question is always asked is, which is a better test? Now, meaningful comparison these tests is extremely difficult for various reasons, because the data comes from studies that differ significantly in terms of sample size, malignancy rates, study designs, and applying of the reference standards. And no studies actually compared head-to-head comparison of these two tests on the same sample. And the third is the high cost of these tests, which of course would limit the use in many countries. But hypothetically, some papers have mentioned that the THYRADS sequence version 3 was more cost-effective than gene expression classifier. Another important test that has been developed commercially is a 10-gene classifier for the indeterminate nodule, which is known as Thyroprine, and which is less costly than the other two tests. And it has also displayed a good performance in an internal multicenter validation study. And if you look at this paper published in Thyroid in 2017, this can be used for predicting malignancy instead of the THYRADS sequence or the gene expression classifier. So Thyroprine is also a good test, a molecular test for your thyroid nodules. Sunil, when he was doing his MCH, also conducted this project on the feasibility of utilizing these mutation panels in the fine needle aspirations. And we cohort of 106 samples, out of which 66 were cytologically indeterminate 3, 4, and 5 category. And we found that the NRAS mutation was associated with malignancy, though it did not reach the enough sensitivity. But the feasibility was demonstrated that in an aspirate, and you don't need any extra slides to be made or extra effort to be made, just one slide to be kept reserved for molecular testing. So it's a very, very feasible test. It's possible in centers, and I think most centers should be encouraged to take up this molecular testing in the fine needle aspiration cytology specimens. Now, the third category of tests is the circulating molecular markers, and it has been shown that the mRNA can be a marker of malignancy, and even if as few as 10 cancer cells are present in per ml of peripheral blood. And it has been shown that an elevated TSHR mRNA, more than 1 nanogram per microgram, was associated with 85% diagnostic accuracy. So it has a very high accuracy and sensitivity as well as negative predictive value. But I must tell you that there are various types of messenger RNAs, and if you very just published systemic review and meta-analysis, you will find that the authors have mentioned that messenger RNAs can assist in the diagnosis of malignancy, but rather than depending on a single messenger RNA, it will be wise to have a group of messenger RNAs to increase the sensitivity. So I'm sure in coming years, perhaps this could become a very important test for our thyroid nodule patients in our clinical practice. So if on the basis of all clinical imaging and cytological findings, the sole aim of surgery is diagnostic, then you should actually do a molecular testing. So you've done the imaging TIRADS and the cytology and elastography, and you still feel that the surgery is only in the form of diagnostic lobectomy, then you should utilize the molecular testing to increase the predictability of malignancy. This was a paper in the use of molecular testing, and the authors concluded that these were the patients who were not operated based on molecular testing, and they had only a 5% false negative rate in these patients when followed over 3 years. So this is what the test of the molecular testing which they utilized by not operating on these patients, and the test used here was gene expression classifier. A word about thyroid nodules in children and adolescents. Two things you should remember: that the risk of malignancy within the indeterminate categories in children is higher, that you should remember, and therefore perhaps you would utilize molecular testing more in cases of children and adolescents as compared to adult patients. So whenever you are faced with a child with an indeterminate nodule, it will be wise to apply a molecular test in these children and adolescents. Now I would like you to draw your attention to this ATA, recent ATA, which is published in 2015-16. And if you remember the 2009 algorithm, there was no mention of TIRADS and molecular testing. But here, after you've done the cytology and a TIRADS sonography risk, the recommendations are that if you get a OS or FLUS cytology, then investigations such as repeat FNA or molecular testing may be used to supplement malignancy risk assessment in lieu of just a diagnostic lobectomy. So this has been a great change from 2009 to 2015. So in 10 years, molecular testing in cases of OS, FLUS, as well as in with follicular neoplasm cytology is very important. And interestingly, in patients with those cytology of suspicious for papillary carcinoma, which is the category 5, they have shown that instead of gene expression classifier, it will be wise to include the mutation panel, especially BRAF. And they showed that if BRAF is positive, then it is 100% specific or for papillary thyroid cancer. So ladies and gentlemen, it is the evaluation and management of patients is no longer a one-size-fits-all proposition. What we have to use is a tailored approach, and this requires careful assessment of each nodule to determine the likelihood whether it is malignant and whether it will cause symptoms. Very few nodules will require an intensive workup that would include cytology, molecular testing, elastography, and all that. But for a vast majority, the assessment of clinical risk factors will provide a stable foundation for the initial management strategy. And this is a take-home slide for all the postgraduate. This is a modern evaluation and management of thyroid nodule. You do TIRADS, you do elastography, the reporting of cytology is Bethesda, you do a limited molecular testing in the fine needle aspirates. You go ahead and do a sutureless thyroidectomy if indicated, utilizing recurrent engine nerve monitoring systems, using ICG dye for intraoperative parathyroid detection so that you can predict hypocalcemia and identify the parathyroid glands. For non-surgical patients, you can use a high-frequency ultrasound to ablate the thyroid gland. And last but not the least, you can offer the patient a scarless or a minimally invasive endoscopic or a robotic thyroidectomy. So this is the modern thyroid surgeon's tools which are available to him to provide excellent thyroid surgery with minimal morbidity to their patients. Thank you very much for your patient listening. I'll be happy to take questions a bit.
It's a very beautiful presentation, very enlightening. It's eye-opener for a small place like Jammu. It's excellent presentation. In this forum, I want to say, can we have a live workshop on thyroid surgery?
Of course, I think once the COVID situation eases out, I'm sure live workshops is the way forward to teach our young budding endocrine surgeons and thyroid surgeons.
It's really very great for us to have you as a mentor for the live workshop.
Sure, I'll be happy to do it. Yeah.
So, any questions from the audience?
Yeah, I want to ask one thing. Sir, it's a great presentation as always. So, in the current era, when whole genome sequencing or exome, when the rates of whole genome sequencing are approaching that of individual gene mutations, so do you see ThyroSeq and for that matter, any other version of it be applicable to Indian population in foreseeable future?
Excellent question, Sunil. See, cost is always a factor, and it's not only in India. Cost is also concerned in even the Western world. And whole genome sequencing or exome sequencing is available. Commercial labs are doing it, but of course, the cost is a factor. Till that time, it becomes cheaper. I think a limited panel testing in indicated patients is the way forward.
Thank you, Sunil. I think we should move to next session.
Thank you.
Okay. Yeah, sure, sir.
Good evening, everybody. I'm Dr. Suman Kochar. I'm endocrinologist at Super Specialty Hospital, Jammu. So without wasting much time, may I invite chairperson for next session? So they are Professor R.K. Chirangu, Senior Professor of Surgery and Senior Surgeon from Jammu. Next is Dr. Malika, who is Assistant Professor at Endocrine Surgery at ST Lucknow. And our own doctor, Dr. Paris Khanna, he is Onco Surgeon Consultant at Jammu. I would request that Professor R.K. Rangu sir to please introduce Rauf Ahmed Bichu for his lecture.
Okay, thank you everybody. Dr. Rauf Ahmed Bichu is an endocrine surgeon. He does breast surgery as well as he's practicing in UK and has so many publications to his credit and many chapters in various books. He has also done many international presentations and presented invited lectures all over the world. Thank you.
Dr. Rauf.
Good afternoon, everybody. My name is Rauf. Yeah, thank you very much, Professor Chungu, for your kind words and a nice introduction. At the outset, I would like to thank Sunil for inviting me to be a part of this wonderful masterclass. Dr. Sunil asked me to talk about hemithyroidectomies in thyroid cancer. Professor Agarwal, he is my teacher and my mentor, and he did an excellent presentation talking about how thyroid cancer or thyroid surgeries has evolved from the traditional approach to where it is now. I would like to start my talk talking briefly about thyroid cancers, and then we go on to the surgical aspects of it. As is true with any cancers affecting the humans, thyroid cancer's incidence has been increasing over the last 3 decades, as has been shown by publications from SEED database. However, it has got a very good prognosis. The morbidity is there because of the treatment, but mortality is very, very low. A brief review of the types of thyroid cancers that we encounter. If we look at the histology of the thyroid gland, it is formed of follicular cells, which has got in between the follicles, there is stroma, which
Sir, can I request you to make your screen full screen, sir?
Is it not coming as full screen?
Not yet, sir. Not yet, sir. It's not full screen.
Now, is it?
Not yet.
Not yet, sir. Not yet. Sir, at your bottom right here. There, now it's full screen, sir. Thank you,
okay. Okay. Thank you for pointing out. Now, I was talking about the different types of thyroid cancers. The cancers can arise from the follicular cells, or it can arise from the parafollicular cells. Majority of the cancers, they arise from follicular cells, and they have been divided into either differentiated thyroid cancer or undifferentiated cancers. Very recently, in 2004, another category of thyroid cancer, which is called as poorly differentiated thyroid cancer, has also been recognized as a separate entity. The cancers that arise from parafollicular cells are the medullary thyroid cancers. Majority of patients who have thyroid cancer, they are either papillary thyroid cancer or the follicular thyroid cancers. And I'll be focusing more on these thyroid cancers. A brief review about how we manage these patients. Now, any patient who presents to us as clinicians with features that suggest that he or she may be suffering from thyroid cancer, apart from a good thorough history and examination, we do take the use of thyroid functions, TSH, FSH. We perform a high resolution ultrasound scan, and we perform pathological evaluation of the nodule with an FNA. Now, these will help us to clinch the diagnosis. Once the diagnosis is made, we do discuss with them the surgery, which will include surgery on the thyroid with or without lymph node dissections, either the central compartment or the lateral compartments, again, depending on the extent of the disease we have found. After the surgery, the pathological assessment will guide us in determining the adjuvant treatment options that we can offer the patient, which may be in the form of TSH suppression or radioactive iodine therapies, either remnant ablation or full-fledged treatment if has got any metastatic disease. Risk stratification in thyroid cancer is something which is not seen in any other cancers in humans. Now, any cancers, whether it is GI cancer or any other cancer, the risk of the patient has of the recurrence or mortality, it's determined at the time of diagnosis and the patient stays with it. However, in thyroid cancer, the risk the patient has, it gets modified over a period of time. Now, there are different stages where the risk stratification takes place. The initial risk stratification, it happens at the time of diagnosis. It helps us in determining which patients are suitable for active surveillance and who need intervention. It also helps us to determine the extent of the thyroid surgery as well as extent of nodal dissection. Now, once we have operated the patient, the post-op histology, again, another risk assessment happens with the post-op histology. The most commonly used is the American Thyroid Association risk stratification, which predicts the risk of recurrence and helps us to guide the adjuvant treatments, either in both the radioactive iodine ablation as well as TSA suppression and the level of TSA suppressions. Once we have treated the patient in the form of surgery and adjuvant therapy, during the follow-up, there is a concept called as dynamic risk stratification, that the risk of the patient of developing a recurrence or a persistence of disease, it changes over a period of time, the way they respond to the treatment. Now, if they have responded well, we can de-escalate the suppression or the radioactive iodine ablations. Coming to the second part of my talk, which is about talking about hemithyroidectomies in thyroid surgeon. As majority, we know that hemithyroidectomy, it involves the surgical removal of one lobe of the thyroid along with the isthmus and pyramidal lobe if present. And in comparison, total thyroidectomy includes removal of the entire thyroid tissue. As Professor Agarwal mentioned about, we do follow American Thyroid Association guidelines. In 2009, the American Thyroid Association, they recommended total thyroidectomy in all patients who were diagnosed with a differentiated thyroid cancer and the size was more than 1 centimeter. This recommendation was based on the rationale that the differentiated thyroid cancer, the total thyroidectomy, it provides better survival, it has lower recurrence, it makes use of radioactive iodine ablation possible, as well as increases the sensitivity of thyroglobulin in the follow-up period. Now, these recommendations was based on the study which was done by Bilimoria et al., which was on the basis of, it was a retrospective study from the National Cancer Database, which found out that the overall survival of patients who had total thyroidectomy was 98.4% in comparison to patients who underwent hemithyroidectomy at 97.1%, which was statistically significant. The study also pointed out that the recurrence rates in patients who had total thyroidectomy was only 7.7% in comparison to 9.8% in patients who had hemithyroidectomy. Again, it was found to be statistically significant. However, afterwards, a few other studies were performed, which in 2015, when the ATA revised their guidelines, brought about certain changes. Now, in 2015, the ATA recommended total thyroidectomy in patients with differentiated thyroid cancer, but size changed from 1 centimeter to more than 4 centimeter, or patients, irrespective of the size, if they had extrathyroidal extension, if they had involved lymph nodes on ultrasound scan, or if they have a prone metastasis. They also recommended that hemithyroidectomy should be considered in patients with a differentiated thyroid cancer with size 1 to 4 centimeter, but it should not be associated with any extrathyroidal extension or any lymph nodal metastasis. They also recommended hemithyroidectomy for patients with differentiated thyroid cancer less than 1 centimeter without any high risk feature, if they do not opt for active surveillance. Now, to summarize, the indications of hemithyroidectomy that we can perform is either for diagnostic purposes in Bethesda category 3 and Bethesda category 4, or for therapeutic purposes in patients with micropapillary thyroid cancers, thyroid cancers 1 to 4 centimeters without high risk features, or in patients with non-invasive follicular thyroid neoplasm with papillary-like nuclear features. This has recently been recognized as a separate entity. It was initially a follicular variant of thyroid cancer which was encapsulated. It was treated with a total thyroidectomy, but since it has got a very excellent prognosis, the majority of now it has been recognized that it is sufficient for these patients to have a hemithyroidectomy. Now, if we are moving from total thyroidectomy towards hemithyroidectomy, the first question that we need to ask ourselves is hemithyroidectomy oncologically safe? And what is the evidence or the data to support it? Now, the first study that I'm going to share with you is a study which was published by Barney et al. It was based on SEER database retrospective analysis. It included almost 24,000 patients, and they found that there was no difference in overall survival at 10 years in patients who underwent total thyroidectomy in comparison to patients who had lobectomy. They also found that there was no significant difference in cause-specific survival. Then to further supplement this study, there was Adam et al. Who performed a retrospective analysis of the National Cancer Database Registry. It included almost 62,000 patients, and they had a mean follow-up of 82 months, and they found that the survival of patients who underwent total thyroidectomy in comparison to patients who underwent hemithyroidectomy was almost similar, with a hazard ratio of 0.96 without any statistical significance. Now, if we look at the recurrence of patients who opt to have hemithyroidectomy, what the data suggests is the initial study published from Memorial Sloan and Kettering Cancer Center by Jitin Shah. They found that the recurrence rates after hemithyroidectomy in comparison to total thyroidectomy was 7% at 10 years of follow-up. The sample size in this study was small, 73 only. There was another study published in 2014 from Japan, which had almost 1,100 patients of papillary thyroid cancer. They were treated with hemithyroidectomy. At a mean follow-up of 17.6 years, the recurrence rate was only 4.6%. So in the literature, the predictive factors of recurrence after hemithyroidectomy are size, presence of extrathyroidal extension, presence of lymph node metastasis. They are known to have increased the risk of recurrence. So if these factors are present in a patient who has been recently diagnosed with thyroid cancer, we should seriously think that these are the patients who should be offered total thyroidectomy, not hemithyroidectomy. Now, this is a systematic review and meta-analysis published last year, which looked at whether how the patients with T1, T2 thyroid cancer will do over a long period of time if they are offered hemithyroidectomy or total thyroidectomy. What the study found, 10 studies were eligible, which with almost 23,000 patients, and they found that the pooled recurrence rate after total thyroidectomy was 2.3%, and after hemithyroidectomy was 2.8%, and it was not statistically significantly different. They also found that 20-year overall survival after total thyroidectomy was 96.8%, and it was better at 97.4% after hemithyroidectomy. If we do a hemithyroidectomy in a patient with thyroid cancer, do these patients need completion thyroidectomy? Yes, and the rates vary. Literature says that less than 10% rate of completion thyroidectomy is acceptable, and it's usually indicated once we have got the diagnosis of follicular cancer after a diagnostic hemithyroidectomy. It can be offered to patients who have high-risk pathological features in the form of extrathyroidal extension, vascular invasion, or nodal invasion. It can also be done in patients where we did hemithyroidectomy, but unfortunately the margins are involved, or patients who have aggressive histological variants. Complications in thyroid surgery is something which we as surgeons do need to take into consideration. There are studies which have looked at the volume of surgeries performed and the risk of complications the surgeons has. Higher the volume of surgeries a surgeon performs, lower is their complication rates. In comparison to total thyroidectomy patients, the patients who have who undergo hemithyroidectomies, the hypothyroidism rates, they vary from 16 to 40%. It depends on if the patient has high preoperative TSH levels, or if they have Hashimoto thyroidectomies, the chances are more. One important factor to consider about supplementing with levothyroxine after hemithyroidectomy is that they may still require it if they are deemed slightly at high risk and need suppression. In comparison to total thyroidectomy, recurrent laryngeal nerve injury and permanent hypoparathyroidism, the rates are less in patients who undergo hemithyroidectomies. It again depends on the surgeon's operative workload, as well as if there is any associated lymph node dissection performed.
Sir, I request you to be brief now.
Yeah.
Thank you.
Coming to the end now. The quality of life is important, especially with the thyroid cancers. the mortality is low. So more and more patients are surviving. So there is a couple of studies that I have quoted here which look at the quality of life in these patients. And they have found that hemithyroidectomy patients have a better quality of life in comparison to total thyroidectomy. I think I'll sum up with this. So when we consider patients for surgery who have been diagnosed with thyroid cancer, the various things that we need to take into consideration is the disease factor as well as the patient's preference. So we can offer hemithyroidectomy because it offers similar survival, similar recurrence rate, is associated with a lower complication rate and provides a good quality of life. But it should be a shared decision with the patient. Thank you, and I'll be happy to take any questions if there are any.
I think there are no questions. We can, if any questions are there, they can post in the chat box.
Sure.
So we will move to the next session now. So for the next session, I would request Professor Rajesh Goyal, HOD Head and Neck Surgery, ESCOMS, Jammu, Dr. Gurjeet Singh, Professor and ex-HOD CTVS, Jammu, Dr. Sunday Naika from Nigeria. She's a consultant surgeon, University Teaching Hospital, Abakaliki. Dr. Rommel, consultant CTVS surgeon, Jammu, and Dr. Vishwak Chanda, assistant professor endocrine surgery, Jammu, to take over and introduce the next speaker. Thank you.
Welcome, Dr. PRK Bhargav, for your talk. And Dr. PRK Bhargav is a renowned endocrine surgeon and a pioneer in remote access thyroid surgery and VATS. He is graduated and post-graduated from Karnal, Hyderabad, and he's a renowned man. So we will be happy to listen to his presentation.
Yeah, am I audible?
Yes, sir, you're audible, sir.
Yeah, good evening. So it's a very nice feeling to be part of this meeting, and I appreciate Sunil for his efforts in realizing and manifesting this first Jammu Masterclass. So basically, I'm from Vijayawada, Andhra Pradesh, presently. So the topic allotted to me is remote access thyroid surgery and video assisted thoracoscopic surgery, VATS. So first of all, remote access thyroid surgery, it's better to start with a definition. So thyroidectomy via any other route other than the direct open cervicotomy or sternotomy or line goiter can be defined as remote access thyroid surgery. So there are various approaches and techniques for thyroidectomy. The direct access, which is the conventional open access, which includes both neck and thoracic approaches. And another one is the remote access. This is the latest kid in the block. Since the opening of this 21st century, this is a revolution in field of endocrine and neck surgery. So there are various approaches in remote access, which have been tried at various stages with reasonable success. Almost all over the world now, it is being practiced. So the first one started with MIVAT, that is the minimal invasive video assisted thyroidectomy. And then with gas approaches are there, gasless approaches are there. The routes can be axillary route or chest wall approach, or the thoracoscopic approach for the thoracic goiters. And the other novel routes which have been tried, like post-auricular route and transoral, which is relatively the latest one. So I am fortunate to have attempted all of them, and I've published quite a few papers on this. Now, the key to any minimal invasive surgery, that is remote access surgery, is always it starts with the basics, that is anatomy, the clear surgical anatomy, knowledge, and also experience in that is mandatory. So the nerves, the parathyroids, and the relationships, the variations, and all are mandatory before embarking onto this novel techniques. So just briefly, because there's a limited time, I will give a bird's eye view on these various approaches. So this is a photo tour basically. So these are usually for any technique, preoperative surgical surface markings are mandatory because that will definitely ease our job. And also because cosmesis is one of the key parameters in taking up these surgeries. So these markings are very important for reasonable and optimal cosmesis. So the main landmarks like clavicle, the midline, and this anterior border of sternocleidomastoid, the goiter, nodule, and the anterior axillary line should be marked, and also the port sites, incision site. And we can also mark the surgical field. So these are the intraoperative image of a transaxillary technique. You can see the goiter with magnified view, even parathyroid in the left panel. This is the specimen delivery through axilla in the transaxillary route with gas technique. This is the immediate post-operative picture. So the neck is scarless. So because that is the key parameter. These are pre and post-operative images. You can see the goiter and the excellent cosmesis in the post-operative images. The previous ones which I showed was the gas transaxillary technique. Now the pictures of gasless single incision transaxillary thyroidectomy. Here one single incision is used, no carbon dioxide insufflation is used, retractors are used, and same axillary approach is used. The cosmesis is similar. This is the chest wall approach with gas. The port sites are in the anterior chest wall. But the problem with this is hypertrophic scars, propensity towards hypertrophic scars and keloid formation. So we should be cautious. We should take history of that. In fact, those who are prone for these keloids and hypertrophic scars are also candidates for endoscopic remote access thyroidectomy because neck will look very ugly. This is the chest wall gasless technique. All the incisions will be below the clavicle, unexposed part of the body. Now the transoral thyroidectomy, which I practice mostly nowadays. So here we approach through a lower gingival sulcus. So most of people are doing, quite a few of them around the world. This is a really excellent cosmesis because you can say it as scarless, really scarless, because the incisions are hidden and mucosal healing will be always excellent compared to the skin. Even hidden scars are not there. So you can see virtually scarless, and also the specimen delivery, if they're small through the port site can be removed. This is famously called as TOE TVA, this transoral route. Now, just a small mini video of the transoral parathyroidectomy. In fact, parathyroidectomy can also be done through transoral route. All these techniques can be used for that. This is just a specimen delivery I am showing through endobag, through one of the ports. This is the parathyroid adenoma. Now, coming to media, now whatever I've shown is for neck goiter. Now for the mediastinal or thoracic goiter, what are the remote access options? So here this is a goiter with mediastinal extension. Conventionally, we do the sternotomy for big goiters, you can see. But one of the revolutionary thing is this approach, which I devised indigenously. This is a combined cervical and video-assisted thoracoscopic thyroidectomy called CAVT, my own coined term. It's a innovative technique for posterior mediastinal extension. For anterior mediastinal and also left-sided goiters, it is little difficult. I have tried only in one case, unsuccessful attempt, but right side posterior mediastinal goiters, this is a wonderful technique which uses not double human endotracheal tube intubation for anesthesia. It's a single human with partial collapse on the ipsilateral side. So this avoids all the lung complications. This is a thoracoscopic thyroidectomy with minimal morbidity. This is published in Journal of Minimal Surgery. You can see no scar, no thoracotomy scar, no sternotomy scar. It's a brief video. So here there's a big goiter which is extending into the thorax, but could not be delivered in toto into the neck. So %70 has been delivered, but now the remaining part was operated through thoracoscopic approach. So here the lung is seen, which is being collapsed gradually. The port is accessed. So here the goiter which is visible. You can see the lung in the right inferior corner, collapsed lung. The goiter is behind the superior vena cava with the overlying phrenic nerve. And also you can see the azygos vein in the triangle, narrow triangle of the azygos vein and SVC. The goiter is seen, which is being dissected. Because this ensures bloodless surgery, because if you deliver blindly, that may lead to catastrophe, because tearing of vessels and can happen. Okay, now just because of lack of time, I'm not going for in detail video. Now the other areas which all these remote access can be used are parathyroidectomy, even thyroglossal cyst can be done, dermoid cyst, lipoma, and lymph node biopsies can be done through many of these remote access. So this is the latest surgery which I have done, that is video straight thoracoscopic parathyroidectomy. So this parathyroid, you see, it is very visible. This is anterior to the superior vena cava, just below the internal mammary vein. Internal mammary vein is clipped, and this huge parathyroid adenoma is dissected off, placed in the endo bag, and removed through one of the port. So this is a video assisted thoracoscopic parathyroidectomy. So the aims and objectives of any remote access surgery should be minimally invasive, minimal pain, shorter post-operative hospital stay, early discharge, early return to work, and should result in more complete surgery, lesser complications, which is directly linked with the experience, and the minimal or no visible scar, which is the universal requirement of any remote access surgery. Thank you all.
Thank you. So if there are no questions, I would move to next session. So I would like to invite chairperson for the next session, Professor Subhash Bharadwaj, who is Professor and Head, Department of Pathology, Government Medical College, Jammu. Dr. Gopika Kalsutra, Associate Professor, Head in Neck Surgery, JMC, Jammu. Dr. Vikram, Assistant Professor, Endocrine Surgery, SGPGI, Lucknow. And Dr. Vikas Roshan, Consultant and Oncologist at American Institute of Oncology, Jammu. So I would request Professor Subhash Bharadwaj to please introduce Dr. Ramaiah for her talk.
Dr. Subhash, you'll have to unmute your mic, sir.
Hello, am I audible?
Yes, sir,
Yes,
you
sir.
are audible.
Yes.
Oh, the next speaker for today's evening is Dr. Ramya C. Veluveru. She is an endocrine and breast surgeon. She's from Government Medical College, Sikandrabad. She has graduated from there. And she is a renowned name in the endocrine surgery. I invite her for her turn now. Please, Dr. Ramya.
At the outset, I would like to thank the organizers and especially my friend Dr. Sunil for giving me this opportunity and the chairpersons for that kind introduction.
Please carry on.
Ma'am, I just wanted to confirm, are you sharing your slides? Ramaya, ma'am, you've muted your mic, ma'am. Ma'am, if you're able to hear us, ma'am, you've muted your mic and you've switched off your video.
हमारे पास 2 चार्जर है ना बेटा।
Suman sir, are you there? Ramaya ma'am, can you hear us? Ma'am, can you hear us now? Ramaya ma'am, can you hear us? Yeah, we can see your screen now.
Till Ramya arranges her slides, so I would like to mention here, she has done a lot of work on medullary thyroid cancer in SGPGI, and her work is published also in World Journal of Surgery recently. So that is why she was chosen for this talk.
Sorry, I think there is some problem. I have already forwarded my slides. Is it possible to share from that side? Yeah. So, hello everyone. Please confirm if I'm audible.
Yes, ma'am, you're audible, ma'am.
You are.
Thank you. So I'll be talking on the challenges in the diagnosis and management of medullary thyroid cancer. Next slide. So as we all know, medullary thyroid cancer is a neuroendocrine malignancy arising from the parafollicular C cells. It's considered a relatively aggressive subtype of well-differentiated thyroid cancers. It accounts for about 2 to 4% of all the malignant thyroid neoplasms, but contributing to up to 15% of the total deaths attributable to thyroid cancer. At presentation, what has been seen is that about 50% of the patients have localized disease, 35% have disease extending into surrounding tissues, and about 13% can have distant metastasis. It can present in 2 forms, that is a sporadic form or a familial form. Sporadic form is seen in about 70 to 75%, and up to 25 to 30% may have familial form of medullary thyroid cancer in the form of multiple endocrine neoplasia type 2. Next slide. So the stage and age of diagnosis are the most important prognostic factors in case of medullary thyroid cancer. Early detection and diagnosis of the tumor are very important to cure the patient. And however, the diagnosis and management of MTC is very challenging and has many pitfalls. Next slide, please. So briefly about the parafollicular C cells, they are basically located in predominantly in the upper 2/3 of the gland and the posteromedial aspect of the thyroid lobes. And the normal C cells produce calcitonin and procalcitonin, and the malignant C cells also produce carcinomyronic antigen. All these molecules are important in the diagnosis as well as prognosis of MTC. Next slide, please. So medullary thyroid cancer is considered to be a continuum from the normal C cells to C cell hyperplasia to medullary thyroid cancer, and it can progress from the thyroid to lymph nodes and from there to systemic metastasis if left untreated. So as we can see in this slide, as pointed out by P, these are scattered parafollicular C cells in between the follicles, and they are generally located in between the follicles and are isolated. Next slide, please. So just for an understanding, C cell hyperplasia means at least 50 calcitonin immunostained cells should be observed per 3 low power fields to call it hyperplasia. But one has to understand that it can be a non-neoplastic process as well and a neoplastic process. Only if there are atypia and there is pleomorphism, we call it a neoplastic C cell hyperplasia, which is a precursor of MTC. Next slide, please. So as we can see in this picture, in the first picture, we can see that the isolated the cells, the parafollicular cells have proliferated and have displaced the follicles and even have displaced the follicular cells, thyroid follicular cells from the basement membranes. And in the picture B, we can see that the C cells are formed into a small nodule in the interfollicular stroma. So that is how the C cells are going to become neoplastic and look like on light microscopy. Next slide, please. So all of us are aware that the usual diagnostic workflow for thyroid nodule involves history and examination, followed by estimation of the basic thyroid biochemistry, followed by high resolution ultrasound and FNAC. Next slide. However, for the medullary thyroid cancer, it's a bit more complex. So we have, apart from the routine ones, in the biochemical evaluation, one has to look for the serum calcitonin, serum CEA, and in some cases, rarely serum procalcitonin. And FNAC washout for calcitonin is also being tried of late. And genetic testing forms a very important part of workflow of the MTC thyroid nodule. And patient has to be tested whether this MTC medullary thyroid cancer is a sporadic one or a familial one. And also the testing for other components of multiple endocrine neoplasia type 2 like the parrot hormone and metanephrines also have to be evaluated. So basically, it's not just evaluation of the thyroid nodule. The patient as a whole needs multiple levels of investigation. Next slide, please. So briefly about calcitonin as a biomarker, because I won't be telling the routine things, I'll be mainly stressing upon the pitfalls that one can overlook while treating these patients. So calcitonin is a monomeric peptide with a half-life of 30 hours. It is derived from procalcitonin. Earlier, there were, historically, the assays were unstable. But the latest bioassays using sandwich technique of 2 antibodies assay only the mature calcitonin, but not procalcitonin, and detect only functional monomers. So they're highly specific. And one has to remember that the normal values, that is less than 10 picogram per ml of calcitonin, has wide variations among different commercial assays, and it has to be done from the same lab in a given patient for reliability. And even amongst the normal population, the range is quite vast, and up to 60 to 80%, according to some studies, may have undetectable levels of calcitonin in normal subjects, and up to 10% of the normal people may have values higher than 10. So the interpretation has to be done in a very, very meticulous manner in order to understand the importance of calcitonin. Next slide, please. So the calcitonin is used in the preoperative workup of C-cell disease, which includes hyperplasia as well as MTC. In the screening of the familial patients of medullary thyroid cancer, It's a preoperative prognostic marker. It's a postoperative marker for detection of cure, persistence, or relapse. And the doubling time of calcitonin along with the CEA has a prognostic importance. It has been seen that the 10-year survival is 100% if the calcitonin doubling time is more than 2 years, and it is only 8 months if it is, 8% if the doubling time is within 6 months. That is how important it is. Calcitonin and CEA measurement are used for assessment of treatment response as well. So as we can see from this slide, there is although calcitonin is useful in understanding the extent of disease and prognostication, there is a wide variability, and sometimes in most of the cases, we see the values which are indeterminate and early MTC. So isolated calcitonin values are of less importance than interpreting it in the overall clinical picture. Next slide, please. So stimulated calcitonin testing is rarely used nowadays because we have other ways of confirming presence or absence of MTC. But however, in the olden days, it was of great importance, and pentagastrin was used. Nowadays, if it is needed, we have to use calcium gluconate for stimulated testing. The cutoffs for males and females are different, and it is about 79 to 90 picogram per ml for females, and it is up to 544 in men. Next slide. So increased levels of circulating calcitonin is always not related to C-cell disease. So for example, there could be laboratory glitches, and pharmacological treatments can interfere. And there are other non-medullary thyroid cancer, non-neoplastic as well as neoplastic conditions which can have increased calcitonin. So the treating physician has to be aware of all these pathologies in order to not make wrong decisions. Next slide. So pitfalls in calcitonin estimation that one has to pay attention to are heterophile antibodies, which are seen in 3.7% of cases, which interfere even in the current latest immunochemiluminescence assays, and they can give falsely high or low values. And this can be overcome by using blocking reagents and testing again. So there's one more thing called as hook effect, and it is seen in the patients who have extremely high values of calcitonins, like seen in metastatic MTCs, and they can give falsely low calcitonin levels. So further diluting the samples can help overcome this. There's another thing called as macrocalcitonin, which shows falsely elevated circulating calcitonin levels due to high molecular weight aggregates. And by using polyethylene glycol precipitation, this can be overcome. Next slide. So in some studies, it has been seen that the precursor of calcitonin, the procalcitonin, is useful. However, it is a non-specific one. It is elevated in many inflammatory states and other diseases. Next slide. So in rare cases, it has been seen that there is elevation of procalcitonin, but not calcitonin. But generally, it is not recommended routinely. Next slide. So the carcinoembryonic antigen is the next biochemical marker, which is seen especially in dedifferentiated medullary thyroid cancers. And basal levels of serum CEA has to be done according to the American Thyroid Association recommendations if the diagnosis of MTC has been made. So that, next slide, it can be used to follow up and prognosticate the patient. In some studies, there have been cutoff values have been derived to predict the extent of disease in MTCs based on CEA as well. Next slide. So coming to FNAC, cytology is the gold standard for diagnosis of thyroid cancers, and the sensitivity in follicular and PTCs, papillary thyroid cancers, is very high. However, that has not been seen the case with MTCs, but in recent studies with more awareness of the pathology of MTC, the sensitivities has been shown to be up to 86%. Next slide. So the classical features in cytology are that the smears are cellular and they have loosely cohesive patterns with plasmacytoid, epithelioid, or spindle-shaped cells with eccentrically placed nuclei, and salt and pepper chromatin, azurophilic granules with a background of amyloid, binucleated and multinucleated cells. Next slide. But these are, if these are all seen, then the diagnosis is generally straightforward. But still, even if these are present, it is recommended to perform immunocytochemistry for calcitonin, thyroglobulin, and chromogranin to confirm the diagnosis of MTC or refute the diagnosis of MTC. as I'm about to describe in the next slides. So as we can see here, there are many variants of medullary thyroid cancer. Unfortunately, they are all rare, but the treating physician has to be, and the pathologist have to be aware of these variants in order not to misdiagnose or miss the case of MTC or misdiagnose it as something else. Next slide. And MTC has been thought to be a great mimicker on cytology. For example, a micro MTC that is less than 1 centimeter may not present with typical features, and it can mimic a follicular neoplasm. Next slide. Or a Hurtl cell neoplasm can be thought like an MTC, but there are fine details that one has to pay attention in order not to misdiagnose. Next slide. So binucleated, multinucleated cells are frequent, but maybe it's only a minor criteria, and the architectural pattern may not be classical, and it can it may not be discohesive. It can be rosette, follicular, papillary-like, and trabecular. Rarely, even a cohesive pattern with rectangular cells may also be seen in MTC. And presence of amyloid is not a sure shot thing for diagnosis of MTC. Even an amyloid goiter can have MTC. So one has to perform a Congo red stain in order to confirm the disease calcitonin. And also one has to also interpret in the clinical picture to presence or refute the diagnosis. Similarly, nuclear cytoplasmic inclusions, which are also seen in PTC, can also be seen in MTC. And however, only nuclear groups presence is a confirming feature, which is for papillary thyroid cancer. And if it is present, the diagnosis of MTC is ruled out. Next slide. So pitfall is there even for immunocytochemistry, that even oncocytic cells of thyroid follicular origin can stain positive with calcitonin. In that case, performing a panel with thyroglobulin is going to save us. So in a study done correlating the FNAC with final histopathology, it has been seen that there is a discordance between preoperative FNAC and post-op histopathology, which was attributed to sampling errors, paucicellular samples, and lack of classical features of MTC in those cases studied. So
sorry to interrupt, Dr. Ramya. Please be brief now. Thank you.
Yeah. So we can move to the next slide. Next slide. So the comments are that the current literature is lacking in the prevalence of specific classical features in each case, and key is to consider the overall clinical picture. Next slide. So we also have options of testing for calcitonin on FNA washouts. Next slide. Or performing genetic testing on these FNA samples. Next slide. Coming to ultrasound, there are no specific features which can help us to clinch the diagnosis of MTC. And because of the rarity, it will be even more difficult to predict MTC just based on ultrasonographic pictures. Next slide. So CT and MRI are predominantly ordered based on the clinical suspicion regarding the extent of disease, and bone scintigraphy may be indicated to know the presence of bone metastasis. Next slide. So PET CT is not routinely recommended, and it has been seen that Dotanox somatostatin analogs are better in having better sensitivity than FDG PET. Next slide. Genetic testing is a well-established part of multiple endocrine neoplasia type 2. But however, the intra and interfamilial variability is an issue, and the prognostication has to be individualized and given in the background of the given family. Next slide. So apart from the genetic mutation, there could be even somatic mutations in the red as well as RAS, which are of prognostic importance. Next slide. As we can see, about 35% of them won't have any somatic red mutations, and 65% can have somatic red mutations, predominantly in the exon 16 codon 918. So the presence of somatic mutations correlate with lymph node metastasis, persistent disease, and lower survival, as evident from the research. Next slide. So there are quite a few challenges in the management as well. So the next slide. The surgery of the thyroid is straightforward. That is, total thyroidectomy has to be done, but the extent of lymph node dissection is controversial, because Next slide. There have been various studies which have correlated the presence, the level of calcitonin, and they have performed guided lymph node dissection based on these levels. The most famous study is from the Halle, Germany, by Dr. Drale and Dr. Andrea Mackins. They have said that ipsilateral neck dissection has to be done for more than 20, contralateral neck for more than 50, contralateral lateral neck for more than 200, and upper mediastinal dissection for more than 500, and it is also recommended by ATA. However, it's an expert opinion, but not proven by robust literature. Next slide. Similar evidence has been seen by this study as well. Next slide. But there are, next slide, please. There are a few contradicting studies to this as well, that it may not predict as much. Next slide. So the best practice suggestions for MTC is that MTC has a high propensity to metastasize to lymph nodes, and which portends a poor prognosis. So routine central compartment dissection has to be done. And as far as the lateral neck compartments is concerned, it should be decided based on the clinical judgment and imaging features by the treating clinician. Next slide. So regarding sentinel lymph node biopsy, there have been pilot studies which are very promising. Next slide. Prophylactic thyroidectomy is indicated in ATA highest risk category within 1 year of birth. Next slide. In high risk category within the age of 5 years. Next slide. In the case of moderate risk category, about based on the calcitonin levels, the surgery may be done around 5 years of age, but there are no clear-cut indications. Next slide. So in locally advanced cases, the surgery is mainly palliative and should be guided based on individual patient and should be done in a shared decision-making process. Next slide. So this is a very busy slide. What I intend to say here is that the follow-up depends upon a frequent evaluation of calcitonin, and the additional imaging should be guided by the level of calcitonin. Next slide. Other options are neoadjuvant tyrosine kinase inhibitors in relevant cases, external beam radiation, and organ-based metastasis management. And if there is operable recurrent or persistent disease, then it can be excised whenever feasible. Next slide. In case of metastatic MTC, we have RET targeted as well as multi-kinase inhibitors available these days. However, the dose has not been standardized for Indian patients, and the cost is an issue. However, we still, earlier we didn't have any option to manage these patients. At least now we have this. Next slide. As well as a PRRT therapy, that is peptide receptor radionuclide therapy, which are available at the major centers in India. And investigational molecules, immunotherapy and cytotoxics are also option in relevant patients. Next slide. So to summarize, there should be high index of suspicion for diagnosis of MTC due to rarity. Attention to detail in between and reading the reports in between the lines is very important in order not to miss it or misdiagnose it, because the first surgery is going to be the best surgery. One has to be very sure about the diagnosis before contemplating a surgery, and the management should be done in shared decision-making process, and genetic counseling is a very important part of management of MTC. Thank you.
Thank you, Dr. Ramya, for providing a good, deep insight into a very complex subject. But I, as a pathologist, would say that good, experienced hands, cytologists alone, are combined with the tumor markers, they can give you a sensitivity up to 70 to 80%.
Yes, I completely agree.
Yeah. Thank you. Thank you once again. Any questions, please? If there are no questions, next slide maybe up.
So thank you, Bhardwaj sir. So we begin our next talk now. So the chairpersons for this talk are Dr. Satish Parihar, Associate Professor Surgery, GMC Jammu, Dr. Vagan Hambad Zumyan, Consultant Surgical Oncologist, Yerevan State Medical University, Armenia, and former physician at Seda Sinai Medical Center, Dr. Mohit Goyal, Assistant Professor, Head and Neck Surgery, ESCOMS. I would request Dr. Mohit Goyal to kindly introduce our next speaker.
Well, good evening, everyone. Our speaker, Dr. Suman Kotwal, is an eminent endocrinologist working as assistant professor in GMC Jammu with loads of experience, international and national publications. I welcome you, sir, to kindly enlighten us with the topic.
Thank you, sir. Am I audible?
Yes, sir, you are.
I want to share my slides.
Yes, sir, you can share the slides.
Good evening, everybody. At the outset, I would like to thank Chairperson and my friend Sunil Muttu for giving me opportunity to present on this forum. So my job is to talk on post-operative hypocalcemia. So I will be just taking only 10 to 12 minutes only. So basically, what is definition of hypocalcemia? Hypocalcemia is defined as ionized serum calcium level below lower limit of the normal range. So it varies from lab to lab, but most of the labs cutoff is from 10.5 to 8.5 to 10.5. So post-operative hypocalcemia can be temporary or it is slightly long-lasting, which is called protected, or permanent if it is lasting for more than 6 months. So temporary hypocalcemia usually develops because of the some damage of the parathyroid gland. Whereas if there is a irreversible damage to parathyroid gland, so that will result permanent hypocalcemia. So recent meta-analysis has shown that the incidence of temporary hypocalcemia is around 19 to 38%, while that of permanent hypocalcemia is 0 to 3%. So what are the signs and symptoms of hypocalcemia? We all know hypocalcemia causes neuromuscular excitability and cardiac electrical instability. So this will result into constellation of signs and symptoms. But most common symptoms are paresthesias of hands and fingers, perioral tingling, and there is muscle stiffness, cramps, spasms. Patient can have vomiting, abdominal pain, or he can present with a confusion, anger, depression. And if the muscle contraction is sustained, so patient can present to you with laryngospasm. And if it is more severe, so patient can present with seizures. So signs are mostly, we usually see these two signs. So they are Chauvistic sign or Trocheau sign. But tetany can be hidden. That is known as latent tetany, or it is observed. So patient presents to you with frank carpopedal spasm. So there is no need to elicit it. But if calcium level is that not low, so patient will present with latent tetany. So and we have to monitor ECG also. So if patient is having hypocalcemia, his ECG will show QT interval prolongation, and it may result in TORC deep pointers, which will lead to ventricular tachycardia and which will ultimately degenerate into ventricular fibrillation. So what are the risk factors for post-operative hypocalcemia? So if patient is taken for bilateral thyroid procedure, so is at risk of getting post-operative hypocalcemia. If he is being operated for autoimmune thyroid disease, like Graves' disease or chronic lymphocytic thyroiditis, is at more risk of developing post-operative hypocalcemia. If he is undergoing this central neck dissection, either for prophylactic reason or therapeutic reason, so he is at risk of developing post-operative hypocalcemia. If patient is being operated for substernal goiter, so he is at more risk of getting post-operative hypocalcemia. So if patient is low volume surgeon, so there is a controversy who is good volume surgeon, but if surgeon is performing less than 100 surgery per year, so he is low volume surgeon. So if patient is undergoing simultaneous thyroidectomy as well as parathyroidectomy, so he is at risk of getting post-operative hypocalcemia. And if pre-operative vitamin D or your magnesium is low, so these are the risk factors for post-operative hypocalcemia. So how to prevent post-operative hypocalcemia? Best way to prevent post-operative hypocalcemia is to refer all patients to experienced endocrine surgeon. Vitamin D deficiency or this magnesium deficiency, if present, it should be corrected. So if patient has the risk factors, as I already alluded to, for getting this post-operative hypocalcemia, he should be perioperatively administered calcitrol, and studies have shown that incidence of post-operative hypocalcemia will be less in patients who has received calcitrol before surgery. So it is controversial whether parathyroid gland autotransplantation, which could be considered if there is a high likelihood of permanent hypocalcemia, may preserve parathyroid function or not. So how to predict post-operative hypocalcemia? Several attempts have been made to identify whether perioperative measurement of calcium, PTH, either together or separately, could predict this post-operative hypocalcemia. But we know that hypocalcemia mostly presents within 24 after surgery. Rarely it can present 3 to 5 days after surgery. So doing calcium on the day after surgery, just within 20 to 24 hours, will tell us whether patient is going into hypocalcemia or not. According to American Thyroid Association Surgical Affairs Committee, a PTH value of more than equal to 15 picogram per ml measured in adults at 20 minutes following thyroidectomy will obviate the need for intensive calcium monitoring and calcium supplementation. While if PTH value is less than 15, this would suggest an increased risk of acute hypocalcemia, and thus patient will require oral calcium or intravenous calcium and measurement of that calcium frequency. The ability to predict whether patient is going to develop transient or temporary hypocalcemia or permanent hypocalcemia is uncertain. So how to manage? The aim of the management of this hypocalcemia is just to take care of symptoms while avoiding side effects and complications. So mainly we give calcium and activated vitamin D, and sometimes we need magnesium also. And really we can give this recombinant human PTH if it is available. Thiazide diuretics may help to manage hypercalciuria if these patients develop hypercalciuria because of the high dose of calcitrol, and we can give low phosphate diet and phosphate binders if patient is developing hyperphosphatemia. So how to treat mild hypocalcemia? Mild hypocalcemia is hypocalcemia when corrected calcium is more than 7 milligrams. Most of these patients, they don't have any symptoms mostly, but sometimes they can have symptoms, or their hypocalcemia can be detected by doing these tests for latent technique, that is Troche's and Chuvastic sign. But mostly we come to know about mild hypocalcemia by checking calcium level. Signs related to neuromuscular stability may unveil these, as I already told you, latent hypocalcemia. These subsets of patients, we give oral calcium only. So we give around 1 to 3 grams of the calcium daily, and we combine it with activated vitamin D, that is calcitrol. So the dose ranges from 0.5 to 2 microgram of the calcitrol or equivalent doses of alpha calcitrol. What is moderate to severe hypocalcemia? So any patient whose calcium is less than, corrected calcium is less than 7 milligram per deciliter. They are classified as moderate to severe hypocalcemia. They are usually symptomatic. That means they are having all those symptoms, tingling sensation in hands and feet, perioral, and they can have observed technique. So there is no need to apply cuff on BP cuff, or there is no need to tap, and they are frankly having this Chuvastic or Troche's sign. Or really, you can just tap on the any branch of the facial nerve. So there will be grade 3 to 4 Chuvastic sign. The severity of symptoms and level of corrected calcium should guide the treatment. Severe hypocalcemia, which usually require hospitalization, and urgent treatment is required in the form of intravenous calcium. So we give mostly we give calcium gluconate, but we can give calcium calcium chloride also. But calcium gluconate, there are two ways of giving calcium gluconate. One way of giving calcium gluconate is simply we give this 10 ml of 10% of calcium gluconate over 10 minutes. Or what we do, we add 2 ampoules of this calcium gluconate in 100 ml of dextrose or normal saline, and then we infuse it over 10 to 20 minutes. The infusion should not be given more rapidly because there is a risk of cardiac complication, and we should monitor ECG while giving infusion. So this infusion we have to continue because the effect of this calcium will, bolus dose will last for 2 to 4 hours. Therefore, continuous infusion is required after initial dose. So this infusion we can make by adding 5-6 ampoules of calcium gluconate in 500 ml of normal saline dextrose 5%, and then we can make this solution as 1 gram in 1 ml, and then we can give at the rate of 1 to 2 milligram per kg per hour. That is around 50 to 100 ml per hour. So we should monitor this calcium every 1 to 2 hours hourly initially, and then after 4 to 6 hours thereafter. Calcium infusion for 8 to 10 hours using the protocol I discussed will raise calcium by 2 gram per deciliter, 2 milligram per deciliter. Oral administration of activated vitamin D and calcium should be started as soon as practical. The use of activated vitamin D, that is calcitrol or alpha calcitrol, is preferred because the potency of rapid, because of its potency, and it has a rapid onset of action. Because there is already impaired renal conversion in the absence of PTH of vitamin D to active vitamin D. The possible coexistence of hypomagnesemia should be considered if patient is having acute post-operative hypocalcemia. So if you suspect magnesium deficiency and magnesium is low, we should give magnesium sulfate, which is administered as 2 gram in 10% solution over 10 to 20 minutes, followed by 1 gram per hour in 100 ml. Recurrence of symptoms of hypocalcemia may indicate need to increase the rate of infusion. The infusion should be continued until an effective regime of oral calcium and activated vitamin D is reached. So usually takes 24 to 48 hours or longer, and subsequently should be tapered. So there is a limited experience with PTH molecules in post-operative hypocalcemia. Some studies have shown the advantages of PTH over calcitrol and calcium, but meta-analysis of only few trials have shown no definite advantage of these PTH molecules over calcium and calcitrol. So how to manage chronic hypocalcemia? The long-term management aims to maintain serum calcium in the asymptomatic range, avoiding significant hypo or hypercalcemia and associated complications. So in order to minimize the risk of symptoms, serum calcium should be maintained in the low normal range, and serum phosphorus should be maintained in no higher than the upper limit. Recommendation for 24-hour urine calcium excretion should be 7.5, less than 7.5 millimole per day, and calcium phosphorus product should be less than 55 milligram per meter square per deciliter square. To prevent hypercalciuria, that means more than 150 milligram in 24 hours, and to reduce the total amount of the calcium supplementation, we should give hydrochlorothiazide at the dose up to 12.5 to 50 milligram. So how to monitor this chronic hypocalcemia? In patients with post-operative hypocalcemia, we should do weekly measurement initially, and both of calcium and phosphorus until the patient is stable. Subsequently, supplement dose should be gradually tapered while serum and calcium phosphorus is monitored and eventually withdrawn if normocalcemia is maintained. Lifelong monitoring is needed in patients with permanent or chronic post-operative hypocalcemia. We should individualize treatment, and the target serum calcium should be kept within the low normal range with no symptoms of hypocalcemia. So baseline renal imaging has been recommended. According to this European Society of Endocrinology guidelines, they suggest for measuring this ionized calcium, magnesium, creatinine after 3 to 6 months, and 24-hour urinary calcium again after 3 to 6 months, and performing renal imaging when patients have symptoms of nephrolithiasis, or if there is a trend of rising trend of the creatinine. And changing the daily dose of calcium or activated calcium, or introducing a new drug, we should perform a calcium this monitoring of every weekly or every other week. Patients should be educated to recognize symptoms of hypo and hypercalcemia and complications associated with long-term therapy. So to conclude, we should conduct surgery so as to avoid removal or devascularization of parathyroid tissue. We should auto-transplant, devascularize, or inadvertently remove normal parathyroid gland. Either we should treat at-risk patient empirically with calcium, or measure calcium and PTH in immediate post-operative period and treat according to guidelines. We should titrate calcium with or without calcitrol to maintain eukalcemia, and wean calcium and calcitrol when appropriate. Inability to achieve independence for calcium by 6 months indicates permanent hypocalcemia. Recombinant PTH analog may be considered for patients with permanent hypocalcemia, but avoiding hypocalcemia is much less costly than treating hypocalcemia. Thank you very much.
Well, thank you, sir, for such an informative talk. If there are questions, we can take them right now. I guess there are no questions. I think we can proceed with the program.
Okay. So for the next session, I would request Dr. Anil Kumar Dar, who is Senior Consultant Physician and former faculty, GMC Jammu, Dr. Avdesh Pandey, who is Consultant Nuclear Physician, Indian Institute of Nuclear Medicine and Scanning, New Delhi, and myself, So I would request Dr. Anil Kumar Dar to introduce our next speaker.
Good evening, everyone. Thanks, first of all, to Dr. Suman and Dr. Sunil Mattu for keeping me in the loop. It's a wonderful program. Only thing is that I wish speakers had a little more time. That would have been really icing on the cake. Now, coming over to the next talk and the next speaker, Dr. Atul Sharma has been my student in undergraduate and postgraduate years. Later on, he did his DM in endocrinology and is now practicing endocrinology in Jammu, practicing, researching, and teaching endocrinology in Jammu. That's really wonderful. The topic is modern management of Graves' disease. Modern word is really tricky here because I'm not really sure too much has happened in the last 1 decade on this particular subject, but let's see how Dr. Atul Sharma tackled this particular word and the topic. Over to you, Dr. Atul Sharma.
Yeah, thank you, sir, for introducing me. And at the foremost, I would like to thank Dr. Suman, sir, and Dr. Sunil for giving me this opportunity to speak here. I hope I am clearly audible.
Yes, sir, you're audible, sir.
Yeah. So I will be discussing the modern management of Graves' disease. So I will begin with a clinical scenario. So we have a 23-year-old female who presented with heat intolerance, anxiety, tremor, and palpitation for the last 4 years, and processing grittiness of eyes for the last 2 years. On examination, it is grade 2 goiter, soft, diffuse, and she has tachycardia. BP is 160/60 with white pulse pressure, fine tremors, and warm and moist palms. And there is no dermopathy or acropathy. Initial investigations, total T4 23.5 micrograms per DL elevated and DSH suppressed. So what will be the further management in this patient? So we will do the baseline complete blood count, liver function test. Basically, Graves' disease is a clinical diagnosis. So we need not go for TIRADS except in some circumstances that I will be discussing later on. So in CBC, we have to look for absolute neutrophil count based sometimes neutropenia can also occur in Graves' disease, like 1,000 to 1,005 pounds can be expected in Graves' disease. So it is not a contraindication for starting treatment. Based on LFT, we have to look for this liver enzymes, and in that also they can also be elevated in case of Graves' disease as per se. So in case of doubt, for example, if there is no goiter, there is short duration of symptom, then we can go for ultrasound neck Doppler and technician 99 scan. So the primary treatment includes antithyroid drugs, which are carbimazole, methimazole, propylthiouracil, and other drugs, which I will be discussing in subsequent slides, and radioiodine ablation and surgery. And the adjunctive treatment will include beta blockers and steroids in special circumstances. So antithyroid drugs, usually they are the first choice in most circumstances. The rule of thumb is that if total T4 is more than 20 micrograms per DL, we start with 30 to 40 of immercazole, this carbimazole per day. And if total T4 is less than 20 micrograms per DL, then the usual dose is 20 milligrams per day. Propylthiouracil is used in special circumstances, for example, in Graves' storm or in pregnancy, first time of pregnancy especially, because it has a high protein binding, it is highly protein bound, so it is unlikely to cross placenta. And upon starting this treatment, we expect biochemical euthyroidism to be achieved in 6 to 12 weeks approximately, and then we reduce the dose by 5 milligram every 2 to 3 months. And the main point is that we have to continue this antithyroid drugs for at least 2 years because they have a immunomodulatory effect as well. So they help in that part also. And the maintenance dose is usually 5 to 10 milligram per day. And with that treatment, the remission rate is usually 25 to 50%. Now coming to the side effects, the commoner, which is 1 to 5%, they include skin rash, urticaria, arthralgia, etc. The rare one include, the main focus will be on agranulocytosis. These include 0.2 to 1%, and very rare will include aplastic anemia, thrombocytopenia, hepatitis, that is especially with PTU, and cholestatic jaundice with carbimazole and methimazole. So this is a basic scoring system. It is called as grade scoring system, which has come up in recent times, in which 4 factors are included: age, FT4 levels, TBI2 and TBI, and goiter size, WHO goiter size. And based upon these, we can grade make a score, and upon that we can predict what are the chances of what can be the chances of recurrence with antithyroid drugs. There is a grade plus score also in which this HLA typing is included. So the other agents will include iodine, and it acts by a Wolff-Chaikoff effect, which is when you give high dose of iodine, it inhibits this organification of the thyroid hormones. And it also, the main action is through hormone release. And basically iodine is used to be used in short term only, because after say 1 month or so, there is iodine escape and iodine no longer works. So the minimum dose for control of thyrotoxicosis is usually 6 milligram per day, which is equivalent to 1/8 of a drop of saturated solution of potassium iodide and 1 drop of Lugol solution. And maximum we can use 2 to 3 drops of saturated solution of potassium iodide twice daily. New regimen which have come up is 38 milligram of potassium iodide along with 15 milligrams of methimazole. This is basically to reduce the side effects of methimazole, and it can also be used. Another ancillary treatment, for example, if the patient is having this agranulocytosis or is having severe intolerance to methimazole, we can use lithium carbonate for the short-term use. The dose is 300 to 450 milligram 8 hourly, and it is basically a temporary use only. Other agents will include cholestyramine. It inhibits enterohepatic circulation, thereby reducing the total T4 and total T3 levels in the blood. And the other agents will include cholecystographic agents. 500 milligram of sodium hypodate twice daily for 5 days can be used, but it is very rarely available as of now. So and perchlorate was used in previous time, but it is mainly abandoned as of now. So the main agents would include antithyroid drugs, iodine, and lithium carbonate to some extent, cholestyramine in special circumstances only. Now the second line of treatment, which can be done is radioadjuvant therapy. Actually, the indication will include failure of remission on antithyroid drugs, or if the dose of carbimazole or methimazole is crossing 40 or 50 milligrams per day, still the patient is not achieving remission. Old age, large goiter size, which are unlikely to be get cured by this antithyroid drugs, and the patient is severely toxic. In that also we can use radioadjuvant therapy. And in this, we have to keep in mind that patient should be made euthyroid or mildly toxic before ablation. He should not be severely toxic, because in that case, this thyrotoxicosis may get aggravated. Typical dose is 10 to 15 millicurie, and we have to stop 1 week approximately before this radioiodine ablation, antithyroid drugs, and iodine-containing preparation for 1 month. And in case of females of reproductive age group, urine for pregnancy test must be done. And breastfeeding is contraindication for radioiodine therapy. And in case of clinically active orbitopathy, concurrent treatment of glucocorticoids, prednisolone 0.5 to 1 milligram per kg per day for approximately 1 month before ablation should be given. And one should avoid pregnancy for 6 months after radioiodine therapy. So post-ablation, there is a gradual decline in thyroid hormones, and 50% patients achieve euthyroidism within 6 to 8 weeks. And in that period, we can continue beta blockers, or if the patient is very toxic, we can give antithyroid drugs also. If patient still remains toxic, for example, 6 months after giving radioiodine ablation, then we can re-administer radioiodine with the same dose of 10 to 15 millicurie. Next type of management will include surgery. The indication will include typically large goiter, compressive symptoms, retrosternal extension, or thyroid carcinoma. And the typical procedure of choice is near or total thyroidectomy. And there is virtually no risk of recurrence in this. And complication in high volume centers will include permanent hypoparathyroidism in less than 2% of the cases, and permanent recurrent nerve palsy in less than 1% of the cases. And of course, we have to watch for bleeding also for compressive symptoms in 0.3 to 0.7% of the cases it occurs. Now, in surgical part, as far as the surgical part is concerned in perioperative management, first as far as from this endocrinologist point of view, we have to render the patient first of all euthyroid with antithyroid drugs and beta blockers. Saturated solution of potassium iodide, 2 to 3 drops twice daily, 7 to 10 days before surgery can be given. Basically, it reduces vascularity, and thus it helps in controlling control of bleeding during the surgery. We have to check pre-op calcium and 25 hydroxyvitamin D levels. And post-surgery, we can stop antithyroid drugs because thyroid has been removed, and we have to wean off beta blockers. And we have to monitor calcium level daily. And if indicated, PTH levels can also be measured. if we are suspecting this hypoparathyroidism, if parathyroid glands have been inadvertently removed. And post-op, we have to, because the patient is now completely hypothyroid, so we have to start this levothyroxine in full dose, 1.6 micrograms per kg daily, and we have to follow up with TSH 6 weeks post-op. Now, transient hypoparathyroidism is usually resolved within 1 to 7 days. We have to monitor it by the signs of latent technique, calcium phosphorus albumin estimation daily post-operatively. And in case of milder cases, we can give oral calcium carbonate up to 6 grams per day. We can give, and calcitriol, that is activated form of vitamin D, we can give it 2 microgram per day, doses from 0.5 to 0.2 micrograms. And in severe cases, we have to give intravenous calcium gluconate, as Dr. Suman told in the previous slides. And other cause of hypocalcemia can include, it is not always that the patient is having hypoparathyroidism, that patient will land into hypocalcemia. Basically, in grave disease, there is severe bone loss. So as soon as you remove the thyroid gland, there is euthyroidism achieved. So the bone will start to form again, and it will utilize calcium from the blood. So the patient will get this hypocalcemia, and it is labeled as hungry bone syndrome. So this is just basically the summary. What are the advantages and disadvantages, as I have already previously discussed. So coming to Graves' or vitopathy, basically two things are there in it. One is severity score and one is activity score. So first I'm discussing activity score, which is basically the inflammation of the orbit, and in which these three things are included: pain, redness, and swelling. Of pain, in pain we include this retrobulbar pain, or in gaze, different side of gazes. In redness we include redness of eyelids, in redness of conjunctiva. In swelling we include swellings of eyelid and swelling of caruncle or plica or chemosis. So if we score, that is based upon this, and if the clinical activity score is more than equal to 7, then we give treatment, which is typically IV methylprednisolone, 500 milligram weekly every 6 weeks, followed by 250 milligrams for 6 weeks. The cumulative dose comes around 4.5 grams per day. We can go up to 7.5 sometimes, but from above 7.5, it is usually not recommended because of serious toxicity of the phytosteroids. Ancillary treatment in the form of teardrops and black spectacles are given. Now this new agent has come up. It is teprotumumab. It was approved in 2020 last year, based on OPTIC trial. And the typical dose is basically 10 milligram per kg every 3 weekly for 24 weeks. They have compared with placebo, and they have found that the clinical activity score reduced by more than 2 points. So although the availability is a concern, but it's a new agent. The second line agents will include retrobulbar irradiation. Basically 10 gray is given over 6 weeks in fractionated doses. We can give repeat this IV methylprednisolone and doses, and rituximab can also be used. But the data is not very clear at this point of time. In case of site-threatening or vitopathy, we give methylprednisolone pulse therapy for 3 weeks, followed by same dose in the second week. If no response is there, then we proceed for surgery. Now, this is a severity score, the typical NOSPECS classification, which all of us know, and we classify based upon this into mild, moderate to severe, and site-threatening. In mild to moderate or vitopathy, if it is active, then we give IV glucocorticoids, as I mentioned previously. And if it is inactive, then we can go for rehabilitative surgery to reduce the tissue burden, soft tissue swelling burden. So in case of dermopathy, treatment is always not required. Most of the times it spontaneously remits. If there is functional or cosmetic concern to the patient, we can give occlusive dressing with 0.05 to 0.1% of triamcinolone acetate. And treatment of orbitopathy, sometimes steroids can also cause regression of dermopathic lesions. Now, special situations in pregnancy, when should we suspect this grave disease? Because tachycardia and palpitation, these are all common signs of pregnancy also. These happen in pregnancy also. So if there is failure to gain weight with trimester, there is intolerance, excessive sweating, tachycardia disproportionate to gestational age, then we can, there is goiter. So then we have to think grave disease. And if the patient was having grave disease prior to conception, then we have to counsel patient that he should be euthyroid prior to conceiving. And drug naive and toxic patient and patient requiring high dose of neomercazole should be radioiodine ablated prior to conception. The complications include preterm delivery, preeclampsia, neonatal thyrotoxicosis. The agents which are used, as already mentioned, propylthiouracil in first trimester, and carbimazole in second and third trimester. And we have to stop beta blockers in first trimester because they cause also fetal, they can also cause fetal growth retardation. And we have to monitor total T4 and oblique, and this free T4, basically free T4 is measured by equilibrium dialysis. That is a very tedious assay and not available everywhere. So we can measure total T4 also. And we have to take the cutoff of more than 1.5 times upper limit of normal. And you have to keep just above the trimester specific range. And postpartum after delivery, if the mother is taking carbimazole dose more than 50 milligram per day, then concentration in breast milk is said to be sufficient to interfere with the hypothalamic axis of this fetus. So it is recommended that once the mother takes this carbimazole, the patient, the neonate should be fed after 4 hours, and we should monitor thyroid function test of the newborn as well while the mother is on carbimazole. So in newborn, when to suspect thyrotoxicosis, when the patient newborn has low birth weight, poor feeding, failure to thrive, diarrhea, prominent eyes, etc. The most common cause will be the maternal Graves' disease, in which TRAPS, thyroid receptor antibodies, stimulating antibodies, they cross the placenta and stimulate the fetal thyroid gland. In this case, the typically remission will be in 3 to 12 weeks, and only temporary treatment with methimazole is recommended, 0.25 to 1 milligram per kg per day. If it goes beyond that period, then we have to think alternate causes like McCune-Albright syndrome, TRAP, and neonatal Graves. So just to summarize, the clinical condition basically based upon which we should choose the treatment. If the patient, for example, patient is young, not having this large goiter, then we can go with antithyroid drugs. If the patient is having orbitopathy as well, we can go with antithyroid drugs. If the patient is elderly with comorbidities, we can either go with antithyroid drugs or radioiodine ablation. If there is increased surgical risk, then we can also go with these both. In case of liver disease, better is to go with radioiodine ablation. Major adverse reaction to antithyroid drugs, same. And the patient is having this kind of heart failure, then also radioiodine ablation. And previous neck irradiation, previous neck surgery or irradiation, then also we should go with radioiodine. When we prefer surgery in case of recurrent hyperthyroidism, if there is suspicion of malignancy, if there is large goiter or thyroid nodules, and if there is coexisting hyperparathyroidism. So, thank you.
Thank you very much for Dr. Atul for a wonderful and a very clear, easily understandable presentation. In interest of time, I would suggest that all the questions be addressed through Q&A button, and over to organizers.
Thank you, Dr. Anil sir. So we now move on to our parathyroid session. So our first talk on the parathyroid in the parathyroid session is hyperparathyroidism, why it needs our attention, and the chairman and our panelists are Professor Abdul Ghani, HOD Orthopedics, GMC Jammu, Professor Badrinath Bogal, Professor of Medicine, GMC Katwa, Dr. Zahur Hussain, Professor of Surgery, GMC Jammu, and myself. And Dr. Suman Kotwal, who is HOD of Department of Endocrinology, GMC Jammu. So I would request the panelists to kindly introduce our speaker. Thank you. So Dr. Suman Kotwal, you can proceed with introduction.
Without wasting much time, so I would like to invite Professor Gaurav Agarwal, who is President Breast Surgery International. He is Professor Endocrine and Breast Surgery SGPGI Lucknow. He is convener SGPGI Breast Health Program. He has many publication in national and as well as international journals. So welcome, sir.
Thank you very much. I hope I'm audible to you all. And it is such a pleasure that Sunil has invited me for, oh, I can't share this screen. Can you please let me share my screen?
You can share a screen also.
Okay. Yeah, so, and it's such a good feeling to see so many of my ex-students connected today on this Zoom session. What Sunil has asked me to do is discuss why primary hyperparathyroidism needs our attention. Actually, he had asked me to discuss about hyperparathyroidism as a whole, but keeping the limited time at hand, I thought, let me make it more focused to only primary hyperparathyroidism. And indeed, this is a underdiagnosed disease which causes significant morbidity and suffering to humankind. And so it does certainly need our attention. I wish to acknowledge the help I have received from my colleague, Dr. Vishwak Chantar, in the department in preparing this presentation. Today, to answer this question that Sunil has posed to me, why we should bother about PHPT, I would like to start with enumerating 4 reasons why we should bother for PHPT. And these 4 very straightforward short answers are that PHPT is a common disorder. Its diagnosis is often missed because the manifestations are varied. And if left untreated, it has serious health consequences and cause serious impairment in quality of life and even mortality. And this is a readily curable disease when treated by experts. And not just the disease itself is cured, the end organ damage that the primary hyperparathyroidism can cause also improves significantly in majority. So let me go a little bit into details of these 4 reasons why I think PHPT needs our attention. So how common is primary hyperparathyroidism? Is it common enough to be bothered about? So, well, the initial description in modern medical literature of this disease came from Fuller Albright in 1930s. But for a long period of time, only certain cases with overt manifestation were detected. And the incidence recorded in those years used to be 7 to 8 cases per 100,000 population. However, with the advent of automated autoanalyzers with monitoring or screening for hypercalcemia coming into vogue, the incidence of the disease rose steadily and consistently to almost 50 cases per 100,000 population by 1970s, and it continues to be around that, or further, it has increased a little further. However, in India, majority of cases are diagnosed because they are overtly symptomatic, because we do not have a routine practice of biochemical screening for hypercalcemia. However, there seems to be a trend of increasing asymptomatic cases in the last 3 decades consistently, as more and more people are undergoing biochemical screening. So it is indeed a common disease. It is the 3rd commonest endocrinopathy, next only to diabetes mellitus and thyroid disease or hypothyroidism and nodular goiters. And classically, it used to be called the disease of stones, bones, and abdominal groans. And current prevalence is, it ranges between 1 to 4 per 1,000 population in various countries where biochemical screening for hypercalcemia is consistently followed. There are no prevalence or demographic data available from our country, but certainly the incidence in our country is much, much lesser, but still quite, large enough or high enough for us to take note of it. Predominantly, this is a disease of women, and the mean age at presentation in Western countries is in their 60s. However, in India, it's about two decades earlier, and the mean age at presentation in our experience has been around 40 years. So second reason why I think PHPT needs our attention is that it is an elusive disease, and the diagnosis is often missed. And this is to a large extent because the manifestations are quite varied and to some extent very non-specific. So it is not inappropriate to call it a great mimic, though this phrase was initially reserved for diseases like pheochromocytoma, but indeed the PHPT2 is a great mimic. The clinical manifestations of this disease are on account of one of the 3 reasons. Firstly, these manifestations can be due to the metabolic effect of the excess amount of parathyroid hormone or the hypercalcemia per se. And
Okay.
these can, or is there something? Oh, so the manifestations may be because of excess PTH or hypercalcemia in form of nausea, vomiting, malaise, and excessive thirst. Or these can be because of target organ or organ system damage due to hyperparathyroidism and hypercalcemia, such as the musculoskeletal manifestation or renal system manifestation. And rarely, the manifestations can be due to a large or invasive tumor, though this is rare. So why is the diagnosis missed? Because it is because the manifestations or symptoms due to hyperparathyroidism are quite non-specific, and the musculoskeletal manifestations are often missed by general practitioners and picked up by an orthopedic surgeon when they start treating bony swelling or non-healing fracture. Similarly, renal manifestations are again missed often in general practice, and only when there is considerable renal involvement, such as either nephrocalcinosis or renal stones, or even CRF, that the disease is picked up. The third reason why this disease warrants our attention is because untreated, the disease can cause significant morbidity and even mortality, and certainly can cause considerable impairment in quality of life. If not treated early, in a certain subset, the disease can be progressive and crippling, and even may have fatal metabolic effects. There is, however, a changing trend in its presentation, and more asymptomatic or mildly symptomatic patients are being diagnosed, even though overtly symptomatic patients are also being treated. There are a number of variants of hyperparathyroidism that we are aware of, including the classical asymptomatic one, but they can be normocalcemic, normohormonal, and hypercalcemic kind of variants as well. The disease is usually insidious, but it has incremental effects on the musculoskeletal system, the renal function, the cardiovascular system, gastrointestinal system, and the metabolic profile can also deteriorate. In our own experience, roughly about 80% of all our patients are overtly symptomatic. 50% of them have musculoskeletal disease, 36% of them have a combined bone and renal disease, almost 35% have isolated renal disease, 15 to 50% in various series have been reported to be having gastrointestinal symptoms or manifestations, including pancreatitis, and about 10% of them have neuropsychiatric illness. In Indian experiences, a small minority actually are asymptomatic, and in our experience, no more than 6% actually are asymptomatic, picked up on biochemical screening. Looking at the musculoskeletal manifestations, you have a couple of pictures projected here, X-rays with a classical salt and pepper skull, and a patient with brown tumor in the bones of the lower limb, and a non-healing fracture due to hyperparathyroidism. So classical musculoskeletal manifestations of primary hyperparathyroidism are called the osteitis fibrosa cystica, which have three components: profound bone resorption, fibrosis, and cyst formation. The musculoskeletal manifestations, as reported in Western literature, they range between 13 to 90% of patients. In developing countries, the musculoskeletal symptoms or disease is much more prevalent and constitutes definitely more than 50% of all patients. In our experience, almost 73% patients had classical osteitis fibrosa cystica, 58% had osteoporosis, a wide range between 18 to 51% have had fractures, a significant number of these patients are crippled due to multiple fractures and profound muscular weakness. And there are a number of patients who have bony deformities or brown tumors and proximal muscle weakness. The musculoskeletal disease has a profound impact on the quality of life of these patients. It worsens over the period of time in majority. The loss of the bone mineral density at cortical site is seen classically within a span of 9 to 10 years if the patients are not treated surgically and followed up. 60% of the patients followed up, they were found to have more than 10% of loss in BMD over a period of 15 years. With overt skeletal manifestations, patients have BMD reduction up to an average of minus 4.8 in their Z scores at the distal radius, putting them at an excessive risk of fractures. And 37% have shown progression in over 15 years in the disease warranting surgery. So these patients are certainly at a significantly higher risk, 2 to 3-fold higher risk of fractures compared to healthy individuals. And our overtly symptomatic patients, we have made some very interesting observations, including this kind of syndrome of disappearing bone. What you see here is actually the X-ray of the right femur, and you can see, or rather not see, any bony outline whatsoever. This is because of the syndrome of disappearing bone, which occurred in about 8% of all our patients at one stage. Renal manifestations too can be crippling in these patients, and these can be in form of nephrocalcinosis or nephrolithiasis. In various Indian series, or varying proportion of patients ranging up to almost 50% have had nephrolithiasis or nephrocalcinosis. A significant proportion of these patients, they are picked up due to recurrent renal and bilateral renal calculi. About almost 20% have decreased GFR and proximal tubular acidosis as well. If untreated, patients and then followed up at around 10 years, they up to 40% have frank hypercalciuria, 10% have increase in serum calcium levels, 8% have decreased renal function, and 6% develop active renal stone disease. And thus, these warrant such surgical treatment. Cardiovascular manifestations too, though under-recognized or under-detected, can be crippling, and these can lead to cardiac mortality as well. Why should primary hyperparathyroidism have cardiac manifestations? It's because hypocalcemia can cause ectopic calcifications. Besides, the PTH itself has been known to be a direct myocardiotoxic agent. And the cardiac manifestations range from hypertension to left ventricular hypertrophy, myocardial, interventricular septal, valvular calcifications, diastolic dysfunction, arrhythmias, and various other manifestations, including premature atherosclerosis. And this disease also causes impaired carotid and coronary distensibility. In our study that we published some time ago, using some objective criteria to detect cardiovascular disease, we have reported a significantly high proportion of patients being affected by cardiovascular disease. And in it's a well-known fact that patients with primary hyperparathyroidism have a high cardiovascular mortality. And this ranges, the causes for this cardiovascular mortality can be myocardial infarction, heart failure, stroke, atherosclerosis, and mesenteric artery thrombosis in varying proportions. Primary hyperparathyroidism also causes gastrointestinal symptoms, and this can be associated with peptic ulcer disease in up to 50% of patients, and in about 15% patients, it causes pancreatitis. There is conflicting data concerning constipation, and in patients with MEN1 or MEN4, peptic ulcer disease is very common. The disease can also cause significant neuropsychiatric manifestations, and the nature of neuropsychiatric manifestations quite varied, right from psychiatric and cognitive symptoms like lethargy, confusion, depression, anxiety, and whatnot. And these symptoms can develop irrespective of the serum calcium levels, and they do not correlate with the severity or biochemical severity of the disease. Psychiatric and behavioral symptoms are usually vague and non-specific in geriatric patients, and thus they're often neglected. There have been a number of attempts at quality of life assessment using various scoring systems such as SF36 or PASICA visual analog scale. And universally, they have all reported a significant impairment in quality of life. So coming to the final reason why I think primary hyperparathyroidism needs our attention, and this is that the disease is eminently curable in majority of patients. Why? The reason is it's a benign disease in majority, and the cause is a parathyroid adenoma in little over 80% of patients, and primary benign hyperplasia in 15% of patients. Parathyroid carcinoma is a rare cause of primary hyperparathyroidism, affecting about between 2 and 5% of all PHPT patients. So the cure rates of the disease in hands of expert parathyroid surgeon exceeds 95%. And with the modern age of appropriate localization studies such as sesame B scanning and high resolution focused ultrasonography in 4D CT and whatnot, and appropriate intraoperative aids such as intraoperative PTH monitoring and minimal access strategies, the success rates are quite good, certainly more than 95% in expert hands, with even cosmetic outcomes being very satisfactory. So parathyroid surgery is capable of providing lasting cure of hyperparathyroidism and hypocalcemia, and also causes considerable recovery of most of the systemic manifestations. Recovery pattern of the biochemical parameters has been studied extensively. Parathyroidectomy has been shown to cause consistent improvement in the serum calcium, PTH, vitamin D, and 24-hour urinary calcium excretions. Serum alkaline phosphatase and oxalocalcin, both of which are biochemical markers of bone turnover or bone formation, they stabilize over a period of 6 to 9 months after successful parathyroidectomy. Similarly, markers of bone resorption, such as urinary type 1 collagen-specific peptides, they start decreasing as early as 1 week after parathyroidectomy and normalize over 3 months. The musculoskeletal manifestations, they start improving very soon after parathyroidectomy in patients who have overtly symptomatic PHPT and musculoskeletal manifestations. And there is a remarkable early increment in the BMD at the lumbar spine and femoral neck, and there is substantial and continued increments in BMD right up to 10 years after parathyroidectomy. Our study published in 2002 about the recovery pattern of osteitis fibrosa cystica after parathyroidectomy was perhaps one of its kind, and the first of its kind for sure, where we documented the nature and the extent of recovery of osteitis fibrosa cystica. Subsequently, we have revisited this issue and provided or published the long-term outcomes of musculoskeletal disease. And some of these details I'll have to skip in interest of time, but we did report very significant and startling nature of recovery. And here you see the pre-operative and 12-month post-parathyroidectomy x-rays of the same patient of the lower limb. And there is a considerable, or rather startling, remineralization of the bones, as you can see there. This is the same picture I showed you earlier. This is the x-ray of the right thigh, and the femur is not visible. 3 months post-op and 12 months post-op, you can see such a deformed but remineralized femur. Similarly, in this x-ray of the right femur, again, you can see to expansile brown tumors 3 months and 12 months post-treatment. There is such a deformed but demineralized femur visible. Here you can see non-healing fracture, and then sometime after parathyroidectomy, you can see a callus here. So this is the extent of recovery that we have documented, and we find that bone pain improves in almost every patient, osteopenia improves in 2/3 of patients, proximal muscle weakness similarly. Those who had a crippling disease, also they recover within over 3 months, and the bone deformity in brown tumors recovery is quite variable, and fractures heal in almost every patient over a period of 3 months. The renal disease too recovers very considerably. Nephrocalcinosis progression is arrested after parathyroidectomy for sure. 90% of patients with renal stones are cured of the renal stones, as evident by the fact that there is no recurrence of nephrolithiasis in these patients, and urinary calcium excretion and rate of stone formation after parathyroidectomy becomes comparable to idiopathic stone formers, and the diminished GFR consequent to renal parenchymal damage may actually not recover after parathyroidectomy, and that's because of irreversible renal parenchymal damage which has set in. The cardiovascular manifestations are also very reversible. We have documented that 50 to 60% reduction in left ventricular mass occurred, and it confers its sustained reduction at 6 months. Thereby, enhanced stroke volume and left ventricular ejection fraction are evident. Hypertension, however, fails to improve in majority after parathyroidectomy. This is one of the studies we have published relating the extent and nature of cardiovascular dysfunction in symptomatic PHPT patients and how they recover or reverse after curative parathyroidectomy in 2013. And these are the various indices of cardiovascular evaluation which we could identify were deranged at baseline, and they improved consistently over a period of time following parathyroidectomy. The gastrointestinal manifestations also improve or resolve after parathyroidectomy. Pancreatitis resolves in about 2/3 of patients over a period of 1 to 9 years of follow-up. And the peptic ulcer disease is also reduced by up to 95% following successful parathyroidectomy. Neuropsychiatric manifestations are amongst the most brittle symptoms, and they do not improve as much as some of the other symptoms or manifestations. However, to a varied extent, they are documented to be improved, and in our own experience at SGPGI, using very objective tools, we could document that certain kinds of neuropsychiatric symptoms they recovered as early as 1 week post-operatively. So what I have talked about in last 15 plus minutes is that we need to be aware of this entity called primary hyperparathyroidism, because it's a common disorder. It is underdiagnosed, and it is misdiagnosed often because of its varied manifestation. The fact that this is a great mimic poses a lot of challenges to general physicians, general practitioners, and to all kinds of specialists. Untreated, that this disease has serious health consequences, both in terms of symptoms, complications, organ failures, including renal failure, and impairment of quality of life. And this all can lead to premature deaths. And certainly, there is a well-documented higher cardiovascular mortality in patients with primary hyperparathyroidism. And finally, the disease is eminently curable when identified and treated appropriately by experts. And the success rate of parathyroid surgery in hands of expert parathyroid surgeons is in excess of 95%. And not just the biochemical cure is achieved, there is a significant improvement in majority of the end organ damage and the manifestations they cause in these patients. So that is why what all I had to discuss today. If there are any questions, I'll be very happy to address them. Thank you very much.
I think there are no questions. I thank Professor Gaurav Agarwal for this wonderful talk and his august presence here in this meet. So I now hand over to Dr. Vishwak for further moderation. Dr. Vishwak, please.
Thank you, Dr. Sunil. We'll move on to the next session in parathyroid. Next is a panel discussion by the multidisciplinary team of panelists. Now I would invite Dr. Sunil Mattu, Assistant Professor Endocrine Surgery in Jammu, as a moderator of the panelists for the next session. Over to you, Dr. Sunil.
Start sharing my screen.
Yes, sir, please go ahead.
Okay, I'll start sharing. Okay, are my slides visible?
Yeah, your slides are visible.
Okay, after this August, these wonderful presentations by August panelists and speakers of national and international repute, I would request all of you to just chill out for a second. We are going to have some sort of semi-formal parathyroid panel discussion. It is actually a clinical case that we are going to discuss. And we have a wonderful group of panelists with us today. So let me introduce my panelists first. So we have Dr. Muhammad Iqbal, who is a nephrologist practicing in Jammu, Dr. Anshul Kotwal, a urologist from Jammu, Dr. Premwada Tyagi, who is a consultant endocrinology at Max Hospital, Delhi, Dr. Sanjay Kumar Yadav, an endocrine surgeon at NSCB Hospital, and Dr. Bhupinder Singh, who is a maxillofacial surgeon. So I would thank all panelists to be a part of it, the panel. So let me begin with the case now. So we had a 40-year-old female who was resident of UP, the Terai region, and she came to OPD and with bony pains for 5 years, and she had pain in both flanks for 6 months. She had past history of fracture, right femur neck with trivial trauma, and she already had undergone a hemiarthroplasty with bipolar prosthesis. You can see the X-rays here. The orthopedician had done a biopsy intraoperatively, which revealed osteitis fibrosa cystica. And somebody ordered serum calcium. It was 10.8 milligrams per deciliter, and serum IPTH was subsequently done. And the values were 860 picograms per milliliter. So this was back in 2019. So going further, so we have an eminent endocrine surgeon with us, Dr. Sanjay Yadav. So Dr. Sanjay, in the wake of these findings, like fracture with trivial trauma, high serum calcium, along with high PTH. So would you suspect PTH? If yes, what should be the relevant history and examination in this case? Dr. Sanjay.
Okay, yeah, hi. Good evening, everyone. First of all, I would like to thank you, Dr. Sunil, for this wonderful webinar. So I think this case scenario which you have presented, this obviously we have biochemical reports here with us. So obviously it points towards PHPT. But even in the absence of this biochemical result with this type of patient, we should always suspect PHPT in Indian patients because it is often misdiagnosed. Just now we heard Gaurav sir, and there is a very different scenario in India as compared to Western countries. We see patients with fracture, with maxillary brown tumors, with other swellings, nephrolithiasis, kidney damage. So all these history should be evaluated first. As classically we know that bones, stones, abdominal bones, and psychic bones, but other symptoms attributable to this hypercalcemia are anorexia, nausea, constipation, polydipsia, polyuria. So these symptoms should be asked. Then again, there should be, although it is not very common, but PHPT is associated with familial syndromes. So again, we should ask history and examine patient regarding that, multiple endocrine neoplasias and familial hyperparathyroidism syndromes, jaw tumor syndromes. So this is very important in history. Then again, examination will include, I think, PHPT affects each and every system of the body. So apart from neck examination, we should examine everything. And we heard this illustrative talk, what all can be affected by PHPT, like CVS examination, then musculoskeletal examination, genitourinary system, CNS examination to evaluate neuropsychiatric system. So all this should be examined whenever we are suspecting a PHPT.
Okay, thank you, sir. Sir, so the pertinent history in our patient didn't have any classical symptoms of hypercalcemia. When she was in first in OPD, there were no symptoms which were suggestive of any hereditary syndromes, including MEN1 or MEN2A. And family history was also not significant in this case. So when we did an examination, we found left maxillary fullness on general examination. There was wrist tenderness bilaterally, and there was scar on the hip, which was probably because of previous surgery. And there were, however, no neck masses and no neurocutaneous markers in this case. Okay, so very relevant physical examination and history you have told us. So I come to Dr. Priyamada Tyagi now, who's an endocrinologist. So in the wake of the findings that we have, so would you go for biochemistry again, considering that patient had serum calcium and PTH done some 2 years back? If yes, then what would be the relevant biochemistry? Or would you directly jump to localization?
Thank you, Dr. Sunil. First of all, thank you for the invitation to this wonderful panel discussion. So, considering the fact that we are clinically strongly suspecting primary hyperparathyroidism, we have prior biochemical evidence of PHPT. She has skeletal, musculoskeletal evidence. She has a maxillary swelling, which is probably an osteitis fibrosa cystica. Since the investigations were done 2 years back, it was probably not treated. Vitamin D deficiency was not looked for. I would like to repeat the biochemistry. So our basic biochemistry panel for a patient for whom I'm suspecting primary hyperparathyroidism would include an albumin-corrected serum calcium level. If it is possible, an ionized calcium level, along with ETH level, 25 hydroxy vitamin D. I would also like to do a serum phosphorus, a 24-hour urine calcium, and creatinine.
Okay, thank you, Dr. Priyamada. Okay, let us see what was done in this particular case. So we repeated serum PTH and it was grossly high, around 2000 picograms per ml. Corrected serum calcium was around 11.8 milligrams per deciliter. But unfortunately, patient had high creatinine also, around 4.7 milligrams per deciliter. And she was vitamin D deficient. So let me now go to our nephrologist, Dr. Mohammad Iqbal. So what do you infer from this biochemistry? Would you consider it primary hyperparathyroidism, secondary, or tertiary? Dr. Mohammad Iqbal.
As rightly pointed out, is that she already had history suggestive of a more likely a primary hyperparathyroidism. But she has severely elevated parathyroid hormone. She has elevated calcium.
I think your network is poor, sir. Hello, Dr. Mohammad Iqbal. I think we lost him. Kashish, can we get him back?
So we just try contacting him. You can move
Yeah,
on.
if we can switch over to some other network or some other device. Well, anyways, I can just say here that patient has very, very high PTH levels. Creatinine is high. Definitely there is some element of renal disease. But one thing that we have here is that serum inorganic phosphorus is low, which gives us an indication that patient is probably having primary hyperparathyroidism, unlike secondary or tertiary, where we can have high phosphorus levels. And also,
am I audible,
since,
Dr. Sunil?
yeah, you are audible. I have already talked of phosphorus issue, so you can take up some other issues.
Yes, the low phosphate level here is a clinching point. In presence of renal dysfunction, it points probably towards the presence of a primary hyperparathyroidism. And as the phosphate, this parathyroid hormone increases the renal excretion of phosphate.
So probably he wants to say there would be some element of phosphaturia also, which has led to this low phosphorus levels. So vitamin D levels in this case are low. So I think we can, there would be definitely some element of secondary hyperparathyroidism as well. So let us go further. I think his network is poor. So we further did an ultrasound abdomen in this patient, which revealed in right kidney multiple subcentimetric stones in upper and middle calyx. In left kidney, again, there were multiple calculi. And at left VUJ junction, there was an impacted calculus of size 1.5 centimeters. And of course, this was leading to left severe hydroureteronephrosis. Also, there was bilateral medullary nephrocalcinosis. So I come to Dr. Aanchal Kotwal. We have a rapid fire round actually with Dr. Aanchal Kotwal. So can you please tell us, would you do, if you get renal stones in your clinic, so when will you perform serum calcium in such patients?
Good evening, Dr. Sunil. Am I audible?
Yes, sir, you are audible.
Yeah, first of all, congratulations for organizing this webinar. This is one of its first of its kind in Jammu. So, and thanks for inviting me. Now, coming to your question, the indications of serum calcium in renal stone. Every stone disease which I treat in my clinic, I go for a basic serum calcium and parathyroid hormone assay. Because about 5 to 10% of the cases of stone disease turn out to be hyperparathyroidism cases.
Is it also for a single unilateral stone?
I go for that. Small single stone also I go.
Okay. So usually the indications, what we classical teaching is that bilateral renal stones, multiple renal stones, and recurrent renal stones, we must do serum calcium, but there are some individual variations which you can manage at local level. Okay, second question to you, sir. In this particular patient, would you go for a biochemical stone risk profile?
Basically, metabolic workup, if the patient has multiple renal stones, patient is looking like a case of primary hyperparathyroidism. There can be hypercalciuria also. So we will go for a metabolic workup of the patient.
Okay. So biochemical stone risk profile is also indicated when required. So he has impacted left VUJ calculus with a creatinine of 4.7. We have two surgeons, an endocrine surgeon and a urologist. So who operates first, you or the endocrine surgeon?
First of all, I will operate because the kidney needs to be decompressed and the kidney function whatsoever needs to be restored. Yeah, obviously, in this case, the kidney function is not deteriorating only because of the calculus. There is a component of parenchymal disease also. But before going for the removing of the stone, I would like to order one plain CT scan, just to see the overall burden of the stone, and if any other calculus is, if there is any evidence of other calculus impacting in the right side also. Because by ultrasound we are not getting what is the total burden of the stone. So first CT, then left URS.
Yeah, definitely. It's an excellent answer actually. So hyperparathyroidism in short term can mostly be controlled medically. So if you have any other renal intervention which can change the profile of the disease and lower the operative risks, we would like to perform that. So in this case, serum creatinine is 4.3. If we can bring it down to 1 or 2, it would be good for the patient because he has to undergo neck surgery. Okay, going further, this patient did underwent a left ureteroscopic removal of stone and left DJ stenting, following which serum creatinine fell down from 4.3 milligrams to 2.2 milligrams per deciliter. Okay, so again, coming to our endocrinologist, Dr. Tyagi. So we have now confirmed diagnosis of primary hyperparathyroidism. Now, just I want to you to tell the public and whoever is listening to this talk that whether you would go for any localization test before biochemical confirmation or not. Short answer, yes or no?
Okay, so of course,
No, it's
yes,
a short
because
answer. No, I'm saying localization before biochemical chemistry.
we already have biochemical evidence. Of course, there's a
Okay.
component of secondary hyperparathyroidism, but localization is important before proceeding ahead.
Yeah, okay. So in this case, we will localize, or otherwise, we need to be very wary of, we need to confirm our biochemical diagnosis before proceeding for localization. So what would you do?
So as we all know, there are 4 parathyroid glands, superior and inferior. The superior are more consistent in their location as compared to inferior glands. But up to 15% of patients can have ectopic location. So it becomes very important to localize the parathyroid adenoma before proceeding for surgery. Otherwise, it's going to be a problem. Most of if you have parathyroid hyperplasia, you will have a midline incision. But if you have the advantage of localization, concordant imaging, you can do a very small surgery.
What test? Audience,
so first thing is, the first thing is an ultrasound of the neck. It will tell us whether there is a single parathyroid adenoma. Of course, we have to remember that the size of the thyroid gland is going to play an important role in identification of parathyroid.
So in this case, indeed, we did an ultrasound of the neck and we found a hypoechoic, classically looking nodule.
Classical, yes.
Yeah, of size 3.4 centimeter. So this is thyroid here and it is just posterior-inferior to the thyroid gland. But there were some subcentimetric lymph nodes also, then they were in the central compartment on right side. The radiologist has given the report as query thyroid nodule, query parathyroid adenoma. So
this is a very common finding.
Yeah.
This is a very common thing because the thyroid will distort the anatomy of the parathyroid. It won't be equalized. So if the ultrasound is not very conclusive, we can proceed ahead with the technetium 99 system AB scan.
Okay, we indeed did a technetium 99 system AB scan. We did both early and 2 hours delayed images were taken, and there was homogeneous uptake in the right paratracheal region. It's actually delayed image where the uptake is persistent, and uptake was persistent in the region of left maxilla as well. So these are corresponding X-ray images of the maxilla where there was osteolytic lesions in the left maxilla, which suggestive of brown tumors. Okay, so I just want to know, can you tell us, the audience here, why do we actually need to do a system review? I mean, is it for any other reason?
That's right.
Yeah.
First thing, when we are interpreting a system AB scan, we have to interpret it carefully because a negative scan does not always mean there is no adenoma. It just means either it did not pick up or the scan was performed incorrectly. Second thing, even if the scan is positive, we still have to be sure that in some cases it cannot be concordant imaging. So the biggest advantage that a system AB scan provides me is that it confirms my finding of the ultrasound. If I have a properly visible nodule, a proper hypoechoic nodule in ultrasound, and there's a proper bright, beautiful uptake in my system AB scan, which is at the same location, then I can be pretty sure that, okay, what I'm dealing with is a single parathyroid adenoma.
Okay, so this was reported as a parathyroid adenoma on system AB. Now, one question that often comes to our mind is that we in India usually do ultrasonography first. If you have SPECT CT in your institution, would you like to do system AB SPECT or ultrasound followed by system AB? Like you are in a tertiary care institution in Delhi and you are getting a very good patient. So can we just avoid ultrasound altogether?
See, ultrasound, it depends on the operator. If my operator is not experienced, I'm not going to get a very good result. So in such settings, I think a 4D CT is a very good choice. It can provide me better anatomical delineation before the patient can go ahead with surgery. So I think it's a good option. If we have the availability, if the patient can afford it, of course, it's a very expensive test, then we should go ahead with it.
No, sorry, I think the question has been misunderstood. I was talking of system AB SPECT CT, not 4D CT. Yeah.
Okay, so system AB scan, we also had such thing. We also had an SDPGI. So with a system AB scan, there is a CT which is provided. In cases where you have an ectopic or the lesion is posterior and it cannot be seen on the planar images on the X-ray like we do in a system AB scan, in that case, a system AB SPECT CT will help us.
Now, let me tell here that there are various institutions which are doing system maybe SPECT CT as a first investigation, but this is mostly in the developed countries, and we in India mostly resort to two imagings. One functional imaging, which is system maybe scan, and other is anatomical imaging. If we find concordant findings on both imaging, we have a different plan of action, and if the findings are discordant or they are negative in any of these imaging, then our plan is different. We'll see it later how our plan changes. So what next? So do you, in this particular case now, would you do any further localization, or I think, or this much is enough?
I think we are having concordant imaging. The same lesion is seen on ultrasound and on the system maybe scan.
Yeah, okay, thank you. So quick question to Dr. Sanjay. Would you like to do BMD in this patient? Or if yes, whether 2-site or 3-site?
Okay, so may I add something to your previous?
Yeah, short answer. I require a one-liner. It's rapid fire round.
No, just I wanted to add something on utilization.
Go on.
So actually, we work in a setup where we do not have nuclear medicine facility. So first investigation we go for is 4D CT, but we have made it shorter version, which we call 2D CT. I mean, it has come from KEM Mumbai. So we do that, and we are getting good results. So coming to BMD, I think, yes, if you have facility, then definitely we can do it, because it can help us in categorizing the patients who will go in for, who will develop hungry bone syndrome post-operatively. And obviously, if we have facility, I will prefer all 3 sites, but we can do 2 sites as well.
Okay. So what is the importance of 3-site BMD? Why do we need to do radial BMD? This is what our audience wants to know.
No, actually, it is not actually required to do that in every patient, radial, but it indicates towards the severity of the disease.
Yes, exactly. So severity of the disease can be well gauged by the 3-site BMD, but it's a more specific thing, because parathyroid affects trabecular and cortical bones both, but it tends to affect cortical bone even more than trabecular bone. So you may not have findings in your axial skeleton where this 2-site BMD is characteristically done. So you can do a 3-site in those cases if patient is affordable. So Dr. Sanjay again, so would you recommend surgery in this particular patient? If yes, lap or open, and what would be your plan?
Yes, obviously surgery is indicated in most PHPT patients. Surgery is curable. So I would always recommend surgery, and that too without any delay. Again, I will prefer open only, because endoscopic parathyroid surgery is technically challenging. So for most surgeons, I would say open is better, because there is a learning curve associated with endoscopic parathyroid surgery.
Yeah, definitely.
And
the size is also large. Okay,
yeah.
what would be your plan? Surgical plan?
Yeah, so I will obviously I will plan focused parathyroidectomy, because both anatomical and functional imaging have localized the disease. Again, if anyone has intraoperative parathyroid hormone monitoring and frozen section, then that can be added.
Okay, why not BNE, bilateral neck exploration? Many centers are doing BNE routinely.
Again, see, here we have a well localized parathyroid adenoma, and there are no pointers that this could be a familial disease, a hereditary disease. So I don't think we will get much if we do bilateral neck exploration in this patient.
Yeah, definitely. I think patient is already has a lot of morbidities, and if we do bilateral neck exploration, when we have concordant imaging, we risk further morbidity in form of post-operative hypocalcemia or recurrent laryngopalacy. So focused exploration is going to be a better option in this case.
Yes.
I think most surgeons would agree. So coming back to Priyambada, how will you preoperatively optimize this case?
Okay, so here hydration with diuresis is going to be a little tricky because patient's creatinine is a little high. Similarly, bisphosphonates are out of question because at such a low eGFR, I would avoid giving bisphosphonates. So what is it? Calcitonin is an excellent option here. It starts action in 6 to 8 hours, and then you can give it for 72 hours without any tachyphylaxis. It needs to be given subcutaneously 3 times a day. I would also, in consultation with a nephrologist, continue adequate hydration because that is very important when you're taking the patient for surgery. In patient if the patient has very low 3-side BMD, then I would give him, I would give her denosumab, so that I would preferably give it much before surgery so that I can prevent post-op hungry bone and post-operative severe dip in calcium levels. But yes, so a proper hydration in consultation with a nephrologist, use of subcutaneous calcitonin along with denosumab is proper preoperative optimization of this patient.
Well, very rightly said. The patient has calcium of 11.8 and it can be very easily managed by diuresis, maybe saline or some drugs. So we may not have to use calcitonin, bisphosphonates, and cinacalcet in all cases. These drugs should be reserved when just to buy time for surgery. And if patient is having some severe manifestations of hypercalcemia. Okay, so this is, I think this should be clear now. So coming to Dr. Bhupinder. Sir, Dr. Bhupinder Singh, are you there?
Am I audible?
Yeah. Patient has a maxillary mass on one side and it is glowing up on system EB scan. So we are just planning surgery for her. So what would you recommend for this maxillary mass? We think it is osteitis fibrosa cystica.
Yes, actually, in these cases, we first look for the management surgically or medically by the U people. And sometimes it with that after the surgery and it's managed, when the parathyroid is managed, these masses will masses will dissociate with the time. But if we can also look the other symptoms like if there is a high parathyroid levels, we go for look to the pulse tones and mandible tories. If there are mandible tories and a pulse tones, and if there is a pain, then we have to intervene at the time before the parathyroid or parathyroid surgery. We have to intervene. Otherwise, after the surgery, we wait for 2 to 3 months and again go for the OPGs and the CBCTs or 3D reconstruction, whether what
Sir, are you there? I think the network is poor. Okay, let me just add to what he has said. So if you have a maxillary mass in the setting of primary hyperparathyroidism, I think we need to have our broad vision. We need to look at system maybe very carefully. If it is growing up, think of osteitis fibrosa cystica. If it is not growing up, just think of some other maxillary mass. We can have hereditary tumors, though rare, in primary hyperparathyroidism. So, and the pointers would be ossifying fibromas of maxilla, or there would be some other jaw tumors. And the condition is known by hyperparathyroidism jaw tumor syndrome. And it's a grave condition, usually associated with parathyroid carcinoma. But in our case, it is osteitis fibrosa cystica, so not very dangerous. It would eventually ossify. Dr. Bhupinder, are you back? No. Okay, we'll go to the next slide. So we opened up the patient. We tried to do a focused exploration, but ended up doing a unilateral neck exploration, Dr. Sanjay, because the gland was densely adhered to thyroid. So will you change your management intraoperatively now?
Yes, if it is densely adhered with thyroid, then I will like to remove that part of thyroid as well, because there could be chances of parathyroid carcinoma. However, it is very rare. It is often sought but seldom reported in histopathology. But as we say in parathyroid carcinoma, first surgery is best surgery. So if we have any iota of suspicion, that it could be a parathyroid carcinoma. So better to do en bloc hemithyroidectomy along with removal of parathyroid tumor.
Yeah, very excellent answer. I think the second reason should be there, like it should be because we don't want to damage a parathyroid mass for any reason. If we do hemithyroidectomy, it is going to be safer for the patient than to rupture parathyroid mass, so which can lead to parathyromatosis later and failed surgery. So let us see what we did. So we did actually en bloc excision of parathyroid mass with right hemithyroid. Plus, as I already said, that there were some lymph nodes. We did central compartmental lymph nodal dissection as well. So Dr. Priyamvada Tyagi, we had a suspicion of malignancy intraoperatively, but our histology came to be reactive lymphoid hyperplasia. So how would you react to it?
If it was parathyroid carcinoma, then I think you would have seen, first of all, biochemical indicators in favor of parathyroid carcinoma, that serum calcium levels are very high. So our patient only had a serum calcium level of 11.8. Such patients also present with the adherent big neck mass. They can also have other symptoms of weight loss. So based on history and biochemically, my suspicion of parathyroid carcinoma is not very high. Of course, when you say intraoperatively that you were thinking of parathyroid carcinoma, yes, of course, it is important. But then we have to think about, we have to keep this patient under follow-up. We have to see whether there is any recurrence. If there is recurrence, then my suspicion for parathyroid carcinoma would go even up.
And even for parathyroid carcinoma or for per se for any parathyroid tumor, we treat all of them in the same manner. We have to have, are very careful in handling those tumors. We prefer not to even FNA them. We prefer not to rupture them intraoperatively, even if it takes us 10 hours to do the surgery, though it doesn't take that much of time. So in our patient, we had intraoperative suspicion of malignancy. We had high PTH level, which was around 2000 picograms per ml, and significant bone and kidney involvement. So these were some factors which made us to do central compartment lymph nodal dissection intraoperatively. So these are some, so I just want to reiterate the fact here that sometimes preoperative plan is not the same as intraoperative plan, and surgeons have to make decisions according to the best interest of the patient. Okay, so we did intraoperative PTH also. So Dr. Sanjay, do you do intraoperative PTH routinely?
Okay, so I do not have,
yeah,
I do not have that facility here, so I do not do it routinely. And there is data that it is not required in all cases, especially in cases of well localized parathyroid adenoma and no history which suggests that it could be a familial. So IUPTH actually does not offer any extra advantage. However, most endocrine surgeons in India, whosoever has this facility, they do use it. So I think if one has this facility, they can use it.
Yeah. So in this patient, we had a significant fall, but it didn't reach normal. It was still significantly high. So can you think of any possible reason why it is still high?
Yeah, so as we saw in the history itself, this patient had kidney damage. So there is data that those patients, particularly Indian patients, their IUPTH falls very slowly. And we saw that beautiful presentation by Gaurav sir, where he depicted this phenomena. Yes.
So even if this fall was curative, it didn't reach normal criteria. So PTH may not fall instantly in patients who have a renal failure or a renal disease. It may take time. So the specimen was 5 centimeters in size. So this is the right lobe here, and this is the specimen. This one is the specimen, parathyroid. So quite big. So as already I said that it was an adenoma. There was no infiltration, no capsular invasions.
Don't put too much water, yeah?
Dr. Sunday, I think you need to mute for some time. The low mitotic figures. Okay, so we made the diagnosis of giant parathyroid adenoma. Now the question automatically goes to Dr. Sanjay when we talk of giant parathyroid adenomas, because he has done a lot of research in parathyroids and done some seminal research from India. So can you please tell us why we have in India such giant parathyroids, and what is the difference of the spectrum of disease in India and in developed countries, so far as histology and intraoperative these things are concerned?
Yeah, so again, our patients are very different than Western population. We see very severely symptomatic patients, and they have very high PTH, they have very high serum calcium levels. So these are a few basic differences. Then again, patients come in a stage when their tumor has become quite large. So this type of finding is very common. That you may even see a palpable parathyroid tumor, which is almost rare in Western population. So these are few basic differences between Indian and Western population. And because of this reason only, we suspect parathyroid carcinoma in our patients. But it is, again, the incidence is not high in our patients. These are classically PHPT patients only due to parathyroid adenoma. And same trend has been found from other developing countries as well, like Brazil, South Africa, China, and Turkey. There also they see patients in symptomatic stage. So yeah.
Sorry to interrupt you, sir. Sunil sir, we are running short of time, sir.
Okay.
Can I
So
request you?
Okay, sure. So in India, probably we need to relax a bit when we see giant adenomas. Not all giant adenomas are parathyroid cancers, though we need to follow them diligently. So this is probably my last slide. So what would be the post-operative considerations, Dr. Priyamvada? In our patient, we had hypocalcemia, and patient was put on oral calcium and vitamin D. So can you just tell me what can we expect in post-operative period?
So the first indicator that your patient is going to have post-operative hypocalcemia is preoperative low vitamin D, a very severe skeletal involvement, and a PTH level within 24 hours of surgery less than 15 nanograms per ml. So in such patients, you have to start them on prophylactic calcium, say about 500 milligrams to 1 gram per day. You can also give them about 0.25 to 0.5 micrograms of activated vitamin D. Such patients do tend to have lower depths of calcium. You have to monitor calcium serially. If your calcium drops down anytime below 7 milligrams per DL, IV calcium has to be instituted. You can give a bolus followed by a continuous infusion, which has to be titrated. As soon as orally your patient can take orally, you should start the patient on oral calcium along with activated vitamin D, along with vitamin D repletion, which must be started preoperatively. So hungry bone syndrome is one of the most common. You will have profound hypocalcemia. However, management is still the same. It will most likely resolve in, say, about 1 to 1.5 weeks.
Okay, so be ready for post-operative surprises as well. So hypercalcemia may resolve, but it may be substituted by hypocalcemia, hypomagnesemia, and other things, which we need to manage. So the patient has been operated recently, and she is on Chalcol and activated active vitamin D right now. So thank you. This was my talk. So just a contribution, I want to just, just dedicate this talk to Sir Richard Owen, who discovered parathyroid first in Rhinoceros unicornis, the great Indian rhino. Thank you very much. Over to organizers.
Thank you.
Thank you, panelists. Thank you, Dr. Sunil. That's an exhausted panel discussion. Few questions are there in the chat box. Because of short of time, like we are not discussing over here, I request the panelists to leave their answers in the chat box. So we'll move on to the next presentation. So I'll take immense pleasure to invite the chairpersons of the next session, Professor Reshma Kaushik, a Professor of Medicine, Himalayan Institute of Medical Science, Dehradun, Dr. Sanjay Dar, Consultant Surgeon, Jammu, Dr. Detiman Maitra, Breast and Endocrine Surgeon, GMC, Kolkata, and Dr. Smita Rao, Assistant Professor, Justice K.S. Hegde Hospital, Mangalore. Over to you, chairpersons.
Hello.
Yes, sir. Introduce the speaker.
It's a wonderful opportunity once again to be a part of the system which has started. And without wasting any more time, let me invite Dr. Vivek Agarwal. I mean, he needs no introduction as such. And sir, Dr. Vivek Agarwal, over to you. Is
Hello.
Dr. Vivek?
Hello. Good evening. Am I audible?
Yes,
sir. Yes, sir. Good evening, everybody. And thank you, Dr. Sunil and organizers for having me here. And it's a wonderful discussion going on, and much has already been spoken about the topic I'm going to talk. It's about hyperparathyroidism, surgeon's perspective. Next slide. So as the name suggests, it is excessive secretion of parathyroid hormone and can be broadly categorized into primary hyperparathyroidism, which basically means calcium insensitive hypersecretion of parathyroid hormone. Secondary hyperparathyroidism is a response to various stimulating factors like low calcium, high phosphorus, low vitamin D, with or without chronic kidney disease. And tertiary hyperparathyroidism is classically associated with chronic kidney disease and can have normocalcemia or hypercalcemia. Next. And there are two more entities which have been described. One is asymptomatic hyperparathyroidism. As the name suggests, most of these presents are having no clinical symptoms, but may have some biochemical evidence of primary hyperparathyroidism. And another entity, just previous slides, another entity which have been described is normocalcemic primary hyperparathyroidism by Mather. And this basically includes patients having normal calcium in presence of a raised parathyroid hormone, and there may be intermittent rise of calcium. And we have to rule out secondary causes like vitamin D deficiency and all to establish this entity. And people say it is basically early stage of primary hyperparathyroidism. So whether this is a separate entity or a primary hyperpara in evaluation needs to be further studied. Next. So looking at the spectrum of this disease in India, as Dr. Gaurav has described, we have presentations, lab-detected hyperparathyroidism, totally asymptomatic, to severe symptoms like multiple fractures, end-stage renal disease, pancreatitis, hypercalcemic crisis. As you can see in this picture, this gentleman lost 1 feet height due to primary hyperparathyroidism, leading to severe osteoporosis, microfractures in the spine, and was detected after he was evaluated for this loss of height. Next. And then much has been said about this severe bone disease by Dr. Gaurav. You can see patients having severe fracture, osteoporosis, and a large parathyroid adenoma. So this is the extreme spectrum of disease. Next. Syndrome of disappearing bone, already described by Dr. Gaurav. So completely disappearance of the cortical mineralization, and you can appreciate post-surgery demineralization is in the right-hand side pictures. Next. So primary hyperparathyroidism has to be treated surgically in all symptomatic patients. Asymptomatic patients, if there are indications like significant hypercalcemia, falling GFR, decreased bone density, and young patients. Details will be discussed in the subsequent talk. I'll just touch upon this. And then secondary and tertiary hyperparathyroidism, surgical indications are when PTH level is more than 500 after correcting the stimulating factors and medically treating adequately. Or if there is high calcium along with high phosphate, leading to a high calcium phosphate product to more than 70. If there are complications like calciphylaxis and organ damage like bone fracture, pancreatitis, etc. Next. So for the sake of management, these clinico-pathological entities can be primary hyperparathyroid clinico-pathological entities can be broadly divided into sporadic PHPT, familial PHPT, and secondary and tertiary hyperparathyroidism. And sporadic generally are due to either a single adenoma, multiple adenomas, parathyroid hyperplasia, and carcinoma. Familial disorders are broadly categorized into eminent syndromes, non-men or familial isolated hyperparathyroidism, hyperparajaw tumor syndrome, and neonatal hyperparathyroidism. And these are categorized so because they have significance on the plan of management. Next. So surgical extent will depend on the clinico-pathological entity we are dealing, and it can vary from single gland excision to multiple gland excision, total parathyroidectomy, along with cervical thymectomy, and at times we have to autotransplant part of it. So these will describe where to use which procedure. Next. So coming to sporadic primary hyperparathyroidism in a well-localized gland, as we have already discussed, minimal invasive parathyroidectomy, or we also call it focused parathyroidectomy, is the treatment of choice. Sporadic primary hyperpara, where there is where localization is discordant or not, or no localization has been done, or you're suspecting hyperplasia, then we resort to subtotal parathyroidectomy or total parathyroidectomy with autotransplantation of part of the gland into forearm. For familial disorders like MEN1, subtotal or total parathyroidectomy with autotransplantation is done, and cervical thymectomy has to be added with both these procedures. This will ensure any ectopic rests in the thymus are being taken care of, and also association of carcinoid, which is found in MEN1 syndrome. MEN2 has got a relatively less penetration, and you can opt for a selective parathyroidectomy or total parathyroidectomy with autotransplantation if you are contemplating a thyroid surgery later on, or a recurrence when there is an association of medullary thyroid carcinoma. Next. Neonatal hyperparathyroidism is a severe form of hyperparathyroidism because of CSR gene mutation, and the recurrences are very high. So we have to do a total parathyroidectomy along with cervical thymectomy, and we do not autotransplant the tissue because most of the time minor ectopic rests which are still left take care of the parathyroid needs. Then hyperparathyroid jaw syndrome is another special entity which is high incidence of malignancy, and hence we have to be careful during parathyroid surgery. We may have to do additional hemithyroidectomy and nodal dissection. Secondary and tertiary hyperparathyroid have to be treated as a multi-gland disease. So you do a subtotal or a total parathyroidectomy with autotransplantation. Both these procedures, subtotal versus total, have their own advantage and disadvantage. Subtotal, you're likely to leave a well-vascularized gland, so chances of post-surgery hypoparathyroidism are less. Whereas in total, the advantage is that you implant it in forearm, from where you can take care of these glands whenever there is a recurrence. Easily, these can be tackled in the forearm rather than reoperating in the neck. Next. So various surgical approaches which we use for tackling these glands are minimal invasive parathyroidectomy using a small incision, which is called as focused parathyroidectomy, then endoscopic or remote access, as Dr. Bhargav described, but there is no neck incision, and the incisions are given at a remote site. Then there are conventional approach for multi-gland disease or non-localized parathyroids, and video-assisted thoracoscopic surgical approach for mediastinal tumors. Next. So So MIPS has already been discussed a little bit by Gaurav and previous speakers. It is basically removing a well-localized gland through a small incision in the neck. Advantage being better cosmesis, less tissue dissection, less pain, can be done under local anesthesia, and hospital stays shortened. And prerequisite, as we have been discussing multiple times, is unequivocal preoperative localization, at least by one nuclear and one radiological image. And absolute contraindication, of course, is multi-gland disease. Next. So various preoperative localization studies have been described. Primarily, we do a high resolution ultrasound combined with MIBI scan, or occasionally, if we have facility, we can do MIBI SPECT, which can take care of both the nuclear and the anatomical localization. Next. If these imaging don't help, then we have newer modalities which are more promising, like 4D CT scan and PET scan using fluorocholine and methionine. And it has been helpful in, or as a troubleshooter, it has been helpful in localizing the glands which were not found on the conventional imaging. Next. So I'll just demonstrate a small video of how we do focused parathyroidectomy for a well-localized gland. So a small incision is given right over the identified gland. Flaps are raised. Is the video clear?
Yes, sir.
So what we are doing is we've raised the flaps. We are now taking a lateral approach in between the sternocleidomastoid and strap muscles. So we separate the deep cervical fascia and closing them. And then we've identified a middle thyroid vein. So we'll just ligate that so that we can lift the thyroid aside. And we can now directly approach the parathyroid and do a fine dissection without damaging the capsule. So you have to be careful in handling the parathyroid glands. And you have to work close to the capsule so as to avoid injury to any vital structure, especially the grand-laryngeal nerve. And it's a minimally edited video, so you can actually see it's a very quick procedure. Can be done under cervical block and local anesthesia, provided you are versed with handling of the gland and the anatomy. And you can see the gland is out. So this incision was a little larger for demonstration purpose. Otherwise, we can manage with even half the size. And patient is up and about in an hour of surgery and ready to be discharged same day if the calcium issues are tackled orally. So intraoperative aids, when you do these kind of procedures, it is always good to have frozen section with you and IOPTH. Much has been discussed, so I'll not go into detail. Next. But most important thing I would stress is having an experienced parathyroid surgeon as intraoperative aid. And why so? I'll dwell upon that next. If you look at these images on the top right, you see situation where you have a parathyroid gland, a thyroid adenoma, a lymph node, a fatty tissue, fibrofatty tissue, all lying alongside, and you have to have an experienced parathyroid surgeon to identify the parathyroid gland in such a situation. And if you look at the right top image, so this is the left top image, you see intrathyroidal parathyroid. So again, a surgeon should not get perplexed when it doesn't find a parathyroid in the topic position, your normal positions, and one has to look for utopic positions like intrathyroid, parathyroid. Then on the bottom right, you see an image of parathyromatosis. So if you are not versed with handling the gland properly, you can create such a situation for the patient, wherein patient can have multiple recurrences, and tackling these recurrences again needs expertise. And occasionally a parathyroid cyst, as seen in the left lower image, can perplex the surgeon when you are actually looking for a solid kind of a gland. Next. Then another situation challenging for a surgeon who is not versed with parathyroid surgeries is neonatal hyperparathyroidism. Identifying these rice grain size parathyroids in very small neonate 6 weeks old with other, you can see multiple morbidities is itself a big challenge. And then perioperative management, of course, needs a teamwork. Next.
Sir, apologies, sir. So can I request you to go through it? We're running short of time, sir.
So this is again a large adenoma. You can confuse it with the thyroid nodule. Next. And of course, ectopically placed mediastinal parathyroids with discordant images. Again, you need expertise. So that is why I always say it is important to have a expert parathyroid surgeon localizing rather than localizing the glands. Next. So a small clip of endoscopic parathyroidectomy or remote access. Bhargav was already described for thyroid. So various approaches are anterior chest approach, next the axillary approach, next the breast approach, and a combination of these next. So small video to show how we did using a combination of all these approaches. We put incision, one in the axilla, one in breast, and one in anterior chest, and we introduce a scope through one of these incisions, raise a subplatysmal flap, and then rest of the dissection is as we do for any thyroid or parathyroid surgery in open surgery. So you reach the midline, separate these flaps, try to identify the thyroid lobe, and as you can see, we have reached the lateral space, and here we can confuse with the thyroid nodule. So you can see along with the working instrument, there is a thyroid nodule, which initially confuses as a parathyroid gland, but on further exploration, we could identify the parathyroid. And then this is to be gently dissected, and if it is small, it can be delivered through one of the scopes easily. Next. Next. So this is the beautiful scar. Next. So this is a ectopic mediastinal parathyroid located in the posterior mediastinum. Next. I'll just show a quick next. So identified on scans, MRIs, patient was carrying these from outside. Next. So small video clip edited how we approach this. So single lung ventilation, you could see superior vena cava and the tumor lying just behind this. So mediastinal pleura is dissected. Tumor is then excised gradually, carefully all around, then delivered through one of the chest ports. Hemostasis is ensured. So a quick view of VATS procedure. Next. Conventional foregland exploration, you have to explore the whole neck right from angle of mandible till manubrium sterni and as deep as possible. Bilateral carotid sheaths, retrotracheal, retroesophageal positions. Next. And in subtotal parathyroidectomy, you leave behind a small portion of the gland equivalent to a normal gland on a well-vascularized pedicle, preferably away from the nerve. And you have to mark it with a metallic clip in case you need to re-explore that. You can identify that. Some people also place this over these straps if there is a long pedicle. Next. And when you remove all the 4 glands, then you need to auto-transplant a part of it in the forearm, brachioradialis. 1 millimeter pieces are made of one of the most normal looking glands, and 7 to 10 pockets are made in the muscles and implanted. Next. So as I described, in severe cases like neonatal severe hyperparathyroidism, we have to do a total thyroidectomy along with cervical thyroidectomy. And identifying all glands is again really a big challenge. Next. Post-operatively, you have to be careful about falling calcium in cases having severe bone disease and hungry bone syndrome. Most of the early stage diseases can be managed by oral supplement of calcium, but you have to keep a watch on for hypocalcemia. Long-term management needs calcium supplementation, monitoring by DEXA. BMD has to be done at frequent intervals. You have to follow up for recurrences and address renal stones and other syndromic association in cases of familial disorders. Next. So with this, I would just give a take-home message that this seemingly simple disease and simple surgery is not so simple. Identifying the glands, holistic management, and all needs expert a parathyroid surgeon who does frequent parathyroid surgery. So instead of focusing on localizing the glands, all my colleagues should focus on identifying a good endocrine surgeon. Next. So with this, I thank you all, and any questions I'll be happy to answer. And thank you, Sunil, for giving me this opportunity. I acknowledge my teachers from SGPJ, Dr. Gaurav, Dr. Amit, Dr. Anjali, Dr. Mishra, who taught me the skills of handling parathyroid surgery. Thank you.
Thank you, sir, for your lovely lecture. There is no question in the chat box, so I think we'll go over to the next session. Over to Dr. Vishwak and Dr. Mattu to continue with the next session, please.
Thank you, sir. That's an excellent presentation and a wonderful video of operative technique. Now we'll move on to the next session. Since we are running short of time, I would request the chairpersons to encourage the speakers to keep that session short and crisp. So with warm regards, I would like to invite the chairpersons of the next session, Professor Rajinder Singh, Professor of Orthopedics, GMC Jammu, Dr. Suman Gopal, Assistant Professor Endocrinology, GMC Jammu, Dr. Priyamvada Tyahi, Consultant Endocrinologist, Max Hospital, Delhi, Dr. Goon Jori, Assistant Professor Endocrine Surgery, AIMS Raebareli, and currently a Specialty Fellow at NHS UK. So we'll move on to the topic of asymptomatic hyperparathyroidism. I request the chairpersons to introduce the speaker. Over to you.
So welcome to this session. For this session, we have one of the most experienced people in this matter. We have Dr. Roma Pradhan with us. She's Associate Professor, Head of Endocrine Department and Breast Surgery at RML Institute of Medical Sciences, Lucknow. She has had multiple awards. She has won multiple papers, scholarships, and she has special robotic thyroidectomy training at Seoul National University in South Korea. So without further ado, I would like to invite Dr. Roma Pradhan.
Yeah. A very good evening to all. At the outset, I would like to congratulate Dr. Sunil and his team for such a wonderful idea of Masterclass in Thyroid and Parathyroid, first of its kind in Jammu. And definitely we need to spread awareness as endocrinologists and even as endocrine surgeons about this parathyroid disorder especially. So I've been given the task of asymptomatic primary hyperparathyroidism. So what we see in our OPD patients are symptomatic patients who come to us on wheelchair, crippled patients with brown tumors, fractures, brown tumors of the maxilla or mandible, then pancreatic calcifications, nephrocalcinosis, and even PHPT masquerading as rickets in children. But in Western world, it's the disease of the asymptomatic PHPT. So you can see in this the chart, now around more than 80% of the patients have no overt symptoms. So basically, asymptomatic PHPT is a disease of postmenopausal ladies. So before I start with the definition and my talk, I would like to present a case scenario. A 50-year-old lady presented to my OPD with a breast lump. We had planned for a wide local excision for some reason. So on pre-op investigations, her serum calcium was found to be high. So we evaluated her further on line of raised calcium, and we found that her intact PTH was raised and phosphorus was low with low vitamin D and normal creatinine. Hence the diagnosis of primary hyperparathyroidism was made. So we end up doing the end organ effect investigations with BMD, 3-side DEXA scan, which was found to be low, and renal ultrasound showed no nephrocalcinosis or any renal stone. Hence, we planned her for surgery. So for surgery, we went for localizing investigation of ultrasound and MIBI scan. I don't have the ultrasound images right now, but they were concordant. So in MIBI, you can see in the delayed image, you have a small uptake in the upper superior gland. So we took her for focused parathyroidectomy. A 1 centimeter tumor was removed, and intraoperative PTH dropped, had a curative drop of more than 50%. Hence, the patient was cured of the disease. So this was a case of asymptomatic PHPT, which we are now seeing. But of course, they are very less in number, as already mentioned by Professor Gaurav, are less than 6% of what we see. So coming to the formal definition, the term asymptomatic primary hyperparathyroidism was actually introduced to describe patients which lacked obvious signs and symptoms referable to either excess calcium or parathyroid hormone. What about the biochemical profile? So it's similar to overt PHPT, just the values are a little lower, like calcium and PTH little lower than the overt PHPT and phosphate little higher. So there's certain issues which we need to see for asymptomatic PHPT. This is asymptomatic really an asymptomatic disease? What are we actually dealing with? What is the natural history of asymptomatic PHPT? What are the benefits of the surgery in these asymptomatic patients? And what are the complications of surgery and criteria for surgery? So coming to the first point, that is asymptomatic really asymptomatic? This is an old study from Mayo Clinic which mentioned that around 50% of the asymptomatic patients had evidence of renal stone. You can see the percentage of symptomatic, the percentage of disease in these patients. Another study from Italy also showed the presence of kidney stones in around 35% of the patients, and also vertebral fractures around 35% in these asymptomatic patients. A very interesting study done in UK about the record linkage study. So they also found that these cases of PHPT, they had high all-cause mortality and also the fatal cardiovascular disease mortality as compared to the controls, and non-fatal cardiovascular disease also. So there's a list of outcomes and events that happened in the study. So all were higher in cases. What is the natural history of PHPT? In this study, 49 patients with asymptomatic disease were followed. So this is a pretty long follow-up they have of 15 years. 37% of the patient actually progressed and they underwent surgeries. Now, before we advise surgery for the patient, we need to be convinced ourselves as to why are we offering surgery to the patient and is it necessary in these asymptomatic patients. So even for asymptomatic patients, parathyroidectomy halts or even reverses the classic negative effects of the disease, like decrease the risk of nephrolithiasis, improves the bone mineral density, and also improves the quality of life. So number of randomized controlled trials we can find in this subject. So all point towards improvement of BND and quality of life and also psychological functions. This another important study which also underscored the importance of surgery was Suresh study, which brought about that More vertebral fractures occurred in observation group, again emphasizing the importance of curative role of parathyroidectomy. Similar study, they also showed improvement in BMD and quality of life. Now, besides having beneficial effects on BMD, patient has a protective effect on even kidneys, and this was well demonstrated by the study from Singapore. So basically, we are just worried about the complications of the surgery in these asymptomatic patients, that we should not do any harm. So just to emphasize on this, we are more concerned about the elderly patients undergoing surgery for PHPT. Now, this study by Palestina et al., they analyzed 898 patients, out of them 135 were elderly, and they found no difference in any major cardiovascular, neurological, respiratory, or metabolic postoperative complications, which are actually what we are concerned about. So coming to the indications of surgery, the criteria. So NIH has given various guidelines since the 3 decades, and they have been changed a little bit all the time. So we'll just discuss each criteria very briefly. So serum calcium is the first point. So surgery is recommended for patients with serum calcium more than 1 milligram per deciliter. This criteria has been followed since 2002, and it is based on the consensus that hypocalcemia above this threshold increases the risk of disease progression to symptomatic PHPT. So if we are following these patients, we need to monitor them with serum calcium annually. Coming to the second point of skeletal, T-score less than -2.5 on 3-site DEXA. So as already mentioned during the panel discussion about the 3-site DEXA scan, the forearm is more important because of the cortical loss, which is first evident at the radius. Very interesting fact in this is, we all know it's a 3-site DEXA that is important, but still only 45% of the patient of PHPT had radius evaluation on DEXA scan. So now we have new recommendation to add to this to evaluate patients with asymptomatic PHPT for vertebral fracture. These are active investigations that we need to do, like radiographs, CT, MRI, vertebral fracture assessment. In a study, the patients who met the surgical criteria, the risk of vertebral fracture was 28%, while in patients who do not meet the surgical criteria, it was 11%, whereas in the normal population, it was only 2%. So you can see the high risk of vertebral fracture these patients have, even if they are not for the criteria for surgery. So the new kids on the block are the trabecular bone score and HRQ-CT, which tells us about the micro structure of the bone. So patients with asymptomatic PHPT, they need to undergo DEXA every 1 to 2 years. That is the 3-site DEXA. Coming to the renal criteria, we have the 3 renal criteria. First is the creatinine clearance less than 60 ml. So it is actually said that if the clearance decreases to less than 60, patient is landing up in chronic kidney disease 3rd and 4th stage, and hence the PTH and calcium will rise. However, it does not rise until it drops to further 30 ml per minute. But still, however, it is associated with altered bone remodeling, suggesting that impaired renal function may negatively impact bone health. The second criteria is the 24-hour urine calcium greater than 400 milligram and increased risk of urinary biochemical stone risk analysis. Initially, this factor was taken as standalone of 24-hour urine calcium greater than 400, but now we have to take it together with the risk analysis for stone formation, which was also mentioned during the panel discussion. So 2013 guidelines recommend patients diagnosed with asymptomatic PHPT should undergo active renal imaging to detect subclinical nephrolithiasis or nephrocalcinosis. As we can see, I already mentioned this study before in my previous slides. The kidney stones, the incidence is about 35% in asymptomatic patient in this study. So patients who do not undergo surgery, they should be encouraged to maintain adequate hydration. And these patients should also receive annual laboratory testing of estimated GFR and creatinine. Coming to the age, so age younger than 50 is a criteria for surgery, and patients who do not meet surgical criteria aside from the age, they also progress. That is 27 to 62% of the patients will progress to meet surgical criteria in 9 to 10 years. So this is how the disease actually, which is called as asymptomatic, is not so asymptomatic. So before I conclude, just a slide about normocalcemic PHPT, because this is often confused with asymptomatic. However, normocalcemic PHPT is defined as persistent fasting normocalcemia associated with increased serum PTH concentration. And these patients are usually diagnosed during the laboratory evaluation of either a decreased BMD, a fracture, or an episode of nephrolithiasis. So basically, patients have symptoms, they come to you, and then you evaluate them, and then you find a normal calcium level. So it is anticipated that these patients may have milder form of disease as compared to overt PHPT. However, majority of the case series suggest high rates of bone loss, fractures, and nephrolithiasis in these patients. So how do you manage this normocalcemic PHPT? The management depends upon the presence of features of the disease. The patient has disease features, of course, you go for surgery. And in the event of progression to hypercalcemic PHPT, the guidelines of asymptomatic PHPT should be applied. Hence, to conclude, patients with primary hyperparathyroidism are deemed to be asymptomatic by classical criteria. Accumulated retrospective and prospective evidence, which I have showed you in my talk, that the majority of these patients suffer from vague, non-specific complaints that are still very real and can improve after parathyroidectomy. And parathyroidectomy in patients with these asymptomatic has been demonstrated to improve bone mineral density, reduce fracture risk, and improve health-related quality of life. Hence, all patients with primary hyperparathyroidism should be referred for surgical evaluation to an experienced endocrine surgeon. Thank you all. Any questions I would like to take up?
Thank you, Roma ma'am, for that wonderful presentation. If it's all right, if I can just ask you one question. During your literature search, did you find any difference in the pathology of these patients who underwent surgery? Are there higher cases of hyperplasia as compared to adenomas than what we see for symptomatic PHPT? I'm asking because currently the center that I'm working at, they see a lot of asymptomatic and patients with very mildly elevated calcium and PTH, very mild symptoms. And a lot of them, when they undergo surgery, turns out to be a hyperplasia, not adenoma. So is there anything?
So a very good question indeed. So these patients usually have low PTH levels, as we know, because this is the initial start of the disease. So the natural history, these diseases first progress from asymptomatic, and then we have the overt. So of course, these patients, but hyperplasia, as we know that the PTH levels are not that high as compared to the adenomas in hyperplasia. We usually have a lower PTH level. So maybe that is the reason that your center finds those findings. Otherwise, the adenoma rates will be same that we get in the routine overt PHPT.
Mujam, can I respond to it? I think
Yes.
there is some recent publication that normocalcemic PHPT has been identified as a separate entity altogether, apart from overt PHPT. I mean, the natural course is that PTH will increase, calcium will increase, but there is a separate entity as well. And in such an entity, they have more symptoms. They have renal stones, but they have hypoplasia. Such patients have hypoplasia.
But my
Dr. Sunil, you were talking about normal calcemic PHPT.
Yes,
that is a
normocalcemic.
different entity from the asymptomatic
My question
PHPT.
is for established
Yes,
hyperparathyroidism, but the asymptomatic group or the mildly elevated calcium group with not such.
Basically, normocalcemic, these are not asymptomatic because they usually come to us with symptoms. Only then we detect them.
Exactly. Yeah, that's a separate entity. My question was specific to patients who had asymptomatic. Thank you, Roma. Thank you.
So If there are no more questions, then shall we move to the next session, ma'am?
Thank you so much.
Thank you, ma'am. Thank you, chairpersons. So now we'll move to the next session from Diaries of an Author, Economist, Analyst, and a Parathyroid Awareness Leader. Now I take immense pleasure in inviting the chairpersons, Dr. Sabaratnam Mailvahanan, Associate Professor of Endocrine Surgery, SGPGI, Lucknow, Dr. Mahalakshmi, Assistant Professor, Endocrine and General Surgery, Deccan Institute of Medical Sciences, Hyderabad, Dr. Sunil Mattu, Consultant Endocrine Surgeon in Jammu. So over to you, sir.
Thanks, Dr. Vishwak. And at the outset, I congratulate Dr. Sunil and all the organizers for debut century like Shreyas Iyer. And to introduce Ms. Rochelle Lambres, she is our distinguished speaker and guest, and her alma mater is London School of Economics and Political Science, author, poetess, economist, parathyroid awareness leader, social activist, and hyperparathyroidism awareness leadership role she has taken. And that group in Facebook has 6,400 members, which was started in March 2017. Over to you, ma'am. And thanks for accepting my friend request in Facebook during this conference. Thank you again.
Hello, everyone, and good evening to you all from Athens in Greece. My life changed in December 2015. All the apathy that had overtaken me in the years before surgery had disappeared, and for the first time ever, with fear and trepidation, I joined a patient support group on Facebook. I felt I was in a new world, that I'd landed on a new planet, paraplanet as I often call it, a land where everyone knows about the parathyroid and the suffering it can cause. I was totally overwhelmed. I realized that the sufferers faced the same problem the world over, the battle to be listened to, the battle to be treated with respect, the battle to find a knowledgeable doctor, and the list goes on. My passion was born. For almost 6 years, I've been immersed in the world of hyperparathyroid patients and have learned much from their experiences and from extensive research on the associated issues. Together with our dedicated admin team, we continue to help and support many people every single day. When I first started the group, there were certain things I wanted to set in place. I personally was always put off if I saw a site or a group asking for contributions or selling certain items with their logo. This is why we have very clear disclaimers about being totally independent and not having or wanting funds. The members of our admin team have been carefully chosen. We are united in our desire to help people with this insidious disease in any way we can, and we work well together. We live in different time zones, which means that nearly always someone is available to deal with any issues that may arise. What happens when someone has applied to join and is approved? We try to create a warm atmosphere so that newcomers immediately feel they are among friends. You can see an example of one of our welcome messages. Many members add some words of welcome too. The group has several different sources of information which can be confusing for new members. The roadmap, called Getting Started, is a simple and practical guide to help them find what they need. The files, for example, mainly contain links to research articles or other information deemed important. The topics group together members' posts on subjects of interest. For example, we have one called Voice and Vocal Cord Issues, another called Children with Parathyroid Issues, and many, many more. At first, we didn't have a set of rules, but we found they were necessary to help people understand what is or isn't permissible and to justify removing unsuitable comments, links, or posts. In the early days, with only a handful of members, newcomers were often reluctant to post their stories. But now, after seeing the incredible interaction between members, newcomers usually rush to share their experiences and unburden themselves. Our wonderful members respond with empathy and support to help the member feel part of the parafamily. The members usually relate aspects of their personal experience, explaining, for example, how they dealt with certain symptoms, why they had to keep changing doctors, the difficulties of getting diagnosis, the guilt they felt about not being able to care for their families or homes as before, the problems associated with their professional life. New members often mention the relief they feel knowing they really have arrived in the right place where they are understood and offered hope. This slide explains several reasons justifying the need for a support group. All are important, but one of the saddest things that we often see is that loved ones do not believe that the patient is truly suffering. Relationships and self-esteem are impacted. This is the curse of an invisible and little-known illness. We now move on to the kinds of support offered. This group has a wealth of information which has been built up over time and is continually growing. However, some members rarely read the articles available and rely on the interchange between the patients for help and advice. The patient's experiences are perhaps the most revealing source of all, since they contain things not found elsewhere. I think an outsider would be astonished to see the kind of deeply personal discussions that take place within the group. These discussions are taken very seriously by all concerned, since the behaviour and incidents described are a result of the horrific impact this disease can have on the mind as well as the body. Much more research needs to be carried out on this. I always feel the need to reassure the sufferer that it is the disease which causes them to act in this way, and the real person inside has not changed and will re-emerge following surgery. And when this does happen, it is a truly emotional moment for everyone. Members need to feel that the environment is safe in order to share personal information, which can include relationship issues, desperation, crisis of rage, addiction, abuse, violence, etc. Practical support of all kinds is available. A member only has to ask, and a multitude of suggestions will be forthcoming. Our one-page guides were created in response to a specific need for people joining the group with little or no knowledge of the disease and information about how to move forward. They cover a very basic description of the disease, tests and scans needed for diagnosis, criteria regarding choice of doctors, and a post-op checklist with information useful after discharge, which should be provided by the surgeon, but sadly often isn't. And despite this checklist being posted every single week, many members still turn to the group for advice and suggestions when they have problems. We always advise them to contact their surgeons or their endos, since we cannot offer them specific advice about the signs of tetany, and we tell them to rush to the ER if they have such symptoms. The absence of input from their doctors in the post-surgery period is of great concern. The recommended lists of surgeons and doctors are categorized geographically by country, state and town, and are very easy to use. Very often, patients consult these lists to find good surgeons and doctors in their area to avoid having to travel. The lists are growing and are regularly updated. Now let's turn to the other side of the coin. Doctors can learn a lot from their patients by paying attention to the whole picture that the patient presents with, including all their symptoms. Unfortunately, many doctors in this field are stuck in the past with outdated guidelines, acknowledging a limited range of symptoms and uncomfortable with diagnoses of normocalcemic or normohormonal hyperparathyroidism. I would imagine that if doctors diligently followed the cases of some members, right from the days where they were struggling to get diagnosed, seeing how their lives were affected in so many ways, following their progress through surgery and recovery, and finally regaining normalcy, they would learn so much and perhaps reflect on their approach to this disease. I hope that some of the topics covered in this webinar will cause some doctors to want to learn more about the disease. Diagnosis can be very challenging, to say the least. Now, how can doctors themselves try to raise awareness? Well, I believe you are in a privileged position. As doctors, you are respected, and people are more likely to pay attention to what you say. In addition, you probably have contacts, even in the media, who you can use to get publicity. And don't ignore the internet. Use it to share articles, videos, and interviews about hyperparathyroidism. I am certain that virtually all of you know many people in the medical community who, unbeknown to them, come into contact with patients who may have parathyroid issues. Just think of the possibilities here. If, for example, dentists, psychiatrists, gynecologists, to name but a few, could pick up on certain symptoms and suggest their patients get tested, I believe many cases would be detected at an earlier stage. Here I have to explain why our list is so long. We have the following criteria for what we believe should be considered a symptom of hyperparathyroidism. If a symptom improves or disappears following curative surgery, it should be considered a symptom. I know many of you will not agree with this, but please study this list carefully. All of these symptoms are mentioned frequently. Here there are just a couple of comments posted by patients, but they are typical of what we hear. The way patients are not believed when they relate what they're going through. The way some doctors don't seem to know enough to be able to help the patient. And the way many members become determined to raise awareness. This slide is about the role of the doctor in the group. He or she should listen carefully to what the members have to say and offer guidance where appropriate, always maintaining a discreet presence. Doctors who have joined the group begin to learn things that they don't usually hear from patients during consultations. They start appreciating the disease from the patient's point of view. I cannot emphasize enough how important this is. This discreet presence is vital because nothing must occur to threaten the integrity of the group. And, as is mentioned, there are many people in the group who have had bad experiences with doctors. This may be hard for you to believe, but unfortunately, it is true. I think this slide is my favorite. It's about where we were, where we are now, and offers hope for the future. At the beginning of all this, when I was really despondent because things were tough and we didn't have many members, a very dear friend of mine encouraged me, saying, "Today you are planting the seeds, and one day they will bloom." And she was right. Thank you for the invitation to talk to you this evening. I'm sure this webinar will be a huge success. On a final note, I want to take you back to how it all started. Eureka. In the year 1852, a rhino died in London Zoo. The search for a secret gland commenced, but no one realised what this meant. In the neck, 4 glands were found. Eureka! Shouted those around. But it took some years to understand that calcium is regulated by these glands.
Sir, Dr. Sabaratnam, sir?
Yes, Sunil.
Sir, you have any comments to make?
See, I thank Ms. Rochelle Lambres. Actually, this is a wonderful initiative. And for all young endocrine surgeons, we learn from the patients, as Madam has rightly pointed out. And if you see as a researcher and a teacher, like 6,400 patients in a single Facebook page. So that's a big potential. Like if anybody wants to do any research, any kind of research with patients who are suffering from PHPT, that's a very, very good initiative. And I really congratulate you for especially incorporating this talk in this CME. Thank you.
I also thank Ms. Rochelle Lambres for joining us today and for this wonderful talk. In fact, when I saw that group, I saw that she has seen much more number of patients than any doctor in this group. So we have a lot to learn from patients, as rightly said by Dr. Sabaratnam also. Thank you very much, Ms. Rochelle, for your wonderful talk. So I have an announcement to make here at this point. Dr. Rajgopal Shenoy, who is a professor of surgery, KMC Manipal, ex-HOD KMC Manipal, and ex-associate dean KMC Manipal, a surgeon and an academician of international repute, and author of many textbooks of surgery. Probably he has mentored us all during our MBBS and MS days through his texts. So he has recently joined us. He is our chief guest of honor. Sir, welcome.
Thank you. Thank you very much. Thank you.
Okay, so moving on with the set of presentations. For the next presentation, we will have Professor Rajgopal Shenoy as one of the panelists, apart from Dr. Rajni Bhardwaj, who is Associate Professor Surgery, Government Medical College, Jammu, Dr. Nitish, who is Consultant Endocrine Surgeon, UP, Dr. Shabas, Consultant Physician, Jammu. So I would request Dr. Rajni Bhardwaj to kindly introduce our next speaker.
Thank you, Dr. Sunil, for inviting me to this platform. I would, hello, I'm audible? Hello.
Ma'am, you are audible, very much audible.
Okay.
Yeah.
I would request Dr. Chaitra, who is consultant endocrine surgeon, oncoplastic and reconstructive breast surgeon. She is gold medalist and she has number of publications also. She is a doctor of international repute. She is having, sorry, my screen is off. So I would like to request Dr. Chaitra to present for today's talk.
Good evening, everybody. First of all, I would like to thank all the organizers for this wonderful opportunity, and I've enjoyed today thoroughly. Many great talks on thyroid and parathyroid disorders today, and it was lovely to hear from Ms. Lambres about a patient's perspective and her patients group, which I'm sure would be very useful for all of our patients here in India as well. I would like to just delve a little deeper, or maybe not as deep, into the struggles of patients with primary hyperparathyroidism. So this presentation is going to be very patient oriented, and it's like a storyboard, if I may say so. Less of medical talk, more of what the patients experience, what some of the patients experience during and before their diagnosis of primary hyperparathyroidism. My slides are not moving. Is my screen visible? Full screen?
Ma'am, your screen is visible. Can I request you to use the arrow keys if you're you're not able to click on the slide?
I'm clicking. Yeah. Okay.
Yeah, ma'am. There you go.
So as you can see, there are many aspects related to patient struggles in primary hyperparathyroidism, whether it be quality of life, emotional issues, economic issues, issues related to diagnosis and treatment, social issues, physical issues, familial issues, or even a whole repetition of the entire thing when there's recurrence of it. So there are many facets of struggles. And coming to the physical aspects, most of the symptoms come under physical aspects, and they have been covered extensively by Professor Agarwal initially, and other speakers. So because we are running short on time, I would like to skip to some of the patient stories as quickly as possible. Before going there, let's just have a small look at what the emotional issues could be. So all of the neuropsychiatric symptoms are direct emotional issues, which could be depression, anxiety, apathy, irritability. And whereas the indirect emotional issues would be the issues that are seen because of suffering caused by other symptoms related to their kidney problems, bone disease, issues related to a loss of means because of not being able to function fully and not being able to work, or being able to work only at a reduced capacity, that will lead to financial strain, and reduced functionality in general, which might affect the patient's relationships with her friends and family. Quality of life is also a very important aspect coming to with regards to struggles of patients with primary hyperparathyroidism, especially those patients who are considered to be asymptomatic. These patients often have neuropsychiatric symptoms which are undiagnosed, and a patient hardly notices these, even though sometimes the family members do notice them. And it is only after the diagnosis that you can retrospectively say that the patient was suffering. And some studies do say that the quality of life does improve after parathyroidectomy. Again, in asymptomatic patients, there are other studies which say that in mild PHPT, there might not be such a big benefit after surgery, and that observation treatment might suffice. There is obviously a disparity in the literature that is present. Coming to economic struggles, as I've previously mentioned, a loss of means or a reduced capacity of earning income, and cost of treatments pre-diagnosis, that is patients before their diagnosis of primary hyperparathyroidism, they might have to undergo treatment for renal stones or pancreatitis or anything else, maybe fractures. And then there is the expense of diagnosis. Once a biochemical diagnosis is done, the investigations required for localization, they are quite expensive, other than the ultrasound scan of a neck. At present, at least where I am working, in the city where I am working, there are very few nuclear scan centers, and it costs about 9,000 rupees to get a sesame B scan, and approximately the same amount to get a 4D CT done. The treatment of primary hyperparathyroidism itself is very expensive, especially in the private sector, as there is a dearth of expertised surgeons present to operate on these patients. And during recuperation time as well, some patients might have been bedbound in the time before their diagnosis and during their treatment, and it takes them many months to recover, and that might also cause economic hardships. And the reverse is also true, where in patients who have limited economic means, they usually get diagnosed late as they do not seek medical advice or treatment whenever they've actually experience the symptoms, but wait until it's a bit late in the day because of limited means that they already do not have. Coming to the social issues, there are many psychological and physical issues that will limit a patient with primary hyperparathyroidism socially. And the reverse is also true, wherein a person who is socially deprived might not be able to receive treatment for primary hyperparathyroidism at the correct time. Moving on to diagnosis, primary hyperparathyroidism is often a disease in where the diagnosis is delayed, the disease is often misdiagnosed, or sometimes there is a diagnosis but a non-localization of the offending glands. Misdiagnosis can often be seen in cases with bony lesions, wherein giant cell tumors or multiple myelomas come into the differential diagnosis. Other musculoskeletal disorders like fibromyalgia and chronic pain syndromes are also some of the differential misdiagnoses that are given to primary hyperparathyroidism patients. Coming to the treatment aspect, often patients struggle with treatments of other organs such as bones, kidneys, and pancreas. And sometimes there are unnecessary treatment of other organs, wherein patients sometimes presenting with a bony lesion might undergo a surgical excision of that lesion, and it ultimately turns out to be a Brown's tumor. And then there are issues with treatment of primary hyperparathyroidism and complications due to renal and bony issues. We all know about hungry bone syndrome, which can lead to prolonged hospital stay after surgery. And sometimes we also see failed treatment wherein the gland is not localized during surgery. And sometimes there's mismanagement of primary hyperparathyroidism, the example of which I'll be giving you shortly. There can be familial struggles in patients with primary hyperparathyroidism, especially if the patient is the primary breadwinner of the family, and taking care of dependents becomes a big struggle. And when the patient themselves are the dependent, not being taken care of might be an issue. And I've seen this plenty of times, especially in the rural Indian scenario, where female family members have been neglected and not been taken for treatment even after the diagnosis was done. Sometimes multiple family members can be affected, and we see these in familial syndromes where there is primary hyperparathyroidism. And then there are men syndromes in which there are associated endocrine disorders, which adds to the agony of patients. A repeat struggle is when a patient is once cured of primary hyperparathyroidism, or actually is not cured immediately after surgery and has persistent primary hyperparathyroidism. In those cases, the patients might have to undergo diagnostic and treatment processes again. And this again adds to the economic struggles and the psychological struggles of the patient. Going on to the patient stories, I would first like to talk about this middle-aged gentleman who was a farmer up until a year ago, after which he developed extreme pains, bony pains in both of his limbs, lower limbs, and was bedridden for quite some time. And finally decided to go to a hospital, and he was evaluated, and multiple bony lesions in both lower limbs were noticed. One of these lesions was biopsied, and luckily the pathologist who did report this was able to confirm the diagnosis of Brown's tumors, after which an endocrine surgeon was consulted, and the patient was able to get assessed for primary hyperparathyroidism. So this patient's PTH levels were to the order of 1400 picograms per milliliter. The MEB scan showed a right superior parathyroid gland, and the ultrasound scan showed a right-sided gland and a normal thyroid gland as well. So that's something that I wanted to stress out here. The surgeon performed sonography, and this surgeon was a visiting surgeon at the hospital, and hence had only limited access to the surgical resources. And the patient, because of their limited means, they did not want to have intraoperative PTH assessment or even frozen section done. Unfortunately, the ultrasound scan that was present in the theater did not work properly, and the SPS was not performed at that time. So even though with those issues, because of the almost concordant imaging, they went ahead with a focused right-sided parathyroidectomy. And then what happened? Through the 2.5 centimeter incision, they could not find the parathyroid gland. They next went ahead to do bilateral neck exploration and found that there was a very firm nodule within the tubercle of Zuckerkandl on the ipsilateral side, where the parathyroid gland was supposed to be present. As there was no frozen section biopsy or intraoperative PTH present, a hemithyroidectomy and again a complete full bilateral neck exploration was done. And finally, a week after the surgery was done, they were able to confirm that the gland that was removed, the nodule that was removed, was indeed a parathyroid gland. Other issues with this patient included that the patient had hypercalcemic crisis at the time of admission. The patient had pre-renal failure with a creatinine of 2. The patient also had an elevated phosphorus, which was confusing for the diagnosis. Post-operatively, it took a while for the patient's calcium to come down, and that could be attributed to the existing renal condition. And the patient was supplemented with vitamin D and calcium tablets at the point where the calcium levels were coming back to normal. However, the patient developed hungry bone syndrome and was needed to put on infusions at that point. This infusion was continued for a few days, and after the oral tablets were put on the maximum dose, the patient again needed the infusion. When looking back at all the records, the patient was receiving the appropriate oral dosage of calcium, but on checking with the patient's medication, the hospital had mismanaged the patient and the wrong medication was provided to the patient. Instead of Arachidol O, which is calcium citrate maleate, Arachidol was provided. And instead of calcium carbonate, a different formulation of calcium citrate maleate was provided. So instead of receiving the 4 grams of calcium that the patient was prescribed, the patient was receiving only 1.5 grams of calcium every day, and hence went back into a second setting of having to need an infusion.
Ma'am, really sorry to interrupt. but since we are running late, ma'am, requested.
Yeah. After the patient was discharged, once the hungry bone syndrome was dealt with and stabilizing on oral drugs, a month and a half later, this is the amount of ossification that happened in the patient's bones. And the patient who was bedridden for nearly a year was able to walk again 6 weeks after the surgery. Another story of another young patient who was a shop owner who presented with pancreatitis in January, pancreatitis in February, pancreatitis in April, pancreatitis in July, and finally, pancreatitis with unconsciousness, hypertensive crisis, needing respiratory support. And this time was shifted to a larger city from the smaller city he was living in. In the larger city, he was admitted at a hospital which had a better lab, and the calcium results showed that he had hypercalcemia, and he was evaluated for PHPT, which was confirmed biochemically. Unfortunately, when he had his original pancreatitis episodes earlier on in the year, the lab results showed that the calcium were normal. After having 5 episodes of pancreatitis and lakhs of rupees down the drain, this low to mid-income patient now had to undergo a primary hyperparathyroidism surgery and evaluation. Unfortunately for him, after spending 9,000 rupees on a sesame scan, there was no localization, and then he had to undergo a 4D CT. To add to his woes, he was discharged on 4 antihypertensives, and he was having palpitations, headaches during the hospital stay. The immediate post-discharge phase, he was also hypertensive. So it had to be, they had to evaluate for any pheochromocytoma, any hypercatecholemic, hypercatecholemic. A little more expense later on. The glands were localized. One of the gland was abnormally enlarged, whereas the other was just at the higher end of a normal gland size. And the patient underwent surgery for this. And because he did not want to have a prolonged hospital stay, he decided that only one of his glands should be removed. And he would like to have the surgery for a second gland if he develops further PHPT later on when he has more means to have the surgery. Coming to 5 more tiny tales. This is a lady who presented to a surgeon with a maxillary bone tumor, which was operated and which recurred, and then she had a second surgery. Initially, it was diagnosed as a giant cell tumor, but later on, it was found out that she had primary hyperparathyroidism, and this was a misdiagnosis of a Brown's tumor. So, a year and a half after her first surgery, she had curative surgery for primary hyperparathyroidism. Another lady who did not have access to localizing imaging such as sesame scan and 4D CT had to undergo an MRI scan and an ultrasound scan of the neck, wherein this lipoadenoma of parathyroid gave abnormal signals on the MRI scan, and hence a diagnosis was delayed. This is the X-ray of a surgical intern who fractured her thumb and 3 years later was diagnosed with primary hyperparathyroidism. A young lady who was working in the United States and diagnosed as having fibromyalgia could no longer hold her job and work and had to come back to India and was housebound for a year and a half and was vexed with any further investigations and reluctantly got a serum calcium done after insistence of a surgeon, one of her brother's friends, and finally was diagnosed with primary hyperparathyroidism and later on got cured. A lady with waddling gait who presented to a very clever orthopedician who immediately was able to get to the diagnosis of primary hyperparathyroidism, but never showed up to the endocrinologist on her own, as her husband deemed that it was unnecessary, as gait change was not life-threatening to her. So these are some of the examples of different kinds of patient struggles that we see. And the take-home message is to show a bit of empathy when discussing with patients their conditions and knowing their limitations, especially the financial limitations, listening to your patients, even if you're not from an endocrine background. Especially in that case, we can avoid misdiagnosis, delayed diagnosis, and wrong diagnosis, and avoid unintentional mismanagement, educating the staff and patient education regarding their conditions, and always provide patient-centric management and circumstantial treatment, which is paramount to the patient's happiness. Thank you.
Thank you, Dr. Chetra, for such a wonderful talk and throwing some light on other aspects which are associated with the disease and patient. This is not only with this surgery only. We face these problems. We don't realize what the patients and their family members they are dealing. And it's very nice to hear that you have thrown some light on this aspects only. Thank you so much. Thank you so much.
Thank you.
Professor Rajgopal Shenoy, sir, your comment, please.
Thank you. I heard wonderful talk, Dr. Chaitra. And just to tell you that before the days of ultrasound and imaging, I have seen many parathyroids. And we have also seen after the days of imaging. The difference is, one thing is that imaging has made diagnosis relatively easy. I use the word, but still, I think lack of education, poverty, awareness, that's how you are able to, get still so patients who come late to the hospital. I think we should understand that these are difficult problems for any intelligent clinician also to diagnose because of their delayed presentation and varied presentation. So awareness, a little bit of, the common sense to be used here. I had a patient who had recurrent pancreatitis, not acute, chronic pancreatitis. In our area, we do get a lot of pancreatitis due to tapioca, etc. And I sent her to a sonologist. He diagnosed hyperparathyroidism based on pancreatic calcification, nephrocalcinosis. He asked me, said, can I do ultrasound of the neck? I said, yes. And he picked up parathyroid adenoma. That's all from my side. Thank you, Dr. Sunil, for the opportunity.
So thank you, Dr. Chetra, Dr. Rajgopal Shenoy, and Dr. Rajni Bhardwaj and Dr. Shahbaz Khan for being a part of this August meet. So I would say at this moment that from empathy comes the desire to treat. So when a patient comes to us, we should not overlook any symptom, however subtle it may be. It may be as subtle as just weakness. And many a times we just ignore those symptoms as we think of postmenopausal symptoms, we think of just anemia. So, but a disease is lingering on in the patient. So we need to be aware of this entity. And this was the sole motto of this whole conference. And I think speakers have done full justice to it. So I am, all our academic sessions are finally over for today. I'm thankful to all respected international and national faculty who have put up immense efforts to make this masterclass a success, particularly our chief guest, Dr. Rajgopal Shenoy. And I am thankful to our patrons, Professor Amit Agarwal from SGPGI and Professor Shadilal Kachu from Jammu, who conceived the plan of a masterclass and worked with the organizing team at every single step. I thank my colleagues from Jammu and from Lucknow and other parts of India and abroad, without whom this conference would not have been possible at all. I thank patients and caregiver providers who are a part of this meet today for your patient listening. I hope you would have got something to learn from this meet, though we have much more to learn from you because this is a relatively misdiagnosed and rare entity. I am hopeful that viewers would have taken a strong message from this conference that there is much to parathyroid disease and parathyroid surgery and thyroid surgery for that matter, from just making an incision in the neck and taking the gland out. There is much social and economic aspects involved, and I expect all surgeons and physicians who are present in this August meet to take care of it, have an empathetic view for the patient from economic aspect, social aspect, and everything else. Thank you very much. So I think we should dissociate for today. Thank you.